cylinder. Working with the lens set. How we work with the lens set? This is also necessary. Right hand takes from the right side and left hand takes from the left side. Use the gap in the lenses to set the full lens away faster. This is the Snellen chart we usually do. Named after Dutch ophthalmologist named Herman Snellen. Snellen chart uses geometrical state to measure visual acuity. In India, we use 6x6 scale, and distance is being set at numerator represent the distance that the patient standing from the chart in meter, and the denominator represent the distance from which patient perfect sight is still able to read. With the smallest line, the patient can clearly visualize. For near vision, we use the 14 inches chart. Subjective reaction can be done directly, but it's better to do objective reaction first. Objective reaction is done using retinoscope, autorefractometer, photorefraction, which is discussed later. Indicates and beneficiation of trial frame. Children, person with disabilities, person with low vision, illiterate people, those speaking a different language, and elderly. We use the refraction, subjective refraction directly. Manual refraction with trial frame. Baseline, starting point and verification. Trial and error method we can use. First we correct the spherical power, then cylindrical power. First we do the axis verification, then the power verification of the cylinder. Patient position in refraction is also compulsory. Sitting comfortable, not forward. Trial frame position adjusted to vertex distance, adjusting to interpupillary distance should be adjusted, and trial frame should be straight, not this type. Adjusted behind the ears. We have to adjust the trial frame behind the ears. Illumination depends upon the chart. If we have electric chart or manual chart, examiner position to the side of patient. Need to be able to manipulate lenses, possibly chart, don't block the patient view. Occlude the first occlude the left eye and refract the right eye first. Measure the best visual acuity at the starting point. Via retinoscopy or autorefraction or previous glasses, show the full chart. We have to correct the full chart first with spherical corrections. Sphere lens should be in the behind and cylindrical lens in the front lens well. Refine the sphere. First we have to refine the sphere. Then we do the astigmatism. Axis verification is done first, and then we do the power verification. Then if we do the Jackson cross cylinder test to verify our cylinder is correct or not. Flip the JCC one side being lens option 1, then other being lens option 2. This is the Jackson closed cylinder type. If the two lenses are equal, then move straight on to power determination. If not, rotate the cylinder lens axis toward the minus, red dot to the JCC. Repeat the question. If the response is in opposite direction, move the axis back by half amount and change the first time. So we have to correct the Jackson's closed cylinder this type and this time, so that the patient is best visual acuity with the cylinder can determine. Advise to patient that neither lens will be completely clear, but ask which option is the best for Jackson's closed cylinder. Maintain the spherical equivalent for the patient. Then we have to do the binocular balance. It is participate and have equal visual eye to the binocular vision balance. Contraindication are strabismus, unstable or decompensating heteropopia, or visual acuity between eyes more than one line apart. Press biopsy. Yeah, the successive, then we can do successive alternate occlusion to do the binocular vision test, or red or green test. Worth photos test can be used for the binocular vision. Then we do the near vision correction. Near vision correction is needed for presbyopic patient, usually after the age of 40 years. Approximate chart is also there for age 40 to 45 years plus 5.5 to 1, 46 to 50 years. Then we can use manual correction with the phoropter can be used. This is the same, but it's used the machine phoropter. Then after phoropter we also use the binocular balance. Then we do the pinhole acuity test. Do not have ECG used in the patient which do not have ocular disease. This is the pinhole type. Most usual pinhole diameter is the 1.2 millimeter. Size of pinhole should be effective error. Individual with macular diseases as well as other ocular diseases affect central vision may have similar or even reduced acuity who are looking through pinhole. This is because reduced amount of light entering through the pinhole makes the chart less clear. Then we do the duochrome test. Duochrome red green test. It can be used for monocular and binocular test to determine proper spherical power. If the lens on the green side appear blacker, add 0.525. If the red side appear blacker, then add minus 0.25. The end point is reached when the latter equally appear black on both red and green side. It is important to ask patient to tell which side look blacker, not which side clear on. Thank you.
In time. Now I request Dr. Sandeep Gupta to please present the memento to Dr. Vivek. Meanwhile, we have our next speaker, Dr. Simran Chabra. She'll be talking on objective refraction and instruments.
Hello, good morning everyone. I'm Dr. Simran Chabra and I'm a fellow in cataract and pediatric ophthalmology in Kapil Eye Hospital, Ambala City. Today I'm going to discuss on direct ophthalmoscope, streak retinoscope and autorefractometer. Starting with direct ophthalmoscope, this is a handheld instrument which is used to look at the retina of the patient. It was first invented by Charles Babbage in 1948, but his work was not recognized and published until it was described by von Helmholtz in 1951. So these are the various parts of the ophthalmoscope. First we have the handle, then we have a rheostat which helps in adjusting the brightness. Then we have a housing recess which holds the head. The head has the following parts. It has a brow rest, a viewing window. It has a recourse disc or lens wheel which helps us in rotating and getting the different condensing lenses based on a patient and the observer's refractive error. So for example, if a patient or the observer is myopic, then we use the minus lenses. Then next on the head we have an aperture wheel which has two filters. First is the cobalt blue filter. Cobalt blue filter is used to assess the corneal erosions after staining with the fluorescein dye. And next we have the red green filter which is used to see the which is used to see the RNFL defects. There are various sizes of spots which are present. First is a small size which is used whenever there is undilated pupil. Then we have a large spot size which is used when it is dilated. And then we have a small size or a pinpoint size spot which is specifically used for looking at macular or foveal lesion. There is a slit aperture which is present. So in slit, that is used to identify any disc edema or macular edema. Then is a hemispot which has characteristics both of a slit and a large spot. And then we have a link star which is a fixation marker, and it is used to identify any eccentric fixation. Then this is based on a principle where we use a halogen bulb and the light then passes either through a mirror or a prism and it enters into the patient's eye, which is then seen by the observer. The optical principle is that we get to see a virtual, erect and a 15 times magnified image. The field of view, depending on the size of pupil, is 7 in cases of a small pupil and 15 when the pupil is dilated. Technique, first of all, we do a distant direct ophthalmoscopy, which is done at a distance of 25 centimeters. Here we look at the red reflex and we look for any discrepancy or asymmetry in the intensity of the reflex. So if there is a dull reflex which is seen, it could mean that either there is a diffuse cataract or there is some vitreous hemorrhage or any other problem. Then for doing ophthalmoscopy, the patient, we have to move closer to the patient and we have to visualize the retina. We look for the blood vessels, trace them backwards to reach the optic disc. The right eye is examined using the right eye of the observer and vice versa. The most important point to remember is that here the stereopsis is absent. So this is why this is not the most widely popular method, and it is mostly used in children who are uncooperative for examination or adults who can't sit on a slit lamp or are uncooperative for the indirect ophthalmoscopy. Next is the streak retinoscope. It is an this is a type of objective retina. This is used for objective refraction and is especially useful for examination of infants, children and adults who are unable to communicate. This was invented by an ophthalmologist, Copeland. And in this picture, we can see that this is a self-illuminating type of retinoscope. And here we use a bulb which has a straight filament, because of which we get a streak. The other parts are the head and the neck. Head contains a forehead rest and a percher to view, and neck has a sleeve which can be moved upwards and downwards in order to get a plane mirror effect or a concave mirror effect. Usually we use the plane mirror, and in cases where there are high refractive errors or when we need to sharpen and determine the axis for astigmatism, that is the time we use the concave mirror effect. It is also based on a similar principle to our direct ophthalmoscope. So in this, the patient is seated at the same level. The distance is approximately 1 meter or less in order to visualize the reflex clearly. We ask the patient to fixate at a non-accommodative target, and we look for the characteristics of the reflex. That is the speed, brilliance, width and the regularity. And based on that, we put in the corrective lenses. If we see with the movement, then it may imply that the patient has hyperopic error, is emmetropic or is myopic less than the dioptric value. And for with motion, we have to use the plus lenses. If it is against the motion, then that would mean that the patient is myopic more than the dioptric value of the distance. And here we use minus lenses to neutralize the reflect. So the end goal of retinoscopy is to get neutrality, which is when the rays are actually converging at the focal point. And this usually implies that the patient is either myopic, that is equal to the dioptric power of the distance. So if the reflex is different in different meridia, that would represent that the patient has astigmatism, and any abnormal reflex like scissoring can also be observed, which is a sign of keratoconus or scarring of the cornea. Next we have autorefractometer. This is also known as optometer. It is basically used as a screening method and it serves as a starting point for subjective refraction, especially where there is high volume OPD, and this is a method to objectively assess the patient's refractive status. The advantages of autorefractors are that these are reliable, repeatable, accurate, quick, and these are non-invasive. This is based on two principles majorly: Scheiner's principle, which uses a double pinhole aperture, and we have an optometer principle where a converging lens is used, and we look at the vergence at the f2 focus, and the measurement of this vergence, whether it is parallel, diverging or converging, that helps us give the refractive status of the eye. The procedure is that we ask the patient to look straight, and then 3 readings are there and we have to calculate the average for the same. So which is better and when we should use what? So retinoscopy or autorefractometer. In case we are screening a young child, since the child will be uncooperative to sit on AR, we prefer autorefractometer over retinoscopy. We prefer retinoscopy over the autorefractometer, and also in autorefractometer we get proximal accommodation, which leads to high myopia and also underestimation of hyperopic error. Then next is, if a child is undergoing cycloplegic refraction, then they have seen that both autorefractometer and retinoscopy, they correlate well. Then third, in patients with mature cataract or poor vision, since AR lacks the assessment of ocular media, and whenever there is mature cataract or poor vision, the patient or the child will not be able to fixate well, and so it usually gives an unobtainable or an unreliable result. So in conclusion, AR is a reliable screening modality, and good correlation is seen in astigmatism and determining the axis. And children under cycloplegia, autorefraction gives a result that is comparable to retinoscopy. Thank you.
Well explained, Dr. Simran. Now I request Dr. Dhul to please present the memento to Dr. Simran. We have our next speaker. He needs no introduction. Dr. Amit Gupta. He'll be speaking on special instruments for assessment in pre-verbal children.
Till the time the presentation is being set up, how many of you are pediatric evaluation, the visual assessment in pre-verbal children? Yourself, not your optometrist. So very less of us. So the most important thing here to know is when we are assessing visual assessment in children, we need to have a very good practical knowledge of how we are to perform these tests and what we are expecting. So till the time we are not doing on our own, we cannot rely on our optometrist, because the results are very, very different in children compared to adults. So we are observing for their visual behavior, we are looking for their responses, whether the child is paying attention to this or not. So all these have a bearing on the ultimate outcome of all these evaluations. When we are assessing for the visual acuity, we need to know what is normal. So children, they have a relatively mature visual system at the time of birth. It is very dynamic in the first year of life. That's why we need to have different tests for evaluation in children. Any impairment in the visual acuity or development in this phase leads to a long-standing impact, and the child can be amblyopic or blind all throughout life. All the more imperative that we are able to diagnose all these conditions at a very, very earlier age. I am commonly encountered with the question, how is the pediatric eye different from an adult eye? So there are both anatomical and physiological differences. When the child is born, the eyeball size is roughly 70% of the adult size, and the maximum growth in the first 2 years of life, and by the age of 4 years we expect 90% of eyeball growth has already occurred. And these children are playing outdoors most of the time, so more chances of having any injury, having an exaggerated tissue response. So all these have a major bearing on the ultimate visual acuity of the child. When we look at a target, the target is presented to both the eyes simultaneously, which is taken to the brain from both the eyes simultaneously, and brain has the responsibility of fusing that image so that we are able to see one target at a time. But any impairment in this, in the form of either strabismus being there or any visual deprivation being there or an anisotropia, one eye, the target is relatively blurred, which over a sustained period of time leads to an amblyopic eye, or that eye stimulus is ignored and the visual acuity of that eye is constantly hampered. So all the more reason that we are able to identify these problems at a very early age. We need to know what is normal. When the child is born, we expect the optokinetic nystagmus to be there at the time of birth. Smooth pursuit is there by around 2 months of age, fixation by 2 to 3 months of age, stereopsis we expect, and contrast sensitivity around 6 months of age. Newborn baby is usually, they have a blink reflex. Anything brought closer to the eye, they have a menace reflex and they immediately close their eyes. By 2 months of age, they are able to respond to faces. Mother's face is the first one they'll respond to. By 4 months of age, they usually try to reach for an object and try to hold it by 6 months of age. And matching of colors is usually there by 2 years of age. So this is what is normal. When we go to visual assessment proper, so first thing that we evaluate in children is at the time of birth is a blink reflex or a menace reflex. They'll close their eyes, anything brought closer to the eye, they'll immediately have a startling response and they'll blink their eyes. Vestibulo-ocular reflex is another thing which is present at birth, which we can elicit with a doll's head maneuver. We shake the eye rapidly with a gentle movement and we look for the response of the eye to fixate. When the child is looking towards, say, you move the child to one side, there would be a slow saccadic movement followed by a refixational movement which usually dampens in 3 seconds. If it is delayed beyond that, up till 15 seconds, we expect the visual acuity of the child is hampered. So this is one of the earliest signs that we can pick up where the child's visual acuity would be hampered to some extent. Then we can check for the fixation preference. Like in the first picture, the child is orthotropic. We expect normal fixation in both eyes compared to the second picture where the squint is there in the left eye. The right eye is a fixing eye and the left eye is one which is amblyopic. So we are able to assess the fixation pattern of the child. Then we look for the falling movements. We give an accommodative target and we look whether the child is moving towards that target and try to reach for that. We are able to assess their motor milestones also with this. We are having a pincer reflex or whatever reflex we are checking, so that can also be assessed. Another very good test to do in our OPDs is a resistance to occlusion. Once we are occluding the right of the child is very comfortable. The moment we include the left eye, the child is very, very uncomfortable. This is because of the cataract being present in the right eye of the child and the left eye is normal. So once we are occluding the normal eye of the child is very uncomfortable. So he is trying to resist the occlusion and his resistance is by either moving his head or he is crying. Then we check fixation preferences with some other tests also, like the first video, if we have a look. This child has an esotropia in the right eye, 25 prisms. We put a 25 prisms base out prism in front of the right eye. The child is still fixating with the left eye. Then we alternate the prism in front of the left eye. The child is still fixating with the left eye. Normally what we'll expect, prism being put in front of the eye, one eye, that induces a deviation in that eye. That eye's vision would reduce because of that. But in this patient, the child is still fixating with the left eye, which gives a reasonable estimate that the right eye is the amblyopic eye. Now, when we have normal patients which are orthotropic or have a deviation within 10 prism diopters, we put a vertical prisms and we look for any change in fixation pattern once we put in front of the right eye, and then we move it towards the left eye, and then we see whether the child is still fixating with that eye or they alternate fixation or they are fixating with one eye alone. That also is a good estimate of the visual acuity in pre-verbal children. Here the video is in a verbal child, but we can still do it in pre-verbal child also. Then candy beads is another test where we put some beads in our hand which are very small. The child tries to look at it and tries to reach for it, which gives an estimate of their visual acuity also and their pincer reflex. CSM is another modality which we do in our practice day in and day out. We look for the central fixation of the child with a pen light torch. If the fixation is central, we mention it as C. If the child's fixation is steady, once we are moving the target to the right or left on a saccade, then it is a steady fixation. If there is a nystagmus, it would lead to an unsteady fixation. Compared to maintain, where we do it monocularly also or on a cover-uncover test. If the child is able to maintain fixation with both the eyes, then we mention it as CSM. In patients with strabismus, they can have an unmaintained fixation in one of the eyes. Another test that we do perform in our OPDs is an optokinetic nystagmus, where the drum is rolled in front of both the eyes. Then we see for the movement of the eyes, the nystagmus is there. If the nystagmus, there is a disparity in the amplitude of nystagmus in the two eyes, the eye with a higher amplitude of nystagmus would be the one which would be having a lesser vision compared to the normal eye. So this is commonly elicited in our patients with congenital esotropia. Then one of the most important tests is looking for preference of the child once they are looking at targets. So here, this is the terror acuity cards. One side is the striped grating acuities and the other side is plain, and we look for the response of the child through a pinhole. The examiner is standing behind this and we are looking for the response of the child where the child is looking. So based on the preference of the child, we are assessing their visual acuity. So here is the pinhole, and these gratings, they keep on narrowing in size, and based on that we are able to assess their visual acuity. if we have a child with nystagmus, usually we see a horizontal nystagmus. So in a child with nystagmus, we'll put this vertically because the nystagmus, we won't be able to assess the visual acuity where the preference is. Here we'll be able to assess their visual as well. Another method, Lia pedals. Here we can put in all the 4 directions and look for the movement of the child, which direction the child is looking at, and assess their visual acuity. Vanishing optotypes, here the target vanishes in the background and we look for the response of the child. Lesser is the size of the resolution and that would indicate a better visual acuity. So here we can see the amount is decreasing. It has some advantages of a teller acuity cards, that it is more interesting for the child than grading, quick and easy to perform, gives some measure to measure so that better fixation pattern can be assessed. Disadvantages, no crowding phenomena is there, so it tends to overestimate the visual acuity. When we have verbal children, then we have umpteen number of tests to perform. We can have picture charts like this, K pictures or Lia pictures, Ellen pictures, illiterate, and all the more tests are there which we can perform. Summarizing, whenever possible, by employing an appropriate methodology, we should be able to assess the visual acuity of these children, because it forms a background of assessment in children, and we can assess or evaluate a lot of other problems and screen for their amblyopia at a very, very early stage. No child is cooperative. I repeat, no child is cooperative. Only we are the ones who should be able to elicit something out of them, and we should be able to make them cooperate rather than the child should be cooperating with us. Thank you.
I request Dr. to please present memento to Dr. Amit. Now I request Dr. Ankita to talk. She'll be talking on instruments for assessment of binocular vision and stereopsis.
Good morning, everyone. I'm Dr. Ankita Bharadwaj, and the topic I'm discussing today is assessment of binocular vision and stereopsis. So what is binocular vision? Binocular vision is the coordinated use of 2 eyes to produce a single mental impression. As we know, there are 3 grades of binocular vision. First one is simultaneous macular perception, fusion, and then stereopsis. Simultaneous macular perception is the power to see 2 dissimilar objects as one simultaneously. Like in this picture, if we present a picture of a cage and a bird to each eye simultaneously, we will be able to see the bird in the cage. Next is fusion. Fusion is the ability to produce a composite picture from 2 slightly dissimilar pictures which are incomplete in one small detail. Like in this picture, one is rabbit with bare hands and one has flowers. So if both these pictures are presented, we'll be able to see a rabbit with bouquet in its hand. Third, which is the highest grade of binocular vision, in stereopsis, which is the impression of depth by superimposition of 2 images which are taken from slightly different angles, which are slightly disparate. It is the highest grade of binocular vision. So what is the challenge here? The challenge is to assess both eyes separately when both of them are working simultaneously. For this, we use certain principles and certain tests, and these tests can be divided into diplopia tests, haploscopic tests, and stereoacuity tests. So what we do to dissociate the 2 eyes, we can either produce diplopia, which principle is used in diplopia test. So there is one fixation target. However, we use certain instruments so that each eye sees them as 2. So this principle can be used in red-green glass, or in Worth 4-dot test, in Bagolini's and Maddox tests. In haploscopic tests, there are 2 fixation targets, each for one eye. And this principle is used in synaptophore and after image tests. And third, these are stereoacuity tests, in which slightly disparate images are seen by each eye, which we'll discuss in detail later. So first is red-green glass. These are very readily available. They are also known as diplopia goggles, as they help us to produce diplopia. Why we chose these colors? Because these colors are mutually exclusive. Red light is seen by red filter but not the green one, and vice versa. If we present white light to the eye, they'll appear as distinctive red with one eye which has red filter, and green with the other which has green filter. So by convention, red is used for right eye. Now this can be used for diplopia charting, Worth-for dot test, Hess screen testing, Lancaster chart testing, and stereoptic tests like TNO tests. Next is a very easy and simple test and readily available is your Worth-for dot test. It has a set of 4 circles, top red dot, 2 green horizontal dots, and 1 white bottom dot. They are usually viewed with red-green glasses, and the test is usually done at 6 meters. There are certain scenarios where we can do it at near also. We'll discuss this later. How do we interpret the red-green glass, Worth-for dot test? So we put red-green goggles, red in the front of right and left, green in front of left. So normally a patient, a subject would see top red light, 2 green lights, and the white light would appear as a mixed or a yellow light. Now if there is left eye suppression, so left eye is not seeing anything, and right eye which has the red filter, that will see, and it will appear as only 2 red dots. Similarly, if there is right eye suppression, only left eye is seeing and 3 green dots will be available. But if any patient with squint is still seeing 4 dots like a normal one, it means that that patient has anomalous retinal correspondence. Then if the patient has diplopia, a manifest squint without ARC, then that subject will see 5 dots, 2 red and 3 green. Now this uncrossed diplopia is seen in esotropias, and crossed diplopia is seen in exotropias. Now there is a special scenario in microtropias where there is a small central scotoma. If we do the we do the test at 6 meters, that one of the images will fall in the scotoma, and the patient will be able to see only 2 dots with one eye. However, if we repeat the test at near, now the angle is more and the image will fall outside of the scotoma, and then the patient will be able to see all the 4, and that's how we diagnose microtropias or monofixation syndrome. Next is synaptophore. It's a very versatile instrument. It is based on haploscopic principle, which we had already discussed, that there are 2 fixation targets for each eye. The images are separated by 2 set of tubes with mirror at the junction, and convex lenses are placed at the eyepieces. Now these slides lie at the focal point of eyepiece, simulating viewing a distant object so that accommodation is not used. There are many functions of synaptophore. They can be diagnostic and they can be therapeutic. In diagnostic, one of the most important functions are measurement of deviation, including primary and secondary deviation. There can be objective and subjective angle in ARC, and horizontal, vertical and torsional deviations. We can assess binocular status. We can measure the range of fusion, and we can also do some tests like after image testing and entoptic phenomena. In therapeutic uses, we can use them for fusional vergence exercises, management of suppression, treatment of ARC, and amblyopia therapy using Hedinger brushes. Next, which is the most important part of this presentation, is how do we measure stereopsis. So there are 2 essential features which we need for measurement of stereopsis. The 2 eyes must be dissociated, and the images must be placed on corresponding retinal areas. And to dissociate the eyes, again we use a few principles. Haploscopic principles we have already discussed, in which we use angled mirrors like in synaptophore. In vectographic principles, we used Polaroid glasses, and this principle is being used in Titmus test. In anaglyph, we use red-green glass like in TNO test, and in panographic principle, we use either lenses or prisms or even thickness of the plate like we use in Lang's test. So let's see them one by one. So this is the Titmus fly test. This has 3 tests basically. First one is the fly test, which is used for gross stereopsis around 3000 seconds of arc. child is asked to wear the Polaroid glasses and asked to grasp the feather of the wings of the fly. If the stereopsis is present, the child will reach above the plate. If this is not present, he'll touch the plate. The next one is the animal test, which has 3 rows of 5 animals each. One animal is imaged disparately. Thresholds are 10, 200 and 400 seconds of arc. However, one animal is printed heavily as a misleading clue. So if the patient does not have stereopsis, he'll select the one which is heavily printed. Circle test has 9 squares of 4 circles each. One circle image disparate. So this is based on vectographic principle, Polaroid glasses. And this is very simple and easy to perform. And some circles are, however, the disadvantage is that some circles are identified by even stereo-blind observers. Randod stereo test, it has the advantage that it does not have any monocular cues. It gives the true measurement of stereopsis. 3 cards are to be viewed with Polaroid glasses. We show 2 cards at 50 centimeter and ask to indicate which one has the letter. It gives a pass or fail response, and if we want to quantify, we have to increase the distance. Similar test is TNO stereopsis test, which has 3 plates. It has the advantage of eliciting quantitative response without changing the distance. Range is 15 to 480 seconds of arc. It has 7 plates. First 3 are used for gross, while next 3 is for the quantification. Each plate has 2 types of figures, and one is seen by everybody and one is seen with subjects with stereopsis only. Next is Lang's test, which has again Randot dot stereogram, but it has a panographic presentation, which means that disparity is created through cylindrical gratings imprinted on surface lamination. Held at 40 centimeter, the advantage is that glasses are not required. In the first plate, if the subject is able to see the cat, he or she has 1200 seconds of arc, or if for car and star, it is 600 seconds of arc. Last one is Frisbee-Davis distance security test. It has 3 plastic cards with 4 squares of small random shapes, and there is a hidden circle in each plate. Disparity is created by displacement of random shapes by thickness of the plate. The advantage is again glasses are not required. Thank you. That's all I'm covering today.
I'll invite Dr. Subhash Mehta to please hand over the memento to Dr. Ankita. Next speaker is Dr. Yuvika. She'll be covering instruments used in assessment of squint.
Morning everyone. Slide. Good morning everyone. I'll be talking about vision. So first of all, what is binocular single vision? Simultaneous use of both eyes to perceive a 3-dimensional single image is binocular single vision. The fixation is bifoveal and there is no manifest deviation. So any disruption to this coordinated working of both the eyes leads to binocular vision disorder. It can be strabismic or non-strabismic. So here lies the role of orthoptics, which is a field which deals with the diagnosis and treatment of binocular vision disorders. It also involves training of an individual to make best use of both the eyes. And we have various appliances to measure the sensory status, motor status, the angle of deviation, as well as to assess the state of accommodation and vergences. So the sensory adaptations are suppression, amblyopia and retinal correspondence, and these are the appliances to measure the sensory status. So we have Bagolini striated glasses. These are the pair of glasses with striations at 135 degree and 45 degree. And the patient fixates at a small light at 33 centimeter for near and 6 meter for distance. And these are the questions which we ask the patient. If a patient sees a cross with a single light, it indicates NRC with straight eye or ARC with squint. Single streak suggests suppression. If patient sees a small gap, it suggests central scotoma. If patient sees two lights and two lines, it suggests diplopia. If patient sees two separate lines, it indicates large deviation. Coming to appliances to measure the angle of deviation, we have tools to measure the subjective angle like Maddox rod and diplopia charting. For objective angle, we have torchlight examination and prisms. So Maddox is a series of plano-convex cylinders mounted on a disc. It refracts the light perpendicular to the axis. So it is useful for subjective evaluation of deviation like horizontal, vertical or torsional deviations. It's a darkroom procedure. By convention, we keep the rod in front of right eye, and for horizontal we keep the rod like this. For vertical we keep the rod like this. So patient views with both eyes open. With one eye patient sees the light, with the other patient sees the line. It is done for both near and distance. This is the perception in case of orthophoria. In case of exotropia, patient sees a cross diplopia. In case of esotropia, patient sees a uncrossed diplopia. For vertical deviation, we keep the rod like this. This is right hypertropia, this is right hypotropia. Double Maddox rod test is very useful test to identify cyclodeviations. Here we keep the two Maddox rod at 90 degree, and if patient is not appreciating the two horizontal lines, we use the vertical prisms to separate the lines. We simply ask the patient whether patient sees two parallel lines or not. If one of them is tilted, to rotate the corresponding Maddox rod to make that line horizontal. So if patient rotates the Maddox rod inwards, it indicates incyclotorsion. If patient rotates the rod outwards, it is excyclotorsion. This is another variant of Maddox rod. So diplopia charting I am not going to tell, as already been told by Dr. Ankita. So coming to objective evaluation of angle of deviation, we have torchlight examination. The most commonly performed test is Hirschberg test, where we look for the corneal reflexes. So the normal reflexes like central and nasal because of positive angle kappa. Any shifting leads can suggest deviation. So nasal shifting is exotropia, downward shifting is hypertropia, upward shifting is hypo. And we can have rough estimate of the amount of deviation by the positioning of the corneal reflex. Coming to prism bar test, it measures the angle of deviation at distance as well as near. We keep prism in front of obvious deviating eye and we start performing alternate cover test and also keep on increasing the strength of the prism till there is no deviation or there is just reversal of deviation. In cases of poor vision or poor fixation, we do prism bar Krimsky test, also known as prism bar reflex test or PBRT, where we keep the prism in front of seeing eye and we again keep on increasing the strength of the prisms till the Hirschberg is central in the other eye. Coming to 4 prism base out, it is used to rule out the central scotoma. So we have 2 steps as been told by Dr. Amit also. So where we keep the prism in front of obvious deviating eye and we look for the fixation. So in second step there will be quick refixation movement of the other eye. If patient sees both the movements, it means there is no suppression in the other either of the eyes. If patient is not showing refixation movement, it suggests suppression in the left eye. If patient is not showing any movement in the step 1, it is suppression in the concerned eye. Coming to appliances to measure the motor status, we have Hess and Lee screen. So the basic principle is foveal projection and they follow the Herring's and Sherrington law. I'll be mainly discussing the Lee screen. We have 2 opalescent glasses at 90 degree and the glasses are bisected by mirror in between, and the back of the screen we have a tangent grid imprinted. So patient facing the non-illuminating screen, one eye sees the blank screen and other sees the illuminating screen. So screen viewed by the patient is illuminated throughout the test. So the examiner points at a dot and ask the patient to point the same dot on the other screen. So this is the least chart. We have two squares. Inner square corresponds to 15 degree from point of fixation and outer is 30 degree. So any compression suggests underaction, expansion suggests overaction, and small field belongs to affected eye. So after having discussed the test for strabismic binocular anomalies, we come to non-strabismic binocular anomalies. These are the visual disorders that affect person's binocular vision and outcome, especially while performing near tasks. We have accommodation anomalies like accommodative spasm, insufficiency or infacility, and vergence anomalies. It is very important to test non-strabismic binocular anomalies owing to, they are quite prevalent nowadays owing to the change in work pattern and lifestyle, more near work, more exposure to gadgets. And we have a major chunk of patients in our OPD coming with chief complaints of headache, asthenopia, watering, difficulty in focusing and switching gaze, and we often misdiagnose these cases as computer vision syndrome. So if these cases left untreated, they may convert into strabismic binocular anomalies. So we have appliances to measure the accommodation and conversion. Most common is the RAF ruler. So RAF ruler measures both NPC, that is near point of convergence, and near point of accommodation. It has 4 target drums. So for NPC, we ask the patient to focus on dot and line and gradually move the drum towards the patient until patient sees diplopia. This is break point, and again move the drum away from the patient when patient again notices dot and line. This is recovery point. So normal NPC ranges from 4 to 10 centimeter. It does not change with age, and it recedes in convergence insufficiency. For NPA, we ask the patient to focus on 6-9 line of either of the 3 phases of near acuity chart, and again move the drum towards the patient till the patient observes a sustained blur. So NPA changes and recedes with age, and amplitude of accommodation is 100 by NPA. We have flippers, which is a set of 2 plus and 2 minus lenses. It is important for accommodation facility, which is the index on how quickly accommodation can be changed with a change in the stimulus. So it can be done with single eye or both the eyes. Patient focuses on the near acuity chart. We first put the minus lens, which will stimulate the accommodation. As the letter becomes clear, we flip to the plus lens, which relaxes, and then flip to the minus. So we count this for 30 seconds. So any decrease in the number of cycles suggests accommodation infacility, that is patient's inability to focus at near after distance viewing, and patient needs therapy. So we have vision therapies which aim at improving the eye functioning, inter-eye coordination, and coordination between eye and brain. So I would like to highlight that vision and learning is not just eyesight. It has many more components, and vision therapies aim to improve all these components. So we have exercises for accommodation like flippers and heart rock near and far chart. For vergences, we have various cards like stereogram, dot barrel, Brock string, pencil push-ups. For the lack of time, I'm not going into detail. The basic principle between vergence therapy is that they induce crossed and uncrossed diplopia through retinal disparity, thereby increasing and decreasing the convergence while maintaining the accommodation at a fixed distance. So we have cat stereogram cards where 2 incomplete cats are shown. We have dot cards where a single line with dots, and we have various patterns depending upon the fixation of the patient. We have lifesaver cards where 4 red and 4 green circles are shown to the patient. We have Brock string, which is commonly available, can be used as home-based therapy. And we have barrel cards. So my take-home message is orthoptic appliances play a major role in diagnosing binocular anomalies. Non-strabismic binocular anomalies cannot be ignored. We have various exercises which can be used at home, and accurate diagnosis of type of disorders is important before we select the type of therapy. Thank you.
Now I invite Dr. Rajiv Sood to please hand over the memento to Dr. Yuvika. Meanwhile, can we have Dr. Shekha? She'll be presenting on lacrimal irrigation and its interpretation.
Morning all, I'm Dr. Shikha, and at the I'd like to thank the organizer for inviting me for this particular talk on lacrimal irrigation and its interpretation. So we all agree with the common fact that the most common symptom with which a patient comes to our clinic is watering. Apart from blurring of vision, it's watering, which is pretty distressing for the patient as well as for the doctor sometimes. So lacrimal irrigation is one of the most important tools in helping us diagnose the cause for epiphora. But before we jump onto irrigation, there are certain points which one needs to keep in mind before starting irrigation. One is important is history. I even ask my patient that how many times do they wipe off their tears with a handkerchief. That sort of gives us the chronicity as well as severity of the disease. Also, like any other case, examination is important. The moment patient walks into our clinic, these are sort of telltale signs which tells us that there is NLDO in the patient. Apart from that, once we start the slit lamp examination, important to look at the lid margin. How is the lid margin? Is there any sort of inflammation around it? What is the position of the lid margin? Is there any lash globe contact, irritation causing hypersecretion of the tears rather than blockage of the tears? Next, I would like to focus on the puncta. How is the punctal anatomy? Whether there is stenosis, whether the puncta is there or not at all. If there's stenosis, what is the position of the puncta? Is there any inflammation around the puncta? And then I would like to do a Roplast test. So what exactly is Roplast test? With the help of a thumb or a finger, we apply pressure over the lacrimal sac area in the backward and upward direction. That means over the posterior lacrimal crest. So that way the fluid regurgitates from one of the canalicula. And if this test comes out to be positive, it's like a telltale sign of NLDO. And I would not even like to do lacrimal irrigation in these cases because I know next step would be a surgical intervention. Now coming to lacrimal irrigation, the main point of the entire talk. So lacrimal irrigation is actually an anatomical test. It's not a physiological test. The reason being we are pushing fluid with much higher hydrostatic pressure into the lacrimal system, whereas the normal physiological flow is much slower. So it does not tell us about the physiological functioning of the lacrimal system. It's just an anatomical test. What would be the instruments required? Punctum dilator, then a probe in certain situations, not always, and cannula. I strongly condemn usage of syringes for irrigation. It is very traumatizing to the canaliculi, which further leads to stenosis of the canaliculi. 26 gauge cannula is the most appropriate one. We can also use 24 gauge. Important thing is it should not be angulated. One needs to use a straight one or a smooth 15-degree curve cannula for irrigation. We ask that we can perform the test in supine or reclined position under topical anesthesia. Most important would be pulling the eyelid horizontally in order to negotiate the angulation of the canaliculi system. That I'll show you in the coming video. And we prefer upper canaliculus because it gives us easier access to the sac and gives us better results. It's easier to perform basically. So when we look at this particular video, I have usually performed my irrigations in a supine position. Proparacaine has already been instilled. Next step would be dilate the puncta. No need to negotiate unnecessarily. Dilate the puncta with punctum dilator. And if you look at it, I'm actually pulling the eyelid. You have to pull the eyelid completely laterally, and if you can see, my cannula is resting flat on the eyelid margin. It is not vertical. This way I know I'm going up till the sac. You can request your assistant to retract the lower lid to see if the fluid is regurgitating from the other puncta. In this case, it was freely patent. But now if you look at the lower canaliculus, when I'm doing the irrigation from the lower canaliculus, my cannula is not resting flat on the eyelid margin. And this is sort of giving us a false positive test. There is regurgitation from the opposite, but actually it is patent. That is because the cannula was not resting flat, it was sort of vertical, and it was giving us a false positive test. So this is what I was talking about. If you look at the direction of the probe, what is happening is it is dragging the roof of the canalicular wall and hitting over the medial wall. This gives us a false positive soft stop. Or in some situations, it directly hit the canaliculus itself. Whereas the canalicular system is actually open. It is because we did not negotiate the angle properly we are getting these results and we'll end up giving a wrong diagnosis to the patient. So when we come to interpretation, what can be the things happening? There would be either regurgitation or it will be patent. If it is regurgitant, whether it is mucoid fluid or whether it is clear fluid. In case it is mucoid fluid, we know that the fluid is coming from the lacrimal sac, and that means there is NLDO. Whereas if it is clear fluid, we have to feel whether there is hard stop or whether there is soft stop. In case there is hard stop, we know it is NLDO. Whereas if it's soft stop, the next step would be to look at the regurgitation direction. Is it coming from the same canaliculus immediately, or is it coming from the opposite canaliculus? In case of same canaliculus, it is the same canalicular block, whereas in case of opposite canaliculus, it would be a common canaliculus block. Next, if there is no regurgitation at all, always take a look at the sac area. Is there any sort of sac dilation? If there is sac dilation, it is indicative of sac atonicity. Another factor which we need to keep in mind before performing any surgery. Management is very straightforward, we all know. Depending on the blockage site, we will perform the procedure. If it is a proximal block, in that situation, we need to go ahead with lacrimal gland Botox or a CDCR. If it is a distal block, that is anywhere the block is somewhere around 8 to 10 millimeters, in that situation, we would plan a canalicular trephination and follow it by DCR if required. And if it's a distal block or an atonic sac, in both the situation, DCR is required because it's equivalent to a block. Even prior to cataract surgeries, these points are very important. If a patient has sac dilatation, but it is patent, you need to keep in mind that it is block. A word of caution, do not perform irrigation in cases of dacryocystitis, canaliculitis or any sort of canalicular inflammatory disorder, because these are the cases in which we are going to worsen the situation by causing strictures. Another important test I wanted to discuss was FDDT, or fluorescent dye disappearance test, which gives us the physiological functioning as well, apart from the anatomical functioning, but cannot differentiate between the two. In this particular step, in this test, we just instant fluorescent stain in the cul-de-sac and we check after 5 minutes. If it is persisting, that means the tear meniscus height is more than 1 millimeter. We consider it to be positive. And it is a test which tells us about the orbicularis functioning as well. And in case of CNLDO, it's very important. Kids, we cannot perform irrigation. So what do? We do FDDT. So in this particular test, we can get the findings. Next, if we have time, I'll discuss sac massage. Otherwise, I'll just skip.
Your time is up.
Yeah, I know. Okay. Summary would be lacrimal irrigation is a diagnostic test. It is not a treatment. And one should stretch the eyelid laterally while irrigating the canaliculus in order to avoid any false positive soft blocks. And FDDT is a simple but effective tool which should always be performed in all cases of epiphora. Thank you.
Thank you, Dr. Shikha, and thank you for giving such a nice explanation of this epiphora. I request Dr. Rahul Singla to please felicitate Dr. Shikha. Do we have Dr. Rajan Gupta with us? Okay. So are you ready with your talk? So Dr. Rajan is going to speak on newer machines for control of progressive myopia.
Good morning, dear friends. First of all, I would like to thank SFS and HOS for giving me opportunity to talk about the newer lenses for the control of progressive myopia. So, as we all know, we are daily encountering the patients of myopia. It's known as near or short-sightedness, and myopia may be caused by the changes at the level of the cornea, the lens, and the axial length. The light rays entering the eye are not focused in the retina, but it is in front of the retina. So it causes the blur vision for the distance. So myopia is a multifactorial condition. It was caused by the genetic changes, the environmental factors. As you all know, the increased close work, the less time spent outdoor for the outdoor activity, the increased screen time, as in the COVID times it is happening. So what are the various complications for the myopia? It will cause RD, glaucoma, and the macular degenerations. What are the various solutions for the myopia management do we have in our portfolio? That is the orthokeratology, the soft contact lenses, the pharmaceutical methods, and the spectacle lenses. So what are the treatments in myopia progression? What does not work? That is the undercorrection. And what probably does not work? That is the bifocals, progressive lenses, and the contact lenses. And what might work in our routine practice, that is the special spectacle lenses, the orthokeratology, the atropine sulfate 0.01% eye drops. So is the regular spectacle lens correction cause increase in the myopia? As you can see in the uncorrected myopia, the light rays are focused in front of the retina and they are in the periphery, they are focused behind the retina. So the traditional single vision glasses, they cause the peripheral hyperopic defocus in such lenses. And the ideal correction will be there. The current theory suggests that the creating myopic defocus slows down the myopia progression. You can see the hyperopic defocus, the eye tries to elongate itself by the corrective factors. So there is a myopia progression in the routine lenses. So there is a peripheral defocus with the DIMS technology that is brought by the Hoya and the different companies, the Zeiss as well. There is a central clear zone of 9.4 mm. So it has a clear 9.4 mm with no defocus segments. It provides the best corrected visual acuity. In the treatment zone, the patient is patent. It is a patent technology by DIMS, and it allows the normal visual perception. For example, that is a high level of visual acuity and myopia maintained at the same time. And the lens has myopic defocus, eye lens distributed in high density honeycomb structure over 33 mm area. You can see it is a 9.4 mm in the central clear zone, and in the 33 mm that is the hyperopic defocus. So each island provides a defocus of 3.5 diopters. It's a detail of this DIMS treatment zone in details. There will be two defocus parts in the pupil zone, that is defocus and focus. The ratio of these areas have to stay similar regardless of the gaze direction. And the defocus islands are distributed high density honeycomb structure. So this is the structure of the DIMS treatment zone. Each island is spherical like front surface of the entire lens. You can see the glass is already ready-made and there are the different spherical front structure that is the refurbished later on. There is always 396 defocus islands, and each island creates a 3.5 diopter of the defocus. And each island, that is, you can see these spherical, you can see the defocus of 3.5 diopter, that is 1 millimeter in diameter, and in between that is each island is a 1.5 millimeter. So you can see the difference between those, that is a clear island of the focus. You can see it is a 0.5 millimeter in the diameter. So each island is 1.5 millimeter apart from the next neighbor. That is from center to center distance. So these are the product features of the DIMS technology. And you can see the lens appearance after mounting. The lens appearance on the wearer, you cannot identify those defocus islands on the wearer. And next is the ortho. Means the ortho means the straight, keret means cornea, and the ology means the knowledge. So reshape the cornea. It's a non-surgical topographical approach to affecting a correction, and where it is needed, basically to correct the refractive errors, mainly myopia, astigmatism and hyperopia, and in some cases can be used in presbyopia. It slows down the progression of the myopia. So what are the principles? Basically it's a corneal shape changes, it compresses, and there is redistribution of fluid and cells from the center to the periphery, and there is a thinner central corneal epithelium and the positive pressure from the flat central lens curve, and there is a thicker mid-peripheral corneal epithelium. It is because of the negative pressure from the tear pool on the step 2. So how does the lens fits on the cornea? You can see there is an alignment curve. It's similar to curvature of the mid-peripheral cornea to the optimized centration. There is a base curve flatter than the central cornea, and a very thin tear film layer that is less than 10 microns, and there is a reverse curve, the steeper than the cornea to bring back surface to the cornea, that is a thick tear layer. So in the peripheral there is a curve. So what is the mechanism of the orthokeratology? Basically, at the apex of the cornea, the fluid reservoir thickness is in between 5 to 10 microns. You can see in the graphs. And the periphery, the reverse curve of the lens, the reservoir thickness is between 30 to 60 microns. And as a result, the central corneal epithelium at the apex gets dehydrated and it loses its cytoplasm and becomes thin. You can see the ideal fitting pattern of the ortho-K lenses. It's a bullseye pattern. The lens movement is between 1 to 2 millimeters. The base curve zone touch is between central. You can see the central black part there 4 to 6 millimeter, and there is a reverse curve zone. It's a green colored. You can see on the fluorescent patterns, a green colored ring with the equal width of 0.6 to 1 millimeter, and there is an alignment zone. That is the black part with the equal width. So it's a various fitting process of ortho-K lenses. And it's as we all practice in day-to-day routine practices, the user guide for the myopia patients, you should spend the more time the outdoors because of the vitamin D3 deficiency we are encountering routinely in the because of the less time spent outdoors, and the screen time should be reduced. And the work ergonomics, you can see a proper lighting condition, the posture and recommended working distance is very important, and the regular eye checkups are required for these myopic patients. Thanks a lot.
Thank you, sir. Now I request Dr. Indamohan Rastogi to please present the memento to Dr. Rajan. The session is by Dr. Megha. She'll be speaking on color vision evaluation.
Good morning everyone. My topic for today's presentation is color vision, testing and evaluation. So starting with color sense, it is the ability of the eye to discriminate between colors excited by light of different wavelengths. Color vision is a function of cones and is better appreciated in photopic vision. There are 3 different types of cones, red, green and blue sensitive. They combinedly perform the function of color vision. All colors are a mixture in different proportion of 3 primary colors, that are red, green and blue. Colors have 3 attributes, hue, intensity and saturation. For any color, there is a complementary color that when properly mixed with it produces a sensation of white. The color perceived depends in part on the color of the other object in the visual field. A normal person can see all the wavelengths between violet to red. Blue cones contain some sensitivity at around 10 nanometers, but crystalline lens blocks all the UV rays. After cataract operation, one can see UV rays to some extent. In dim light, all the colors are seen as grey. This is known as Purkinje shift phenomenon. Mechanism of color vision. There are 2 theories, trichromatic and opponent cell theory. This theory was stated by Young and Helmholtz. It postulates the existence of 3 kinds of cones. The sensation of any given color is determined by the relative frequency of the impulse from each of the 3 cone systems. This is the graph showing the absorption spectrum of 3 cone pigments. Opponent color theory. It proposed he noted that there are some color combinations that we never see, such as reddish green or yellowish blue. Distribution of color vision in the retina. The trichromatic color vision mechanism extends 20 to 30 degrees from the point of fixation. Peripheral to this, red and green become indistinguishable, and in the far periphery all the color sense is lost. In this image we can see the center 1/8 portion is blue blind, which attributes to chromatic aberration. Beyond that, from 30 to 70 degrees there is the dichromatic region, and beyond the dichromatic region the region is monochromatic. Normal color attributes. Hue, it is the dominant spectral color. It is determined by the wavelength of the particular color. Munsell defined hue as the quality by which we distinguish one color from the other. The second is the saturation. It can be estimated by measuring how much of a particular wavelength must be added to white before it is distinguishable from white. Another is lightness or brightness. It depends upon the luminosity of the component wavelength. In photopic vision, normal eye has a peak luminosity function at approximately 55 nanometer, and in scotopic vision it is about 507 nanometers. This is the graph showing the photopic and the scotopic luminosity curves. Then coming to color blindness, an individual with normal color vision is known as trichromate. In color blindness, faculty to appreciate one or more primary colors is either defective, that is anomalous, or absent, which is known as anopia. It can be congenital or acquired. In congenital defects, it affects both the eyes equally. In acquired defects, it may affect one eye only or asymmetric. Usually, a red-green defect is found in congenital defects. In acquired defects, it is blue-yellow or red-green. In congenital defects, other visual functions are absolutely normal and it is stable throughout the lifetime. In acquired defects, other functions are also abnormal and it is variable. It depends upon tests and diseases. In congenital defects, they are more prevalent in males, and one or more cones are absent in congenital defects. In acquired, they are equally prevalent in males and females. The cones are present but work at decreased or altered spectral sensitivity. Causes of congenital defects are X-linked recessive gene, and acquired defects are diabetes, glaucoma, medication, aging, and it may be due to chemical exposure. Congenital color defects are of two types, achromatopsia and dyschromatopsia. Achromatopsia, it is an extremely rare condition characterized by cone monochromatism or rod monochromatism. Cone monochromatism, it is characterized by presence of only one primary color cone, and thus the person is truly color blind. Such patients usually have a normal visual acuity and dark adaptation. Rod monochromatism, it is characterized by total color blindness. Acquired color blindness, it can be blue-yellow impairment or red-green impairment. Blue-yellow is usually seen in CSR, macular edema, shallow-RD. Red-green deficiency seen in optic nerve lesions like optic neuritis, Leber's optic atrophy, optic nerve compression. Acquired blue defects, it is seen in old age due to increased sclerosis of the crystalline lens. So coming to tests for color vision, these tests are designed for screening defective color vision from normal, qualitative classification of color blindness, that is protons, deuterons, triton, quantitative analysis of degree of deficiency, that is mild, moderate or marked. Plate test, it was first introduced by J. Stilling in 1873. Today they are the most commonly used screening tests for color deficiency in clinical practice. These tests are inexpensive, durable and readily available. Plate tests are best used as screening tools. Ishihara test is the most commonly used. The test consists of a series of cards on which a figure is printed in multiple colors against a multicolored black background. The figure is recognizable to normal trichromates but not to those with color defects. The figure used in the test is usually easily identifiable number, letter or shape. Figure and background are drawn in dots. The size of the dots usually in plate design can be varied or uniform. The only difference between the figure and the background is color. The Ishihara test is published in a full 38 edition, an abridged 24 plate edition and a 14 plate edition for quick screening. Scoring instructions for the Ishihara plates accompany each test. In a 38 plate edition, for example, a normal score permits 4 or fewer errors. In the 24 plate edition, 2 errors or less are considered normal. The 16 plate edition also puts 2 errors or less in the normal range. The Ishihara can be used in children as young as 5 years. The color differences between the figure and background are chosen to separate normal trichromates from mild anomalous trichromates. If the differences in color are too large, anomalous trichromates will be able to identify the hidden figures. Small differences may cause normal trichromates to fail some screening plates. So how to test the color vision by Ishihara chart? Room should be adequately lit by daylight. Nature of the test should explain to the patient. Full refractive correction is worn. It is preferable to do test before pupillary dilatation. One eye is occluded and then other is tested. The plates are kept at a distance of 75 cm and the standard time to taken to answer each plate is 3 to 5 seconds. It consists of 38 plates. First is the demonstration, then 2 to 9 are the transformation plates, 10 to 17 the vanishing plates, 18 to 21 hidden plates, then 20 to 25 are classification plates, then the tracing plates. Arrangement test, one is the Frankfurt Munsell 100U test. It is a spectroscopic test in which the subject has to arrange the colored chips in ascending order. The color vision is judged by the error score. Greater the score, poor the color vision. The color differences between the adjacent caps on Franz and Manthal were designed to be very small. This is the image showing normal response in the Franz and Manthal test. Another test is Frankfurt panel D15 test. It is a miniature version of 100U test. Then another is anomaloscope. It is an instrument that uses the principle of color matching to test the color vision. The lower half of the field is filled with the spectral yellow at 589 nanometers. According to Rayleigh match, the subject should be able to match the color of the upper and the lower field by adjusting the mixture of red and green light. And the last one is the City University test. There are 10 plates. Each plate consists of central color and the 4 peripheral colors. One more is the lantern test. These tests are simple devices geared towards measuring the subject's competency to perform the specific task. The subject is asked to name the colors of the light signals that are presented to him, and the 2 types of lantern tests exist. Those that present single colors and those that present the pairs of lights together.
Thank you, Dr. Megha, for such a nice lecture. Now I'll request Dr. Yuvika Goyal to present a memento to Dr. Megha.
So with this, we conclude the first session. May I request Dr. Khurana to please felicitate all the panelists and chairmen. I request Dr. Dhul to please come on stage. Dr. Subhash Mehta.
Very good morning.
Dr. Markande Ahuja, Dr. Praveen Arora sir, Dr. Rahul Singla.
एक सेकंड सर ये सत्तर पुराना सर
Dr. Vivek, Dr. Shilpa, Dr. Megha, Dr. Ankita. I think Dr. Amit has left. Dr. Rajan. Hanji. Can we have the photograph with the speakers and panelists? We hand over the stage to next session. Next is cornea.
ये व्हाट्सएप पर अच्छा बात कर रही है आपसे
Good morning, everyone. I will request Dr. Harshul Tak. Dr. Harshul Tak, please. Dr. Harshul Tak. Dr. Narendra Taneja, sir, to please come on the stage. Dr. Bindya Dhupar, Dr. Monica, Dr. Vishal Arora.
Is it okay, sir?
Dr. Mansi Jindal.
आप यहाँ आ जाओ बीच में आपने चलाना है
एक कम हो गया आप आगे आ जाओ इसके ऊपर रख दो
हाँ दो भी लगा HDMI लगाना HDMI लगा दीजिए
ठीक है वो नहीं आ रही ठीक है so we will like to start our first session. Dr. Akashdeep.
I'm here, sir. Good morning.
Right on time. So we'll start with our first talk, Dr. Akashdeep.
Hello, a very good morning, everybody. So we'll start with corneal ulcers, how to trace the bug. So what is a corneal ulcer? Every epidefect is not an ulcer. An epidefect with underlying inflammation or necrosis is a corneal ulcer. This is a typical corneal ulcer. You can see inflammation and an epithelial defect. So how do we approach a case of corneal ulcer? We do a stepwise approach. We take in account of the risk factors, history of the patient, detailed examination, relevant investigations, especially corneal scraping, and then reach a diagnosis and treatment. So we need to send each patient to this funnel with a diagnosis rather than giving a or a mixture of drugs. So one of the epidemiological studies showed out of all the corneal ulcers, around 50% are bacterial, around 40% are fungal, and other 10% are parasitic or viruses. Can I have show of hands from the audience? How many of the people actively do corneal scraping in a case of corneal ulcer? Very few. Okay, so this is a study conducted in China which showed out of all the cases seen on picture, only 70% of the surgeons were accurate in the diagnosis based on the picture. And this is including cornea and non-cornea specialty, which is quite equal, around 67 and 75%. So 30% of the cases are misdiagnosed on clinical picture. And this is how much is the sensitivity and specificity of gram staining and KOH, more than 90%. So this helps us make 20% better diagnosis with a very cheap and easy to investigation to do, increasing our treatment rates. What is the present scenario? Most of us use multiple drugs, combination of antifungals and antibiotics for corneal ulcers. Issues are poor compliance, high cost, drug toxicity, and lower efficacy of the regimen. It is our inertia rather than the lack of facilities that stops us from doing microbial workup. For what samples can we collect? We can take scraping from corneal ulcers, contact lens solutions, corneal sutures, broken or loose ones, corneal foreign bodies, biopsy, corneal buttons while doing PKs, and anterior chamber tap. What do we need for scraping? A slit lamp or a microscope, proparacaine eye drops, 50-number surgical blade or a Kimura spatula, a glass slides, culture medias, the BP handle, and eye speculum. All of this is readily available. How do we do a scraping? We remove all the necrotic muck and debris from the ulcer, scrape from periphery towards center, and take scrapings from the active edge of the ulcer and the ulcer bed. Prioritize order of samples as per the case. So clinical judgment says bacterial, take grams first. Clinical judgment says fungal, take KOH first. Clinical judgment says bacterial, take aerobic culture first. Clinical judgment says fungal, take Seborrheic dextrose agar or potato dextrose agar first. Gram stains helps us differentiate between gram positive and gram negative organisms. KOH dissolves the cellular debris and gives us clear picture of the fungal hyphae. and calcifer white enhances the morphology of these. This is a specialized stain. When in doubt, it gives a very clear demonstration of the fungal hyphae, black hyphae against green background, and can be used for restaining of the gram stain. So when in doubt, you can use a restaining of the gram stain. This is available with all the pathologists, and we can see a very sharply demarcated fungal hyphae. So these are the culture medias which we use. There is blood agar and chocolate agar for aerobic culture, non-nutrient agar with E. coli overlay for acanthamoeba, sabrods and potatoes dextrose agar for fungus, and then infusion broth, thioglycolate and brain heart infusion broth for enhancing the growth of the bacteria. So when do we call growth to be significant? When there is confluent growth on the solid medias, when there is consistency between scraping smears and cultures, repeated isolation on the cultures, or growth in more than one media. So a single media growth, non-confluent, can be contamination, but if it is something like this, confluent growth on colonies, then this is significant growth. So this is Staph aureus and Streptococcus colonies, very, very common infectious organism. This is how Pseudomonas looks, creamy, opaque, moist, confluent colonies. This is how nocardia, wreath-shaped ulcers, beaded filaments on the gram stain, and very tiny, dry, chalky, white colonies. This is how a fungal hyphae looks. This is how fungal hyphae looks on the gram stain. This is how the fungal growth looks. This is Aspergillus, granular colonies, greenish black in color. Fusarium gives fluffy off-white colonies. And this is a pigmented ulcer, that is dematicious fungal ulcer, giving a pigmented colonies on the slope. Acanthamoeba has distinct double-walled cyst on gram stain with granularity. Even on KOH they are visible. This all helps us to get something like this picture. You do a scraping. It comes as something like gram positive or gram negative on the bacteria. Start on empirical therapy, combine something covering both gram positive and gram negative organisms. Wait for the culture, then you get a sensitivity report. Patient starts responding, you can start the patient on the steroids, and the patient comes out with a very much better results. So this is something which really helps the patient, the complete sensitivity report. This I do for routine all my patients. Then comes PCR. PCR is often not done, but the lack of expertise, lack of the facilities is the main reason and the cost factor why we don't get PCRs for our patient. For bacterial and fungal, PCR has a slightly dubious role because even non-pathogenic organisms will have positivity on PCR. But when you do PCR for HSV, when in doubt, it can help. Hypertensive uveitis, Poshner-Schlossman syndrome, eye syndrome, something recurrent iritis, you are not able to diagnose, take an AC tab, send for PCV, very high sensitivity and specificity. Then there are cases of unidentified corneal edema not responding to conventional acyclovir, valcyclovir and steroids, repeated hypertensive uveitis in a young 20 to 40-year-old male or female. Could be CMV, very high sensitivity and specificity on PCR, can be CMV. For CMV, we need valganciclovir, not acyclovir will not work. Then there is something called direct fluorescent antibody test. Corneal edema, corneal keratitis, pigmented KPs, don't know. Just take a scraping on the slide from take an epithelium, send for direct fluorescent antibody. continue the session. Meanwhile, I'll answer the question. So I see 5 to 10 new ulcers every day, and I do KOH myself of all the cases. I bought a microscope, 5,000 रुपए का आया था, ठीक है ना? 2 रुपए की वो टैबलेट आती है KOH की. I take 2 ml distilled water में वो टैबलेट डालना है, 10% KOH बन जाता है. I replace it every. My staff knows how to do it. 2 ml का टैबलेट लेना है, 2 ml distilled water डालना है और KOH बन जाता है 10%. स्क्रैपिंग लिया, स्लाइड पे डाला, 1 ड्रॉप डाला, ऊपर कवर स्लिप रखा, 5 मिनट रखा उसको. 5 मिनट के बाद अब देखो 5 मिनट में वो डेब्री डिसॉल्व हो जाता है. आफ्टर दैट इट गेट्स ड्राइड अप, इट वोंट वर्क. एंड आई वुड सजेस्ट कि अगर आपको मतलब अगर वो फंगल है तो कम से कम 70 to 80% पॉजिटिविटी कैन कम विद एनी अल्सर्स. आपको कोई माइक्रोबायोलॉजिस्ट की जरूरत नहीं है, किसी को बुलाने की जरूरत नहीं है. माइक्रोस्कोप लीजिए, वो KOH का डिब्बा आता है वो लीजिए, 1 टैबलेट लेना है, 2 ml डिस्टिल्ड वाटर डालना है, 1 ड्रॉप उसका ड्रॉपर से लिया, स्लाइड के ऊपर डाला. टेक अ चंक ऑफ अल्सर, नॉट द डेब्री. टेक अ चंक ऑफ अल्सर फ्रॉम द अल्सर बेड और द एज, ऊपर डाला, कवर स्लिप पे देखा. अ वेरी वेरी हाई पॉजिटिविटी रेट विद KOH. समथिंग विच आई थिंक एवरी ऑप्थेल्मोलॉजिस्ट शुड डू एंड नॉट डिपेंड ऑन अ माइक्रोबायोलॉजिस्ट. Whenever I send to a microbiologist, यही होता है कि I send it, patient comes at 11, I take a scraping by 12, I'll send to a microbiologist, वो तो लंच पे गए हैं जी, वो they are being a non-clinical branch, they take their breaks. तो 3-3:30 बजे रिपोर्ट आती है and the patient is by then कि मैं दोबारा इस हॉस्पिटल में नहीं आऊँगा, 4 घंटे बिठाया इसने. So something like this. So I have stopped relying on KOH with the microbiologist. For cultures, I take their help. And cultures, the reporting is around 50% positivity, and कई बार उनकी contamination reports भी आती हैं. Whereas KOH is something which every ophthalmologist should include in their practice.
Okay. Thank you for that practical tip.
सर एनी जो केमिकल सप्लाईज वाले नहीं होते जो अल्कोहल और जो स्कूल्स में सप्लाई करते हैं एवरीथिंग, उनको बोलो KOH टैबलेट्स का डिब्बा आता है, व्हाइट कलर्ड बॉक्स, इवन अवेलेबल ऑनलाइन. अगर आप Amazon से भी ऑर्डर कर सकते हैं, ऑनलाइन अवेलेबल है. एक सिंगल टैबलेट, 2 ml distilled water, take any urine sample वाला जो हम बॉटल रखते हैं उसमें रखिए, डालिए. You can use it for a week. After a week you replace it. Put on one single drop on a slide, cover slip, wait for 5 minutes, and then you can see on 5 minutes. Make this a practice. Within I think around 10 to 15 cases, you'll be much more comfortable in detecting fungus on KOH. And I have made it a practice. I take a photograph. I always send it to a referring doctor. Positive आया है. 45x on the objective eyepiece and 10x on the surgeon side. Yeah.
Dr. Akashdeep, let's start.
Sir, yes, sir. Okay. So there is direct fluorescent antibody test. Again, fluorescence microscope चाहिए, requires skilled expertise and the skilled lab. So that's why not commonly employed. But whenever in doubt, you can take HSV and CMV samples on direct fluorescent antibody, and it does help to detect HSV keratitis. It's equally sensitive and specific when it comes to PCR, and cheaper and easier to do and a very rapid method. Confocal microscopy is more of a research tool now because it's very expensive, very difficult to do, requires very skilled expertise, and only very few facilities across India has this specialty. It's not practically viable, but it is very good to see fungal filaments on acanthamoeba cyst on the confocal microscope. I have had the opportunity to use. I've never used it for diagnosing, but have used it for my interest and personal choices. Thank you.
Thank you, Dr. Akashdeep, for such a wonderful talk. I would like to invite Dr. Namrata. Please be ready with the talk, and request Dr. Harshul to please give a momentum to Dr. Akashdeep. Sir, we will have at the end. We will take the questions in the end for the entire session. So pick up the sit in the hall only.
Good morning, everyone.
Dr. Namrata will be talking on two topics. She will be talking on slit lamp photography and pachymetry.
Good morning, everyone, and thank you, Sirsa, Fatehbad Ophthalmic Society and Haryana Ophthalmic Society for this wonderful symposium on diagnostics. So my first topic is corneal pachymetry. Though it's a very vast topic and the time allotted to me is very less, so I will just hurry up so that I can cover all the points. What is basically a pachymetry is a measure of corneal thickness, and we have various approaches to measure the corneal thickness: optical, ultrasonic, and cross-sectional imaging. This is a simple flow chart. So how do we actually divide the various techniques amongst the contact, non-contact, ultrasonic device, pachymetric devices, optical and cross-sectional devices for measurement of corneal thickness? Why do we need to measure corneal thickness? It's an important and sensitive indicator of health and endothelial function, and it helps in various corneal diseases like in Fuchs dystrophy, corneal edema, keratoconus, corneal and glaucoma. It's a very important tool for correct measurement of IOP, and the most important for all of us is selecting patients for the refractive surgery and assessment of posterior corneal curvatures. Corneal in normal eyes is in the central cornea is between 0.49 to 0.56 millimeters, and mean CCT is 0.51 to 0.52 millimeter. Peripheral corneal thickness is asymmetric, so that the temporal cornea is thinnest, followed by the inferior cornea. Amongst the various devices, the optical pachymetry first device was popularized in 1950. It was an optical pachymetric device. The most commonly used, though rarely uses Hack Street pachymeter, and it measures the corneal thickness by evaluating oblique sections of cornea using split prisms and aligning the split images to coincide epithelial and endothelial image and layers. Now we have gone so far from this, and we have newer devices. The most and the basic principle of it is that it depends on the reflection of ultrasonic wave from the anterior and posterior corneal surfaces, measures the transit time between the echoes of ultrasonic signal pulses from the transducer of probe and reflected signal from the front and back surface of cornea to the transducer. There is a simple formula to calculate the corneal thickness in corneal ultrasonic pachymetry. The various should be placed on the center of the cornea perpendicularly. Any wrong placement of the probe on the cornea can give us a false reading. And this is an ultrasonic pachymeter, no financial interest. The various pitfalls in ultrasonic pachymetry is that the exact points of reflections are not known, limited to a single point measurement, and is sensitive to positioning and angulation. Despite the numerous limitations, many papers refer USP as a gold standard, which is a common misnomer. Though most commonly used thickness measurements, its inherent limitations should preclude it as serving as a baseline to judge other devices. But still, USP remains a de rigueur at many ophthalmic practices due to its low cost, ease of use, and relative reproducibility. It is based on this principle of normal to surface tangent method. I am not going into much detail. Apart from this, there are other procedures, there are other mechanisms to measure the corneal thickness, the parallel vertical sections, minimal distance, and from a fixed point. Now coming to UBM, it is a high resolution ultrasound machine, but it has a very less depth of penetration as compared to the ultrasonic pachymeter. This is a UBM machine. The various pros and cons are there with the UBM also, but most important, it is useful in the opaque cornea. But the disadvantages is that we cannot actually standardize it, and we cannot use it intraoperatively. The patient has to lie supine, and there should be a use of coupling fluid and immersion for the measurement of corneal thickness. Specular microscopy is the oldest method of pachymetry, and it is based on the principle of focusing of light rays from the front-back surface of cornea, unlike the sound waves in ultrasonic pachymetry. And it has two types, the contact and the non-contact. So advantage is of specular microscopy is it is very much operator independent, non-invasive, and simultaneous measurement of the cell count is possible with this tool. And it has few disadvantages also. It is less reproducible, cannot be done intraoperatively, it is time consuming. Then the most important, one of the most important tool is the OBSCAN, which is based on the slit scanning pachymetry principle, and it's an elevation based system. It helps in the measurement of thickness, anterior posterior topography, elevation, anterior chamber depth, and it's a pictorial representation of corneal topography in the form of 4-point map. The wide field pachymetry identifies the thinnest point in the cornea and can be used to calculate ablation depth and optical zone in corneal refractive surgeries.
It overestimates the corneal thickness in 5% of the normal cornea, and it underestimates in the patients who have undergone PRK, LASIK or keratoconic eyes. This is anterior segment optical tomography. I think this topic will be covered in the next presentation, so I am not going into much detail. Nowadays we have the better machines for the anterior segment optical tomography. We can measure the epithelial thickness also, which is very important for the refractive surgeries. And we have a caliper system, so we can measure the lenticule thickness after the DSEC surgeries or the DALC. Pentacam is one other, which is the latest and most commonly used, one of the most commonly used machines, and it's a Scheimpflug imaging system, and it performs various functions in just 2 seconds. The 4-map analysis, this is the most frequently read map in the Pentacam. It has many advantages, like it is every minute, every minute eye movements are captured very correct and corrected simultaneously, but it has certain disadvantages also. Sometimes it underestimates the corneal thickness in comparison to the ultrasonic pachymetry. OLCR, optical low coherence reflectometer, the hack streak OLCR. And now the CCT values comparison with different techniques. We have seen that the CCT value is highest with the ultrasonic pachymetry, followed by Pentacam, then 3D OCT and tonopachymeter. There's a positive correlation between USP and non-contact devices, and significant correlation is present between anterior segment OCT and USP, Pentacam and USP, and Pentacam and anterior segment OCT. So to conclude, anterior segment OCT, Scheimpflug based imaging USP could be interchangeable to measure CCT in healthy subjects. They are not simply interchangeable in high myope, post-refractive surgery, high irregular astigmatism or other corneal ocular pathologies. Thank you. I have one more topic to cover. If
you can continue, Dr. Namrata.
This is a very interesting topic. This is basically, the topic was slit lamp photography, but most of the time we are not using the cameras mounted on the slit lamp, and we have the handy Android phones with us. So I converted the topic to smart photography. So we will be discussing how we can capture the best ophthalmic images in our busy clinical practices. So this is a reference picture for the keratoconic eyes. We can capture a beautiful keratoconic conical cornea, and the patient had severe uncontrolled VKC in the patient. So like the light camera action, we have 3 important points to cover in smart photography. First is the exposure, the point of focus and the zoom. Why do we need a smart photography? Mounting cameras on slit lamp costs thousands of rupees. High quality slit lamp photography is just possible with smartphones, which are handy and available with every doctor amongst all of us. And the main 3 prerequisites are the smartphone with at least 5 megapixel camera, creating ideal lighting, make the camera steady on slit lamp either with an adapter or with a gifted ophthalmic surgical hands. Why I prefer the handheld method? It's a very quick way to obtain images in a fast-paced clinic. We just need to practice to steady our hands. The procedure is we need to hold the smartphone with one hand, stabilize it with placing elbow on the slit lamp table if you like. Align the camera lens through the eyepiece and slowly bring it closer to the eyepiece while looking at the smartphone screen. Observe a good image and snap off few photos. Depending on what is to be clicked, adjust zoom either with the slit lamp or through the smartphone. So this is a simple way how I take the slit lamp photography in the clinic. I'm not taking the I'm not keeping my elbow on the slit lamp. With the practice, I have been clicking the photograph for the last 7-8 years, and it has stabilized my hand so much that I just take 1 second to click a picture. Just we need an external light source, or a light source can be mounted on the slit lamp, and a good camera, and we can click as much as we like. And for every photograph, I generally used to click 7-8 pictures, and amongst all those pictures, I choose the best one that is best suiting to me, and convert it with the various apps which are available in the phone for the editing purpose. So lighting and exposure is most important to have a good quality click. There is a tendency for the images to white out if overexposed, so exposure should be appropriate. We have the various illumination systems. External illumination system includes the room lights, focus light sources like handheld illuminator, pen light, or the clip, or we can clip a light on slit lamp. and internal illumination is a slit beam illumination. So why it is important to edit the picture? This is the first picture which has taken out from the phone, and there was no editing. Then I used some apps to edit the pictures, and this is the second picture, and we can make out the corneal ulcers so well on the second picture, and all the exposure I have adjusted with the editing apps, and we can get a good image for the corneal ulcer. This is a picture of a desmatocele. In the first picture, I just used the external beam illumination, and in the second picture, I used the dual illumination, the slit lamp illumination as well as the external beam illumination. So we can make out the desmatocele, shining desmatocele very well in the second picture, but not in the first picture. So we have to see what lighting we are using to the pathology we are trying to click. This is a pure internal slit lamp illumination. I have not used any external slit lamp illumination, and though the picture is good, but it should be better if we would have used the external illumination. So this is a dual light. We have used the slit beam of the slit lamp and the diffuse external beam, and we can easily make out the demarcation line post cross linking. Just the 4 days cross linking, and the demarcation line is so clearly visible on the slit beam. This is a direct diffuse illumination, corneal bent in secondary Sjogren syndrome. This is a DSEC lenticule, can be easily make out with the slit lamp photography. So everything can be clicked. Whatever we want to click, we can click everything. The various out of this, the direct diffuse illumination, this is a case of granular dystrophy. Here I want to focus on the extruded SFIL haptic. So I focus the beam, and the rest is blurred in the background. This is cornea verticillata, bilateral. I use the parallel loop slit lamp beam. Over that I used external beam illumination from the external torchlight, and we can capture this. This is a direct focal illumination focusing on the SPKs on cornea. This is an optical beam keratoconic scar. In the second one, it is a nuclear cataract. But once we made an optical section and we clicked it, we can easily make out that it's a nuclear cataract. Anterior 1/3 of the vitreous face can also be captured with the slit lamp photography, and they are the cells in the vitreous cavity, anterior 1/3 showing the vitritis. So why we can even capture the retro illumination captures. This is the first picture. There is a retained cortical matter, but we cannot make out in the external diffuse illumination. So I captured the image with the retro illumination, and we can see very well the rhexis margin, the lens, and behind that the retained cortical matter. So here's the role of zoom. I want to focus on the epithelial defect, so we can even follow the progression and the healing of the disease with the help of the zoom, and we can keep a record of the patient progression. AC cells can also be captured with the photography. This is the retro illumination captures of PC tear and the superior subluxated lens. Fluorescent captures are also possible. Microsporidial keratitis, dendritic ulcer, very well captured on cobalt blue filter. So epithelial ingrowth. So these are the some pictures which we have clicked through the smartphones, just the simple Android phones. Thank you very much for the patient hearing. Thank you.
Thank you, Dr. Namrata, for such a smart talk. I will request Dr. Taneja sir to please facilitate Dr. Namrata, and Dr. Vishal sir, please be ready with your talk.
So, Dr. Namrata, that was a wonderful talk. And I think it's really quick to capture slit lamp images with your mobile cameras, handheld cameras, freehand. But if you want to capture them in higher resolution and better quality, then of course you have to go for DSLR if you are game for the photography higher than this. Because see, the sensor of the mobile cameras, I also use daily with iPhone and this. But when you have to capture something which is very good and you want to, go for competition and like that, then I use DSLR only. Because the sensor of these cameras are smaller. So it can never capture that high resolution as compared to DSLR. And secondly, there is always an air interface which is there, freehand. And if you have to zoom, the suggestion for everybody is zoom with your magnification of slit lamp, because there is the optical zoom of the mobile which is working, so it pixelates when you are trying to blow up the image. So it's wonderful to take quickly photographs and show to patient and to show here, but for those quality of pictures, you have to use DSLR, which can be mounted on slit lamp. Of course, it costs 1.5 lakh, 2 lakhs, but it's worth it. Yeah. Thank you very much.
Thank you, Dr. Namrata, for such a wonderful talk. Thank you, Sirsa Fatehbad Ophthalmic Society, for inviting me. So I'll be very brief in my presentation. I will not be covering the advanced aspects here. How many of you do have access to any topographer? Most of us know, right? Okay, let's go. So I'm going to discuss about techniques and their evaluation, basics, and their application with a few examples. We have come a long way from machines that could measure only the interior surface to the machines that can measure the whole of the eye. So it started with the VKG 20 years back, and now to the dual Scheimpflug devices, and now to the OCD enabled topographers also. We should also remember this historically, and this is for the people if they are into their PGs, that how the Placido topographer, how the output of the topographer from the Placido disk can be noted and can be graded into these various shapes, and you put a Rabinowitz criteria and still it goes a long way in detecting frank keratoconus. We are utilizing this to detect corneal ectasias in our keratorefractive surgeries, IL power calculations, Pachy, topo-guided LASIK, corneal aberrometry and cataract surgery, and much more. So before understanding this, everybody knows that there are colors on the topography output. What do they mean? Any topographer which we see is measuring the cornea or a tissue of interest. On that, it puts a reference sphere. There will be some points which will be over the reference sphere, which will be hotter. There will be some points which will be below the reference sphere, which will be cooler. So green usually means at the plane. Anything hotter than that means that it is steeper than the reference sphere, and anything below that or a bluish tone means that it is a deeper color. Now, to understand this, we should know the corneal shape. Natural corneal shape is prolate. That is why most of the time we always see this island in various shapes. You can have a bow tie here, you can have so many things. I'm not going to go into details. Then the central island corresponds to the steep part, and then the side panel goes below the reference sphere, then that's why you have the blue space. And then at the periphery, that is beyond 8 millimeters, you have that steepening also, which you feel in, as you see in the presbyops or presbyon surgeries. So this is it. I'm going to first discuss with the OBSCAN printout. Everybody knows the OBSCAN printout, yes? This is a 4-map printout. Even in the Scheimpflug also, I'm going to discuss on this only. I'm not going to go towards Bellin, or I'm not going to go towards Corbis. I'm not going to go towards OCT. Please remember, if you master this, you will not miss ectasias or keratoconus. So this is how the normal printout looks out. It has a curvature map, interior elevation, posterior elevation, and a pachymetry map. And then centrally you have the data points. What is considered normal? Please remember, if the posterior float difference is less than 0.05, it is considered as a normal scan. Also, look at the irregularity in the 3 millimeter and 5 millimeter zone, if it is less than 1.5 and less than 2.5 respectively. When you move the cursor on the keratometry map, though it's a Roche criteria, which is now not being followed much, but if you move your cursor on the keratometry map, if the keratometry is anywhere corresponding above 40 diopters, you should be suspicious. You look at the thinnest point and the thinnest location. The difference between the two in terms of thickness should be less than 20 microns. If it is more, then you are dealing with an abnormal cornea. Look at the other eye. If the other eye difference and your eye difference is more than 1 diopter, it's an abnormal cornea. Roche criteria, it is good for detecting frank keratoconus, but unfortunately not for detecting the form of Reste types. So what is abnormal? So for example, in this scan, you have the posterior float which is difference is more than 0.05. The irregularity index at 3 and 5 is more than 1.5 and 2.5. The pachymetry is actually very thin, and the thinnest point is also 20 microns thinner than the central cornea. Also, it is lying away from the 3 millimeter zone. When you look at the keratometric power map, it is more than 48 diopters. Other eye did show more than this. Now, there has been an update. Now in the 2Z, you have the score analyzer. For example, what does it mean? So it is only taking care of 5 aspects, which we discussed. So it is just showing how far is your thinnest pachymetry point, how much is your posterior elevation, how is the irregularity in the 3 mm zone, what is the offset and what is the actual thinnest pachymetry, and what is the central pachymetry, and what is the difference between the inferior and superior points. If this score comes out to be more than 1, you are dealing with the suspicious cornea. Remember this. Let's come to the next most common topography that we see, and the topography printout which everybody sees, which is the pentagram. So pentagram, you don't need the building, you just need this 4 map. You should always have an axial map here, which can be axial or sagittal, or some people use instantaneous also. You can have elevation, you should have the elevation map of the front, the back, the pachymetry map, and look at the data points. In data points, you have the keratometry values. Then you look at the thinnest point values. Where is the thinnest point, and how much far is it displaced from the center of the cornea. If these things you remember, you will not miss any keratoconus. So for example, in this patient, if you look at the 4 map, there is inferior steepening, there is increased values of the keratometry. Then you look at the anterior float, which is more than 15 microns, which is going most indicating that it might be a cone. These are not absolute, these are relative. And then you look at the posterior float. All these points are coinciding. There has to be a correlation. It is not like one is abnormal and you label it as an abnormal topography. There has to be a coincidental point for all. And it should coincide with the thinnest point on the pachymetry map, especially the posterior ones. Then in the end, look at the displaced corneas, displaced thinnest point. If you want to go further, then yes, Berlin will give you a much better insight, because it uses a difference of sphere method by reducing the BFS and giving you a clearer picture by enhancing the cone, which is on the left side. It will give you how the thickness profile is varying from the center of the cornea towards the periphery. How is the dip going, and how is it progressing? Is it progressing fast? If it is progressing fast, that means we are dealing with an abnormal cornea. Any values, gross values of more than 8 or 2.6 is considered abnormal in case of a D value. So this patient is a 37-year-old patient. I'm coming to the examples. So you look at the pentagram. So if you don't have the Berlin, you might say, yes, there is some inferior skewing. You remember your Placido times. Yes, there is inferior steepening. When you look at these points, okay, there is inferior steepening, and just go, yes, there is some suspicious, yes, this is elevated. And then you go on the same area, there is elevation, and it is progressing, and it is shifted towards the inferior temporal side. And this is coinciding with your thinnest point also. The left eye is much more explanatory as compared to right eye. If this patient is not ready for an excimer laser surgery, especially the flap based ones. Example 2, a much recent one. This was sent to me. It's a -4 diopter, stable. This is a 26-year-old female. There is steepening, yes, definitely, and you can see a central island. But the central island is not regular. Had this been whole blue, this would be considered as a normal thing. This central island, and then there is a inferotemporal steepening, which is coinciding with the thinnest point here, and the thinnest local is displaced more than 5 diopters, 0.5 millimeters. In the other eye, it is much more prominent in the left eye, and you can see these points directly here, and the displacement is much more. So I just sent him this, that because of this patient is not ready for a laser surgery. So this is my second last slide. Yes, there are much more definitive topographies available. You can attach your pentagram to the corpus to get an ABCD classification. You can have more better scoring. You can have OCT based topographies. You can have Baumann layer based topographies also. So this is going further and further to detect FF cases. But if you are doing a refractive surgery, 99% of the times the 4-map refractive printout will do your work for you. So take home message is remember the red flags that I just showed you. Better to follow up the patient if there is any suspicion. Surface ablation is what I do most of the time if I have any suspicion in the suspected cases. Thank you so much.
Thank you, Dr. Vishal, for such a crisp and wonderful talk. We'll request Dr. Bindia to facilitate him and Dr. Aditya to be ready with the next talk. Yes, sir, please.
I think this is one of the best talk I've heard in 8 minutes to cover pentagram. It's really difficult.
Thank you.
You have explained the entire concept very nicely so that all the youngsters they can go back and read it and understand it better. And he rightly said that there is not just one map or one D which you should rely on. It's the final D which matters, and correlation with all the maps is very important. Yeah. So if you understand basics, that as he mentioned, how the data is displayed, from the best fit sphere, if the surface is steeper, it will go down, and if it's flatter, it will come up. You'll be able to understand all the maps very nicely.
Thank you, sir. Thank you.
Dr. Aditya.
So good morning. We cannot deny the fact that OCT has revolutionized the field of ophthalmology, especially in the management of macular degeneration, diabetic retinopathy, glaucoma. But with the advent of these higher wavelength OCTs, the cornea practice is also, it has become an indispensable tool in cornea practice. So to have a visually appealing outcome for both the surgeon as well as the patient, we need to know the details of the cornea and the ocular surface, angle anatomy, anterior chamber details, and lens status. So anterior segment OCT helps us, especially in cases where visualization is difficult, where cornea is a scar or haze. So in my practice, majority of cases are keratoconus treated by contact lens, DALC or C3R. Then for pseudophakic bullous keratopathy, we have endothelial keratoplasties. Corneal opacity is giving various vivid results, and then we have corneal infections. In corneal infections also, OCT helps in serial monitoring of the cases. Person doing refractive surgery, he should definitely use AIOS OCT because it gives you a complete flap parameters as well as vaulting in cases of ICL. So for keratoconus, there is no doubt that tomography is the gold standard for diagnosing a keratoconus. But with the newer OCT, now we have OCT-based tomographers like the one Anterion I use, which is showing high reproducibility as compared to the standard devices, as well as faster acquisition rate, which is less than 1 second. Along with that, when we see this case, like in this case, we can see there is a central thinning, as well as there is scarring due to old eye drops. So now this is like a real-time image. It is very easy for us to counsel the patient about the need to treat the case. As well as for me, I could go ahead that I don't have to try a big bubble, in this case a manual DALC will be preferable because otherwise this is going to rupture. Secondly, we as corneal surgeons come to see the periphery also, which is very important, where we have to trephine so that we can approximate the depth up to which we have to do the trephination. When it comes to miniscleral contact lens fitting for keratoconus, it can give us the vault, where we can measure is it not touching the cornea at any places in the periphery or in the centers. Secondly, like this case, the lady presented with irritation in the left eye. If we see slit lamp, it was appearing normal, but if we see on the AIOS OCT, we can see this hazy fluid. The tear is not clear. So I asked that lady to regularly replace her fluids. This way it helps us in picking up small details. Next to cataract, the only thing which gives wow effect is the endothelial keratoplasties. So, but they are not always easy because most of the times it's a result of a complicated surgery. And as a corneal surgeon who has to go for a DSEC or DMAC, we need to know the angle anatomy also, apart from the thickness. Because with the angles, if it is shallow angles, it helps us approximating the size of the grafts. as well as positioning our ports or incision, because if superiorly it is, there is a synecdoche, there is no point, approaching from that side. And sometimes the looks are deceptive. You see this picture, it looks like a total corneal opacity, but on ASOCT we can see that the stroma is totally clear. It's the hypertrophic epithelium which is the overlying. A DSEC was done and the patient is doing good. So in corneal opacities, like in these cases, it helps us tell that there is a synecdoche below. Then it helps us know the lens status also. This is a non-dilating pupil. You cannot make out because the technique for aphakic or a pseudophakic or phakic keratoplasty changes. So ASOCT becomes very useful in such cases to gather more and more information. Now this case, this case had anterior chamber reaction also, which is very well picked up on the ASOCT, and it is fibrin. It's a case of a chronic uveitis. I did a EDTA chelation for this BSK in this case. So the retinal surgeon was thinking to remove, but we saw the fibrin inside and we dropped the plan to intervene because there's no use. In corneal infections, it helps us monitor the case serially. This is a case of post-femtolasic fungal keratitis, positive on cultures. We can see this infiltrate here, as well as this area which correspond to this area. We can see there is a infiltrate on the stroma also, bed also. So a flap lift was done, antifungal wash was given, and it was started on antifungals. It healed very nicely. Now we can see a scar also, the healing scar. There is a difference. This is a diffuse kind of infiltrate, whereas the scars, they are like lamella packed and very demarcated. So this helps us monitor closely. It helps in explaining the patient also. We can show the patient what we are doing. For those who are doing refractive surgeries, yes, it gives you all the detail of parameters for the LASIK, for SMILE. You can watch, observe carefully. In ICL, we can get a vault height. Then we can, come to know about the wide to wide diameters. This all can be available on ASOCT. In DALC, we come to know about the residual stromal bed thickness. Then fluid and interface problems, if there is a visco entrapment or double anterior chamber, everything becomes very visible and we can mark the location where it is. For DSEC, apart from knowing the thickness of the graft, like in this case an ultra thin graft, 38 microns, we also can know about the area, what is its distance from the angle. Like in this case, if we see, I did a ultra thin DSEC, but it became too thin actually. You can see the DM here only. So this was a vitrectomized eyes. They are deep eyes usually. So air bubble don't stay. This graft is floating. So air rebubbling was done again, and the graft is very well opposed. The cornea started showing of resolution, and now I have made sure that it is away from the angles. In DMAC, it helps in resolution. We can observe the serial resolution of the cases. Along with that, very important thing in DMAC is it tells us the orientation of the graft. Now this graft is an inverted graft. It had to be replaced because the other graft, the normal graft is rolled upwards, which is the right orientation. So if we see this, I knew that this is an inverted graft, so I had to replace it. But had it OCT shows the other way, the rebubbling would have helped in this case. So to conclude, it is a must-have for surgeons doing refractive surgery or lamellar procedures. With the advent of OCT-based tomographer, it becomes a cost-effective tool also as a one-stop solution for practicing. And ICL, it helps us give the details of all the vault and everything. And even for cataract surgeons, if they have a OCT access, there are sometimes cases where there is, corneal edema. Corneal edema shows resolution fast on OCT before the vision improves. So it gives surgeon a confidence before thinking that it's a failure or the cornea is not healing. Thank you.
Thank you, Dr. Aditya, for such a wonderful talk. We'll request Dr. Monica to facilitate.
Yeah, very nice talk, Dr. Aditya. I think the resolution of anterior is amazing.
Yes.
Yeah. So we have older OCTs, Optoview and all those, but the entire eye is shown in one picture. It gives a lot of perspective. Yes. Yes. So are you using this to calculate white to white for ICL?
It's like 0.5, like for the pentacam and y to y to the digital also there is a 0.5 distance.
Yeah.
It is also good, but it's for the high.
Any questions? Yes.
Aditya, it was a wonderful talk, I would say. And it's not a question but a comment that interior segment OCT has come a long way. And now it has so many indications that we need a full symposium for it to be enumerated. I, being an ocular oncologist and an oculoplastic surgeon, in my specialty, all the ocular surface tumors as well as the conditions have a very big role of interior segment OCT, like for OSSNs and all. So you can see the invasiveness of the tumor even if after excision or before excision, and you can explain those patients that what are we going to look in for that. Sometimes you excise the tumor, you have that, because in those cases you cannot ask for the clearance of margins. Those are not the type of cases. But you can have to see that post-operatively whether you have a residual ocular surface and you need to treat it post-surgical intervention or not. So these type of things are very important. I'll be definitely asking you for my post-op cases.
There's a paper on that, sir, which shows that the epithelium changes in OSSN cases. There is a AIOS OCT based exam published in this.
Even for so many ciliary body melanoma.
I didn't have any case so I didn't put it.
That's fine. Just making a comment so that we know that there are so many other things we can look in for with this. It's a tool in our hand. Yeah, definitely. Wonderful presentation, and as you say, it's a wonderful pictures.
Hello. Good morning, everyone. So today we are going to discuss a very important and a very interesting topic where we are discussing the role of ray tracing. So what are we striving for these days in our private practice? I think a glass-free vision for our patients, and all the patients want it. So what do we do for that? Refractive surgery, maybe LASIK, ICL, whatever we are doing. And now a lot of presbyopic patients or the patients with cataract come to us and they say that we don't want glasses for near as well. We want the correction. So what is the option then? Premium IOLs. But such patients do have a lot great expectations. So what are the options we have? One of the options is ray tracing, which we are using in our practice. Basically, what is ray tracing? Ray tracing is a 5-in-1 instrument. It has wavefront barometer, it has a corneal topographer, it has an autorefractometer, autokeratometer, and a pupillometer as well. How does it work? It basically sends 256 sequential laser beams inside the eye, and then it depends how the beam ends and where it ends, and that is how ray tracing gives you the refractive error and aberration of the eye. Why do we need it in our practice? It tells us 4 important things which we use in our daily practice. First of all, it tells us the optic alignment measurement. Many other instruments also do, but this is one of the point. Then the other very important point is it tells us where is the actual problem is, whether it is on the cornea or in the lens. Then it is very important for LASIK, toric, or any premium IOL planning. And post-operative assessment. First of all, optic alignment measurement. It tells us what is angle alpha or angle kappa. Angle alpha is important for cataract surgeries. If the angle alpha is more than 0.5, then we don't recommend premium IOL to a patient. And if angle kappa is variable, then we have to do some settings in our LASIK machine so that it is not a decentered ablation. The other important thing which ray tracing tells us is it separates the optical components of the eye. For example, this is the chart, which is a root mean square chart of eye tracing, and these are the internal or lenticular abrasions, and these are the corneal abrasions, and this is the total abrasions of the eye. So it tells us where the actual problem is, whether the lens is affected or the cornea is affected, and what is the total vision a patient can get out of it. So, for example, this was a patient who came to us for LASIK surgery, a 26-year-old male with a refractive error of around 6 diopters. So when we did eye tracy, he was fit for LASIK, corneal topography was normal, everything was good. But when we did eye tracy, so what we saw was that patient had lenticular abrasions. If you see here clearly, the lens vision is also not clear. So we did go for LASIK, we didn't refuse the patient, but we explained the patient that even after getting LASIK surgery, there might be some compromise in the vision. So post-operatively, patient was prepared for it. So patient was a happy patient after the surgery. He didn't complain. The other thing which ray tracy tells us is dysfunctional lens syndrome. Basically, what is a dysfunctional lens syndrome? It is basically when a patient is ametropic earlier, but then he develops abrasion in the lens, maybe because of cataract or presbyopic changes, and so he develops refractive error. Ray tracy tells us exact amount of that in the terms of dysfunctional lens index. Lower the value of dysfunctional lens index, lower is the vision. So this is one more example where we can see that the DLI here is 3.97, which is low. That means the patient has low vision. And if we see, this is the lenticular vision, and it shows that lens has some abrasions, it can be cataract, anything, but the cornea is crystal clear. So in such patients, if we put a premium IOL, the patient is going to be a happy patient. The patient is not going to have any problem after surgery. But in this case, DLI is again low, that is 1.98, and the lens has abrasions, but the cornea is also not clear. So such patients are always questionable. Either explain to them that premium IOL is not going to, there is going to be some compromise even after premium IOL, or don't consider them for premium IOLs. Other thing what we can see in premium IOL planning in eye tracy is modulation transfer function. This is an option in ray tracy where we can see this graph and we see this red square along with this yellow line. If the red square fits inside the yellow line, like in the second picture, then the patient is a fit candidate for premium IOL. Otherwise, if the line touches the red square, then patient should not be considered for premium IOL without counseling. Toric precision is another very important point in ray tracy, and ray tracy helps in many points in toric IOLs. First of all, it uses wavefront guided K1, K2, whereas other of the machines which we usually use, they use SIMK. Other important thing what we can do for toric IOL is marking. We can always mark the important limbal vessels on the slit lamp, and then we can check the angle on the Osher's ring on eye tracy, as seen in the picture. Post-operatively, ray tracy helps us to check off-axis toric IOL and lens tilt. This is how it tells us an exact value of where the lens is placed and where it should be. And it also shows the amount of rotation we need to do for a toric enhancement. Like in this, we can see that if a 8-degree rotation is needed, it will cause only 0.21 diopter change, which is not a significant change, so the patient should not be planned for toric enhancement. But in the other case, 25-degree rotation, it causes a change of 3.72 diopters, which should be taken as a toric enhancement case. Sometimes you do nail it, and the toric is actually lying on position. How do we see a tilted IOL in ray tracy? Well, tilted IOL, if a patient comes to you and everything is good, but you don't find any cause, then ray tracy is a must thing. And you see a lenticular wavefront chart, and there you can see the green color in the center, warm colors on one side, and cold colors on one side. This is a typical presentation of tilted IOL, and this can be seen on ray tracy. So what are the benefits to the premium practice of ray tracy? It is an easy and rapid test to show doctor-patient vision problems. It locates where the vision problem is, whether it is cornea or the lens. We can explain prognosis of refractive surgery to the patient prior to the surgery, and so select the best IOL to use and plan the surgery accordingly. It verifies the results and checks the positioning of the IOL, and so solves most of the post-op problems, all to maximize the quality of the vision so that your patient can have a spectacle-free vision. Thank you.
Can I ask a question?
Yes.
Hi, Dr. Sapti. So, very nice presentation. So, in eye trace, basically, the ray tracing method that they are using, they are actually unable to give you internal aberration per se. It is a total minus corneal. Then you get those internal. Sometimes when we, as clinician, might say because the lens is the most aberrant part in our visual system, we might say that yes, it is because of the lens only, and we say yes, this is due to the lens. Even in your post-LASIK patient, it deteriorated. You have done the corneal surgery, it should not deteriorate at all. You saw the E chart, right? You saw the simulated vision chart. So it is the total aberrations of the eye minus the corneal aberrations. That is the internal aberration on the top left.
Yes, sir. Internal aberrations do include aberrations from the vitreous also.
Yes,
it does.
So everything.
Yes.
Also, it includes the surface behind your epithelium. So it is the corneal aberration which is the front.
Yes.
Then from that system behind the epithelium to the retina.
That are the internal aberrations.
That is the internal aberration. That's why the simulated ones, the E chart that you showed, it deteriorated in the internal ones more because it must be after post-LASIK surgery.
No, that was pre-LASIK.
No, post-LASIK. You see your E chart in the post-LASIK ones also.
Just show you.
Please be ready with your talk.
So I think that's how
all the aberrometers are doing like that only. They are not specific for the tissue. So we have to be very careful labeling them that they are only from
lenticular.
The lens.
Yeah, they are internal aberrations.
Yes,
true.
Yes, that's the point. Thank you.
Thank you.
Good morning everyone. Today's topic is the confocal and specular microscopy. First of all, specular microscopy. Specular microscopy is a diagnostic modality used for the imaging corneal endothelium. First, visualize the corneal endothelium by the slit lamp microscopy in the 1980 by the Vogt, and first described laboratory microscope in 1968 by David Morris. Coming to the optical principle of the specular microscopy, that is the based on the specular reflection, that is the angle of reflection is equal to angle of incidence. From the light incident on the corneal surface, some of the light is reflected, absorbed and transmitted. On the posterior surface of the cornea, some of light is reflected due to change in the refractive index at the endothelial aqueous interface, that is 0.02% from the incident light, that is captured by the specular microscope to form the image. Types contact and non-contact specular microscope. Contact microscope coupling agent is used between the objective lens and the cornea, hence applanate the cornea and enlarge the image. It is less comfortable to the patients, and non-contact microscope is just like autoref, automatic image focus technology, and image come from the curved surface, so image will be small and more comfortable to the patients. Human endothelial cells has a regular array of arrangement, the pattern showing the endothelial mosaic, and six-sided shape has greater surface area, has a more energy efficient, and due to aging, trauma and corneal diseases, endothelial cell density will be decreases. Coming to the specular scan, here the normal specular scan in the quantitative or qualitative analysis. In the next slide with the qualitative analysis, then first of all number of cells evaluated in this scan, that is the 227 in this image, and cell density is the number of endothelial cell present in 1 mm square of the area, and average cell area is the area of each cell measured in the mm square. Standard deviation is the standard deviation in cell area, and max or minimum is the area of the largest cell and area of the smallest cell. Qualitative analysis of the specular microscopy, and coefficient of variation is the amount of variation in the cell size, and that is normal is the less than 40%. Lower the CV indicate the uniformity of the cells, and increase in CV indicate the polymorphism. And HEX, the number of hexagonal cell counted in the total number of the cell in the scan, and variation in the cell shape is evaluated as the pleomorphism. As the age increases, endothelial cell density progressively decreases, and at the rate of the 0.6% per year. In this graph showing the age-related endothelial cell density. Coming to the analysis method of the specular scan, first of all the fixed frame analysis. Here the cell lying within a given cell area, and variable method analysis in the entire group of the border of the cells are analyzed. Corner method, each corner of the cells is analyzed. Center method, each center of the cells is analyzed, and centerplex, a visible border with area and center of the cells is analyzed, and last is the automated method. Clinical application of the specular microscopy from primary endothelial disorder and secondary corneal endothelial disorder. The Fuchs endothelial posterior polymorphous and iridocorneal endothelial syndrome. And secondary is the endothelial changes after the surgery, pseudoexfoliation, uveitis and endothelitis, and systemic condition like diabetes mellitus. Here is the diagram showing the Fuchs endothelial corneal dystrophy. First one diagram is the non-compliant hyporeflective areas of the shows the gutte, and second image the compliant increase in the number of the dropout cells in the compliant gutte, and cells density decreases in the second image, and also loss of the hexagonality of the cells. And this image is the posterior polymorphous dystrophy, round vesicles circumscribed as the elongated abnormal cells. And third one is the IC syndrome. Here is the pattern of endothelial reversal pattern. Cell border are the white and inside the black. A diagram of the endothelial cells specular scan in the post DSEC. Here is the slit lamp picture of the cornea, and in specular scan reduction in the cell density and also variation in the cell size and the shape. And pseudophakic eye with the anterior uveitis, this is a hyporeflective area, shows the endothelial pigment and swollen endothelial cells known as pseudoguttae. These are confirmed by the after improvement of the uveitis, there is a resolution of the pseudoguttae, also improvement in the cell size and the shape. Here is the systemic condition, diabetes mellitus, change in the size and shape of the cells in diabetic cornea. Specular microscopy gives only information about the morphological status and to assess the endothelial status and serial follow-ups. And the second is the confocal microscope. Types of the confocal microscopy: tandem scanning based and scanning slit confocal microscopy and laser scanning. Nowadays laser scanning confocal microscopy is used. Principle based on the confocal design, that is illumination and detection part have the same focal plane. From the laser light source, reflected light focus on the one point object through the pinhole aperture, and reflected beam are separated by the beam splitter, that is detect through the photosensitive detector through the second confocal diaphragm, and image formation at the focal plane. A basis of the image formation based on the back scattering of the light. Coming to the clinical application of the confocal microscopy for the detection of the corneal pathology and pre and post surgical evaluation like refractive surgery, corneal cross linkings, and microscopic examination of ocular surface like ocular surface neoplasia, and for diagnosis of the infectious keratitis. Here is the normal epithelium of the confocal microscopy, superficial, intermediate and basal cells. Here is the disease epithelium in case of keratoconjunctivitis sicca. Here is the epithelial cell metaplasia. The normal corneal stroma of the confocal microscopy containing the keratocytes and cell nucleus density and stromal nerves. Is the normal stromal nerve that is thickened in case of the neurofibromatosis. Other cases of the keratoconus and amyloidosis. The corneal innervation after the refractive surgery. Confocal image after the LASIK at the 6 month. Corneal nerve seen in the confocal microscopy. Here is the corneal infiltration, absence of cellular or structural element in the defect area, in contact lens wearer. Confocal image of the hyperreflective rounded cyst in case of acanthamoeba keratitis and fungal keratitis. Filamentous hyphae seen in the confocal microscope. Thank you.
Thank you, Dr. Anita, for such an informative talk on such a difficult topic. We'll request Dr. Narendra Taneja sir to facilitate Dr. Anita. And Dr. Anchal, please be ready with your next talk. Sir, any comment?
Yeah, so Dr. Anita very nicely covered each and everything about specular. So I have specular microscope for last 12 years with me, and we do specular microscopy of each and every cataract patient. And it saves us many a times, because we have 40% of our cases which have hard cataract, black cataract, brown cataract, and you don't have a clue what's happening to the endothelium. So it's our practice to do specular of each and every patient. And we take all precaution if they have less CD, that of course we explain to them. So that is the biggest thing. So, and then we use viscoelastic which protects endothelium, video like this. So we can plan accordingly if we know the exact status of the endothelium. Yeah. So next we have Dr. Anchal.
Good morning everyone. Myself Dr. Anchal. My topic for the today is a toolkit for dry eye assessment. So as we know that it is a multifactorial disease that will affecting the tear film. It will lead on to discomfort, the visual disturbance, and ultimately lead on to the tear film instability and various inflammations of the ocular surface. So there are certain clinical diagnostic tests which will coming in the categories of like first is a measurement of tear secretion, then measurement of tear film stability, then measurement of tear film integrity, and then various laboratory and other tests. So based on measurement of tear secretion, we have these tests like Schirmer 1, 2 and 3 test, then John basic secretion test, then we have cotton thread test, then phenol red impregnated test and fluorescein clearance test and tear function test. So the first test is Schirmer strip test, which generally involve the Whitman 41 filter paper having a length of 5 into 35 mm, and it is generally folded at the length of approximately 5 mm. In Schirmer 1 test, it is generally placed in the lower fornix at the level of a medial 2/3 and 1/3 medial lower eyelid junctions, and it basically measures the basic and the reflex secretion of the tears. So after 5 minutes it is being taken out. So reading more than 15 mm it is considered normal, and less than below the 15 mm we have suspect the dry eye, and less than 5 mm it is confirmed the dry eye. So basic secretion generally measure the basic tear secretion where we are using the topical anesthesia. In Schirmer 2 test, it measures the reflex tear secretion where we are not using any anesthesia. Here the nasal mucosa is being irritated with the cotton swab, and wetting of the filter paper is being noted after the 2 minutes. So wetting more than 15 mm is considered normal, and below that we suspect some dry eye conditions. So based on that we have Schirmer 1 where there is a stimulation of conjunctiva, and in 2 we have nasal stimulation. In Schirmer 3 patient is asked to look directly into the sun where it will lead on to the retinal stimulation. So it will measure the reflex secretion of the tear. These are the findings. So with age, the tear secretion goes on decreasing. Up to 30 years, there will be wetting of approximately 20 mm filter paper into 5 minutes, and as the age advances, like above 50 years, it will lead on to only 10 mm. So there will be dry will be increasing as the age advances. Another test is a fluorescein clearance test, where we will measure the amount of the fluorescein which will remain in the eye. So basically it will measure the tear turnover rate, which is very important, as tear turnover will help in removing the inflammatory cytokines. It will provide the fresh supply of the growth factors. So if there is a delay clearance of the tear, that will strongly correlate with some ocular surface symptoms, some irritations, and that will lead on to some inadequate aqueous tear production. So basically in this test we are using the fluorescein, approximately 3 microliter, which is being placed in the conjunctival sac, and then tear turnover rate is being determined by estimating the residual fluorescein which will remain in the tear. So this is basically measured with the help of either first is Schirmer strip that will collect the fluorescein stain smear, second with the help of the fluorophotometer, which will with the help of the microtube we just take out the fluorescein after 20 minutes, and then residual fluorescein is being calculated. So in normal condition it is approximately 22.4 nanogram per ml. As the dry eye increases, like in grade 3, it will reach up to 1479 nanogram per ml. Another test is a phenol red thread test, where we are using the cotton thread which is impregnated with the phenol, which is basically pH sensitive. So in contact with the tear, it will convert its color from yellow to red. So basically it is a 75 mm long cotton thread commonly used. So normal it is more than 16 mm in 15 seconds, and less than that, that is less than 6 mm, it will lead on to dry eye. Now another test is measurement of tear film integrity, which will include various vital staining. So first common staining is the sodium fluorescein. So normal cornea will resist any type of staining due to the high lipid content, but if there is any tear film irregularity or any corneal epithelial defect, so it will take on the stain. So sodium fluorescein, it will generally we are using 0.25 to 2% solution. So after staining the person, patient is mainly asked to sit on the slit lamp, and with the help of the blue light, it will color change into the green, and various epithelial defect is being noted. Another stain is a rose Bengal stain, which will stain conjunctiva more than that of the cornea, and it will stain more dead and devitalized epithelial cells, plus stain the mucous threads, the filaments and the threads. One of its disadvantages is that it is very toxic, and it will lead on to the decrease in the cell vitality and the motility, and ultimately lead on to the cell death. Also it will causes the ocular discomfort. So prior using this, anesthesia is being used. So scoring according that 0 staging represent absent staining, and as the stage increases, there will be increased chances of any ocular integrity discontinuity. So these are the staining patterns, various grading, like for the cornea fluorescein. So more than the 3 out of the 15 sectors is being taken, and in conjunctiva, where rose Bengal will be there, more than 3 out of the 18 sectors is being calculated. Then we have Lissamine green stain, which have the same pattern as that of the rose Bengal, but it is much less irritative. So score 5 indicate diagnosis when is Sjogren's syndrome. These are the Lissamine green staining pattern. So sodium fluorescein commonly seen under the cobalt blue light, where rose Bengal commonly seen under the white light under high illumination. Also the Lissamine green will see in the white light under the low illumination. Then we have measurement of the tear film stability, which will measure the tear film breakup time. So it is a time interval between the complete blink and appearance of the first black spots on the cornea. So these are the dry spots basically we are seeing. So according to that, there are certain breaks which are appearing on the cornea. First we have area break that will indicate severe deficiency. Then we have a spots break that also indicates some advocacy in the wetting of the eye. Then we have some this line break and the dimple break that will indicate some mild to moderate deficiency of the tear. And we have random break that also increase that there is some increased evaporation. Then after that we have a keratography, which also measure the tear film breakup time, the tear meniscus height, lipid layer and particle. But it is non-invasive and very quick procedure. It basically uses a software which really take an image of the full this meibomian glands, and it will 3D display the meibomian gland in both upper and the lower eyelid. Then we have certain laboratory and other tests where we are using the tear film osmolarity test. Here we are with the help of the micropipette, we are just collecting the tear from the lower side, and normal range is in the 295 to 309 milliosmol per liter. So in severe cases it is more than 323 milliosmol per liter. So this is show the osmometer, where we are using the we are collecting the sample from the lower eyelid, and then we are recording the samples. Then this is an enzyme analysis. The lysozyme, which is one of the most important, approximately 20 to 40%, it will consider most of the tear protein. And in case of dry eye, its concentration goes on decreasing. Then this mebography, where we take a 3D image, the photography of the meibomian glands. It is basically discovered by the TAFE. So we have two types. It will be based on the two types, like contact and the non-contact. Contact mebography, it was developed in the late 1970s. We are just using the probe, and it will directly come in contact with the lower eyelid and take the image of the meibomian glands. Whereas in non-contact, which was developed in the 2008, there's infrared coupled devices being used and take the image of the mebography. These are the one. Generally, in normal case, the meibomian glands will cover more of the tarsal plate, but as a grading will be increasing light toward the dry eye, the meibomian glands they are shortened, they are shrunken, and there is increase in the tortuosity of the gland as the stage advances. So these are the points to be kept in mind, like increased tortuosity. In grade 4, as in advanced case, it will become shortened and shrunken, and there is absence of the meibomian gland in some part.
Thank you, Dr. Anchal. Thank you for a wonderful talk. We request Dr. Vishal to please facilitate Dr. Anchal. And Dr. Ravi Trehan sir to further facilitate all the panelists. We will request inauguration team to be ready. Dr. Narendra Taneja, Dr. Vishal Arora, Dr. Bindya Dhupar, Dr. Mansi Jindal, Dr. Monica, starting with the inauguration, and we are just waiting for our dignitaries. Till then, I will request Dr. Manisha ma'am.
Class member as observer standing delegate.
Sir, please.
Good morning, everyone. On behalf of Sirsa Ophthalmological Society, I, Dr. Yuvika, welcome all of you to this academic feast. We are grateful to Dr. Prashant Bhavan sir for giving us the opportunity to organize this national level symposium by AIOS ARC the theme on diagnostics in ophthalmology. It's our great privilege to hold this symposium in Sirsa under the aegis of Haryana Ophthalmological Society. We could not have done it without Dr. Manisha Nada ma'am and all other office bearers of Haryana Ophthalmological Society. We thank you all for trusting and supporting us. We also extend our thanks to Dr. Tinku Bali, who is member of ARC North Zone. We are thankful to Haryana Medical Council for giving us 3 CME credit hours. So, a warm welcome to all the distinguished guests, esteemed faculty and delegates who have come all the way to be part of this symposium. So, we'll start today's program with Saraswati Vandana, followed by lamp lighting. So, I request the dignitaries to please come forward. So I request the dignitaries to please come forward and light the lamp. So we have Dr. Ved Beniwal amongst us. So please come forward. Dr. Prashant Bhavan, Dr. Tinku Bali. Is ma'am around? Dr. Manisha Nada ma'am, Dr. Markinda Ahuja sir, Dr. Indamohan Rastogi sir, Dr. Rajan Gupta, Dr. Dheeraj, Dr. Chand Singh Dhul, so please, Dr. Taneja, we have national like Dr. Harshal Tak and Dr. Arvind Moria. So please come forward for the lamp lighting. And we have HOD Dr. Manpreet from Batinda. Sorry, Dr. Rajvinder from Batinda. Dr. Praveen Arora, President of Sirsa Ophthalmological Society, and Dr. Mahit Bansal, Secretary Sirsa Ophthalmological Society.
श्री मेरा जो
दो तीन इधर आ जाएंगे. डॉक्टर ढुल इधर प्लीज.
डॉक्टर वेद बेनीवाल क्या
ये बुलवाएंगे दिल्ली में खतरनाक. डॉक्टर साहब थोड़ा ऐसे खतरनाक डॉक्टर साहब लाइट क्या डॉक्टर डॉक्टर आई एम ऐसे डॉक्टर प्रवीण को डॉक्टर बेनीवाल बेनीवाल ठीक है यस Yes, doctor. Please turn.
सर ट्रेजरर पीओएस को बुलाओ ना, आ जाना. ये ट्रेजरर पीओएस एक मिनट ये तो हमारा प्रॉब्लम अरे बहुत सारे ये देखो ये बात ट्रेजरर वाला बना आज कहाँ से लेनी है बता दो तो. हाँ भाई दस्तगी भाई दस्तगी भी
एक सभी ऐसे ग्रुप हो जाएगा. डॉक्टर साहब थैंक यू. ऐसे पीछे डॉक्टर मही Thank you.
Thank you all. I request all of you to please take your seats, and I would request Dr. Ved Beni back. We will now proceed to the facilitation ceremony of our dignitaries. So it's a token of love and affection. I request Dr. Ved Beniwal sir to do the honors. I invite Dr. Prashant Bhavankule to please come to the stage. He is President and Chairman AIOS ARC. Dr. Prashant Bhavankule sir, please. To receive the memento. Sorry for the glitch.
साउंड भी लगा दे, ध्यान ना डिग ना पवे, साउंड वाली तार भी लगा दे। तू भी कर ले, मैं भी कर लूँ। यस डॉक्टर साहब।
Dr. Tinku Bali, okay. Has she arrived? No. Dr. Manisha Nana, she is president of the Ophthalmological Society. I request Dr. Praveen Arora sir to please accompany.
पहले ही उनसे कर लेगा फोकस में। यस
Dr. Markandeya Ahuja. Dr. Indu Rastogi, he is General Secretary, Haryana Ophthalmological Society.
कोई नहीं, कोई ला दे। Yes. Thank you.
Dr. Rajan Gupta, he is Treasurer, Haryana Ophthalmological Society.
किथे लाई सी गई?
Dr. Dheeraj Gupta, he is Joint Secretary, Haryana Ophthalmological Society.
इथे लगा ले, हाँ किथे है? Yes, doctor.
Dr. Praveen Arora is President, Sirsa Ophthalmological Society. And next we have Dr. Mahik Bansal, Secretary, Sirsa Ophthalmological Society.
किथे बबलू? लेवल भी नहीं है।
लेवल तो आ रहे हैं। लेवल तो आ रहे हैं।
लेवल आ रहे हैं।
Thank you, sir. Now I request our worthy chairman, Dr. Prashant Bhawankule, to do the honors to Dr. Ved Beniwal. He is patron IMA Haryana. He has been ex-member of Haryana Medical Council. We are lucky to have Dr. Ved Beniwal with us.
Sir.
So please stay back. We have Dr. Tinku Bali with us. Dr. Harshul Tak, I would like to invite Dr. Harshul Tak on stage. He has come all the way for this symposium.
नहीं वैसे ही नहीं आ रही ना। सर। My favorite. I believe this.
थोड़ा पीछे रहेगा। पत्ता बड़ा लगा।
जा रही है।
Thank you. So I hand over the stage to Dr. Amit Vasal.
Now we are going to start with our retina session, and that is instruments used in posterior segment evaluation. Invite Dr. Prashant Pavankule sir to kindly chair this session. Sir, you are invited. Please come over, sir. Dr. Rajvinder Kaur, Dr. Tinku Bali ma'am, Dr. Raman Mittal, Dr. Manisha Nada, and Dr. Gaurav. Dr. Gaurav Mangla, kindly come over as a panelist. पहले करवा लो, डाउनलोड तो करवा दो. प्लीज बैठिए Now I call upon Dr. Manisha Nada ma'am to kindly come for the session, the third session. We are going to start with the third session.
पीछे जाओ, पीछे अल्ट्रासोनोग्राफी या फोल्डर में इसमें ऑर्बिटल बी स्कैन नंबर 1
मेरी टॉक है ना उधर चली लास्ट में. इसका कहाँ से आ गया टॉक? हाँ, इसका बाद में है.
Now I call upon Dr. Kanshuk Marwaha to kindly come up for the presentation. This is binocular indirect ophthalmoscopy and slit lamp diagnostics and the lenses to use in clinical practices and advances. Dr. Kanshuk.
A very good afternoon, and thank you the Haryana Ophthalmic Society, All India Ophthalmic Society, and all the esteemed panelists. And I'm going to start my talk on tips and tricks of clinical examinations. So basically, I am going to start on BIO lenses firstly, then slit lamp lenses, gonio lenses. It is just an overview of the things that we are using in our routine day-to-day practice. So choosing the right lens design, why that asphericity is important, because as you can see that the image distortion is the least when we have both sides tapered, which is the double aspheric design of the indirect ophthalmic lenses. So nowadays the lenses which are coming have an anti-reflective coating. So on the left side you see a lot of Purkinje images and on the lens. So always choose your lens which has least amount of reflections. So coming to the diagnostic lenses, so what is important as we start with our BIO lenses is the trick that we learned in our PG is always start doing our indirect from the temporal side, because that's the most easiest to do. And I always tell my colleagues to, who are interested in learning this art of indirect ophthalmoscopy to start from the temporal, because it's easier to start from there and then you further move on the various clock directions. Pointing the silver lining of the lenses towards the patient, and you can make it out where the images are right. So now coming to choosing the various type of lenses, we have a lot of lenses with various numbers, so that confuses us. So just a simple trick to remember is that higher diopter means lower image magnification and a lower working distance. and a wider field of view. So this thing one should remember. So as the diopter goes on to the lower side, you have a higher image magnification. So when you are having magnification, you are compromising on the field of view. So BioLens comparisons are here. You can see on the extreme right hand side is a 40 diopter lens. So I've used 40 diopter lenses, but in those lenses the image is so small that to make out details is very difficult. So routinely used lenses are 20 and 28 diopter lenses. So but nowadays I prefer to use a pan-retinal 2.2 because it gives a more field of view compared to a normal 20 diopter lens. So I would suggest that who are the PGs to make a note of this and prefer to use a pan-retinal. That is better for initial also, because once the lens you take, it goes on for more time. So these are the images which I have taken from a BIO lenses. The above one is a papilledema patient, and she was referred, and the other one is of a Ozurdex implant in the eye. These are all taken through the BIO lenses. The lower image is basically just to show that the image is inverted and laterally inverted, and the other one is also through a mobile camera, and I've collated the image, and it's a proliferative diabetic retinopathy image which requires urgent laser treatment. So India is the diabetic capital of the world, and now all of us have advanced cameras, and so taking image through various gadgets, MRI retinal device is very common, and this is another case of proliferative diabetic retinopathy. And the scleral indentation also is quite important in our day-to-day practice, because most of us here are refractive surgeons, and we require to check the retina. And through the indentation one can actually look at the lattice with the holes, and there's another hole there. And even if you are good enough, you can actually go and look to beyond the aura to the pars plana. So the last image which is being shown is aura, as well as the pars plana image is also shown on the. This is another image of the horseshoe tear. And so that warrants an immediate laser treatment. So whenever you see a horseshoe tear, you have to laser. So the marking is done by the blue sign. So that is the HST. So there are next generation lenses. What is different is that it's just a fancy name for a better HD quality image. So it is, if you call a digital clear field, it's the next generation 20D or a 2.2, and digital clear mag is 14D or 15D. So most of us use digital clear field 20 or 2.2. Now coming to the pediatric lenses, I'm using mostly 28 diopter lens in my day-to-day practice, and on the left hand side you see a lasered ROP being captured on this thing, and the second image is showing a pediatric retina evaluation, and the other one is a hemorrhage in a newborn which is being shown at the posterior pole. And this is my day-to-day practice in the NICU in various hospitals. And this is just a summary of the biolenses and the field of view. If you look at the charts, whenever it is given to you, so like the macula plus shows 36 degree and 43 degrees, that means that central view is 36 degree, but you can actually look up to 43 degrees by asking the patient to look in various directions. So the diagnostic lenses we usually use are 78 and the 90 diopter lens routinely. We always start with the 90 diopter lens. But nowadays I use both of them in my day-to-day practice, because I need to look closely at the optic nerve as well as the macula. So, and there are other next generation slit lamp lenses. Here I would just like to highlight the suprapupil XL, especially our glaucoma colleagues. Here through suprapupil XL one can actually look through a 1 mm pupil also, and the optic nerve is seen very clearly. So this is one thing. And similarly the digital means that it is a HD kind of a quality. So digital high mag means like almost like a 60D. So these are the comparisons of the various slit lamp images. So as the field of view increases in the digital wide field, the image becomes smaller. So that is one has to remember. So just to make it clinically more interesting, so these are the images in a 78 diopter. Above left one is with the coloboma. Here you can see the optic nerve very clearly. In the lower one is the 90 diopter image. You can just see up to the edge of the coloboma. And the other one on the middle screen is the digital wide field, where I have done a laser, and you can see the lowermost part of the coloboma. So, that is the advantage of a digital wide field, that you can actually, look quite far. And the last image is of a blunt trauma, and the patient has a choroidal rupture. It's in the concentric lines along the optic nerve. So there is another fancy thing which has come is ClearPod. Actually, these have a marking, and they actually tell the right distance which you have to keep from the eye. So as a beginner, it is sometimes useful for people who are starting. And here is another image of a magnification versus the field of view. So as you move towards more field of view, your magnification decreases. So finishing the last in the bucket, gonio lenses. So the most important thing is the contact element. So usually you have to, when we are taking a contact lens, is with the flange and without a flange. So without a flange, you are able to do the indentation. So this one on the left hand side is a flange lens. So there you need a coupling medium. On the right side is a no flange contact, which can help us to do indentation in the gonioscopy. So these are just the images of the 4-mirror. So 4-mirror is the ideal suited for the indentation of the angle. So just coming up, what we have to take care of our lenses, that we have to, like, whatever lenses I'm using, which I bought in my PG, are still being used. It's been 17 years and I still have the same lens. It is about you cleaning your lens. It should be kept in the right place in your case always, and always handled with the rim, not touch on the lens, which can cause scratches on the lens. So these are other new things which have come, which is the digital video recorder. So through which we can actually record through the indirect the images.
Dr. Kanshuk,
so this is just a last video I'm just showing. That's it. I'm going to close it. This is a video through the video indirect, and these are the laser marks which are being seen. So it is just a 10-second video which is there of the indirect. Because starting the screen is magnified, the marks are slightly on a brighter side, but this is how it is shown on the recording. So this is another mobile-based recording system. There is the VistaView, then there is MII by Dr. Ashish, which is there, and it is quite easy to use. And these are the images now, the rate-free images. Now you can take it through your mobile, which is much more easier to do. So now I think it's a world of telemedicine where patients are asking us all the reports on the phone. Now people will be sending us by taking images through these gadgets and asking what is the stage of diabetic retinopathy. So we have to move forward in that direction. Everyone has a very high quality mobile in their hands with so much of HD images. So that can be used very well. So this is just a thought to share that our PGs can also take images through their mobile phones also. So nowadays, earlier we used to have black lenses only. Now there are colored lenses, so which is yours. So that's it. Thank you for this opportunity.
Very nice talk, Dr. Kanshuk. We'll be taking the questions in the discussion.
Sure. Thank you.
Okay. Now call upon Dr. Rajvinder to kindly give the presentation on fundus camera and advances in fundus photography.
I want to thank Haryana Ophthalmological Society for giving me this opportunity, and All India Ophthalmological Society ARC program. Thank you. So the topic of my presentation is fundus camera. So the principles of commonly used fundus camera we are going to discuss, review the clinical significance of fundus photography, the technique and personal involved in fundus photography. So this method, that is the indirect ophthalmoscopy with the indirect ophthalmoscope and fundus drawing, will stay. Whatever comes, but it will stay. It is gold standard when we don't have anything. So it was there, but we cannot replace this method with the advances. So now after that the fundus camera came in 1886. It was discovered Jackman and Webster when they took the first fundus photograph, and it usually utilizes the principle of indirect ophthalmoscopy. So fundus photography, when we do not know anything, we should take the photograph. When we know anything and we want to search on it, we should take the photograph. So anything should be documented. Whenever we are in research institutes, so we have to take for the fundus photography for the research purpose. But for documentation, it is very necessary in this era. So taking the image of the retina of the eye with the fundus camera, it is conventional. It captures 30 to 45 degree of the field. And it is analog to digital, that is higher resolution, magnification. We can take the color photograph autofluorescence, we can do the fundus fluorescein angiography and ICG in a single machine. And there are so many filters. What is less talked about is the filters. Red, green, blue filter. So what are the indications? Vitreoretinal diseases like diabetic retinopathy, age-related macular degeneration, retinal vein occlusions and dystrophies, ROP and tumors of eye. So in this scenario, we can document the optic disc damage also. When we are following the patient for progression or the stability of the glaucoma, we can show our patients that your glaucoma is progressing. Now the posterior uveitis cases which are less seen, we can document it like vasculitis, chorioretinitis and choroidal granuloma, which are also rare. Arteritic, ischemic optic neuropathy, morning glory syndrome and optic atrophy. So this is the patient in which the fundus photograph was taken. The patient had the dengue. So he came with the sudden decrease in the vision. So we can show him in the picture that this is the scenario and it will go in few days. Nothing to worry. So documentation is important. It is the objective evaluation of the fundus, not dependent on the observer, can go back and re-verify the findings. So whenever we see things for the first time, we can always discuss with our seniors or with our colleagues. So it is a great method to discuss, less time consuming. And these are the few fundus photographs. In first picture, we can see the partial central retinal artery occlusion. This was a picture taken in the COVID era in a case of mucormycosis. Then it is a Valsalva retinopathy and retinitis pigmentosa. So in these patients, it is very difficult to counsel the relatives of the patient in retinitis pigmentosa. So we can always counsel them by showing them with the pictures. So these are the other views. The first picture is taken in the that is a very sick baby child in a pediatric intensive care unit with the we can see the exudation in the macular area. And the next picture is the coloboma involving the that is type 5 of the coloboma. And in the BRVO we can take the picture of the interest image. Suppose in this we can see that is a spironasal, we are looking for the BRVO. So we can document there. So when a filter of single color is used to change the illumination into the patient's eye by altering the wavelength. So the green light, when we are suspecting there is a retinal vascular occlusion or RNFL defect, we can always document it with the green filter. When the blue light provides the optimal visualization of the vitreoretinal interface abnormalities. And red filter highlights the choroidal disturbances. So red free filter fundus photography enables the excellent view of the retina as peak spectral sensitivity of human eye falls in the green-yellow range of the spectrum. So in the children's patients with higher myopia and low vision. And also here RNFL damage secondary to glaucoma. So better in detection, that is IRMA, NVE, NVD, vitreoretinal interface abnormalities, complex vitreal phalanges and hereditary vitreoretinal degenerations. So we can experiment with these filters. So always try to, after the color fundus photography, take the photographs with the filters. So we can see the vascular lesions, like in the NVD it is more clear now. It is visible in the fundus picture also, but we can document in the green filter also. So we can the pattern lines secondary to that is papilledema and the fundus autofluorescence. So it usually works on the that is fluorophores, lipofuscin and melanin. So lipofuscin is the fusion is the byproduct of the lysosomal breakdown of outer photoreceptor segment within the RPE. So it is very helpful in the that is the fundus dystrophies. So we can always document like the Stargardt disease, these pictures, fundus autofluorescence. So in the that is near infrared images which can be taken from the they are also in the OCT also. So we can experiment with these pictures. So this is a picture patient of the young female which has the hypertensive choroidopathy in a pregnant female. So I experiment with all the pictures and we can see in NIR it is showing very beautifully the choroidopathy. So we can use autofluorescence in central serous chorioretinopathy, ARMD, retinal dystrophies and the choroiditis. So this is a patient with the choroidal granuloma and which is also showing the that is a subretinal fluid. So I experiment with the pictures, and we also documented this case showing the multimodal imaging. So the traditional camera, the traditional fundus camera, 30 degree to 40 degree, it can be shown with the traditional fundus camera, the central picture. But with the ETDRS, the 7 standard fields, they came in. And now we can that is take 75 degree of the retina. So these are the few montage pictures. First picture is the choroidal osteoma with the focal choroidal excavation and choroidal neovascular membrane. The second is the BRV or secondary to the vasculitis. So the posterior pole. In the fundus photography, we can document up to 50 degree. And mid periphery, that is with the montages, we can take up from the 60 degree to 100 degree. But now what is ultra field and wild field? The wild field, when we can take the pictures up to the vertex veins, posterior to the vertex veins, that is the wild field. And previously the interchangeable, the names were given. Now whenever we can see anterior to the vertex veins, that is the ultra wild field. So here we can compare all the fundus cameras, and in optos there are pseudo colors, but in the Claris there are true colors. So we can see that is the confocal scanning laser ophthalmoscopy. It will be covered in the subsequent lectures, so I am not going to detail. And the previous speaker has already shown the smartphone based fundus photography. So these are the few fundus which are taken in the that is outreach program. So I am not going to cover it. Then RETCAM and my MR RETCAM, they are also will be discussed in the subsequent lecture. Thank you.
Kindly wrap up. Yeah. Thank you, Dr. Rajinder. Very nice and elaborative talk. Now I call upon Dr. Salil to kindly present on fundus fluorescein angiography.
Well, so good afternoon, everybody. So moving ahead with the fundus photography, the next step is the angiography. So the sodium fluorescein was first synthesized by Mr. John Bayer, and it was introduced in ophthalmic imaging in 1961. So just a few points to remember. We work on a principle of fluorescence. The principle works because there is absorption of light in the range of 465 to 490 nanometers and excitation at 520 to 530 nanometers. The 80% of the dye gets bound to the plasma proteins, and it is only the 20% dye that you inject that helps you in the fluorescein, and it is metabolized by the liver and the kidneys. Now just brief about the relevant anatomy. Retinal vessels, they are non-fenestrated and they maintain the inner blood retinal barrier. In contrast, the choriocapillaries, they are fenestrated, which allows your fluorescein extravasation and diffusion through the Brooks membrane. And the outer retinal barrier of the choroid is maintained by the tight junction at the level of the retinal pigment epithelium. So technique we know, let's go to the thing. So once you inject the dye, approximately I use 5 ml of 20% fluorescein, which is given in either in the antecubital vein or any other vein which is good enough to sustain your cannula. So the first thing you would see when you inject a dye with the choroidal phase, first of all the the dye enters into the choroidal vessels, and as I said, these are leaky, so you get a flush-like thing. Then you get an arterial phase within maybe around 10 to 14 seconds. The dye enters into the major arteries, retinal arteries, and you can easily capture them. After another 2-3 seconds, your veins start filling. So initially the veins show a laminar flow. As we know, the blood flow in the veins is slightly slower. So initially what you will see, the vessel edges, and then your lumen starts filling. Now this AV phase is very good time to check on the macular area for the angiography. Then comes in the midvenous phase when the the dye fills up the total veins, and you get the best of the capillaries is imaged at this time. In the late venous phase, you start seeing that the arteries start emptying, and this is a phase when And then you come to the late phase. This is a time when you start seeing for whether the dye is having leakage or pooling or it is staining the lesions. So this is what you see on a typical sheet. So from the first you take a photograph of the anterior segment, then a fundus photograph, and you subsequently from 1 to around 17 to 20 seconds, 25 seconds, you'll get the late venous phase, and then at the late phase you can take it around 100 to 120 seconds. So now the question comes, you have done the angiography, so how do you interpret it? So the major things you have to see in interpretation is what is the anatomical location and the depth of lesions you are looking for, and whether you have a hyperfluorescence or a hypofluorescence, or is it a pseudofluorescence or the autofluorescence. So when we are talking about the hyperfluorescence can be just a blocked retinal fluorescence, that is a masking, which could be because of any media opacity or any vitreous opacification or a subhighlight hemorrhage or an intraretinal pathology. So just few examples. Now this is a subhighlight hemorrhage which is causing a blocked fluorescence. Here you have optic disc melanoma which is blocking the fluorescence of your optic nerve head. Then you could have a blocked fluorescence of your choroidal vessels, which could be because of any outer retinal pathology or a subretinal pathology or a subretinal pigment epithelium or choroidal pathology. Few examples. Now this is a patient of peripheral telangiectasia where you see the pigmentation has blocked the fluorescence of the choroidal vessels in the center. Then intraretinal blood. Again, this is a patient of BRVO, and you see a lot of blocked fluorescence over there. Then this is a patient with subretinal gliotic bands. So again, these things will not, this will block your choroidal fluorescence. Or you can have sometimes a combination. You could have a blocked fluorescence, or along with that you could have a capillary non-perfusion also. So this will deal later on. Then vascular filling defects. Vascular filling defects can occur at the 3 levels: retinal, choroidal, or optic nerve head. So when we are talking about the retinal, the major thing you are looking out is either a central retinal artery or a vein occlusion, right? Then as we know, the central retinal occlusions, the dye will not come in you will have a very long choroidal phase. But in the recirculation phase, later on, the dye might enter the vessels. But in the case of a CRVO, you will have convoluted vessels. These vessels seems to be a lot of tortuous, and you will have a lot of blocked fluorescence along with the leaking vessel in the later phase. Now, this is a patient where you have a capillary non-perfusion, secondary to diabetes, venous occlusion, etc. And you, along with the blocked fluorescence, here you also see some leaking vessels and staining, which in subsequent slides will go forward. So now here lies the importance of the timing which we talked. Now this is a patient of venous stasis retinopathy, right? Seeing everything looks good. There is no leakage, the dye is entering, there is no pooling, nothing. But if you see, if you have timed it, sorry I have not put a timer over here, but if I had timed it, so the dye enters into the circulation, into the retinal circulation or the choroidal circulation late as compared to the normal. So it is approximately more than 10 seconds to 12 seconds when we label it as a venous stasis retinopathy. Now this is a case of a BRVO where you have a lot of capillary non-perfusion areas. So now coming to the choroidal vascular defects, which could be because of the occlusion of the large choroidal vessels or atrophy of the absence of the choroidal vessels. So the vessels are absent in that area. Now this is a case of a BRAO involving the macular area. So you can see the choroidal vessel vasculature is not seen as in a triangular way. Now here you can see there is an absence of the choroidal tissue at all, so you can't see the vessels of the choroidal. Now this is a patient who had an optic nerve AION. So again here the vasculature is not filled with the fluorescein. Coming to the hyperfluorescence, autofluorescence has been discussed. Let's take window defects like bullseye maculopathy. You see more of the choroidal vasculature in the bullseye maculopathy and in macular hole. You could have abnormal vessels like in retina. You could say angiomas or Weber-Mason syndrome. There is a patient of choroidal neovascularization, choroidal hemangioma, where you can see a lot of hyperfluorescence in a very delineated manner. This is a patient of CNVM. You could see a hyperfluorescence in the late stage and the membrane getting stained over there. On the optic nerve, you could have a leakage, like you have retinal vessels like phlebitis or a neovascularization. Now, this is a patient who has phlebitis and along with that vasculitis. So you can see the leakage over there. You have both the things, phlebitis and vasculitis, in the same patient. Or you can have a pooling of the dye. Now, this is a patient of CSR. Initially, you see a smokestack leakage. Later on, you see a pooling of the dye. So you see both the lesions over here, leakage as well as the pooling of the dye. Now, this is a patient of cystoid macular edema, very typically diagnosed on angiogram.
You have a wind up your talk.
Thing. Okay, sir. And staining, Best disease. Just now, this is just one slide on the choroiditis. So choroiditis patients, they initially show hyperfluorescence. Later on, they stain, and you see hyperfluorescence. This is a very typical picture of a choroiditis. So that's it. Thank you.
Now I invite Dr. Prashant to kindly facilitate Dr. Salil. Dr. Salil Gupta.
So I thanks the society for inviting me here today, and at the same time I take this opportunity to invite you all, and being the organizing secretary of NZOS with HOS annual which will be held in Karnal from 22nd 24th December. So kindly mark your days, and I will expect all of you to be there. Thank you so much.
The next talk is Dr. Tinku Bali. Then I'll invite Dr. Prashant to kindly start with their presentation.
No, it's not moving here. I can't see that. यहाँ नहीं मूव हो रहा मैडम. एक मिनट.
हमने लोड करी है वहाँ पर, ये किसी भी दोनों तरफ भी कहीं भी चलती है.
दोनों भी चलती है वैसे. हाँ, लोड जो की है वो दोनों पे अपना.
इधर पे नहीं मूव हो रहा भाई. दिख नहीं रहा है ना. Thank you. So, good morning friends, and let me at the outset do some preliminary job before I start my talk on OCT angiography. Seriously, this is the first CME, physical CME we are doing in our new term for ARC, AIOS. And this is the first physical CME, so when Dr. Rajan, Dr. Manisha and everyone said that it should be in HOS, I was very delighted, and the way the HOS and the Sirsa Ophthalmological Society has pulled out the show, it's beyond my imaginations, and my sincere most thanks to the whole HOS as well as the Sirsa Ophthalmological Society for organizing such a wonderful CME. I also wanted to express my thanks why this series which we have started, initiated from Sirsa. When I did my post-graduation way back in 93, that time we didn't have so many gadgets, right? From beyond fluorescent angiography in retina, we didn't have anything. Similarly, in corneal topography and every other diagnostics, the ophthalmology has evolved over a period of time very phenomenally. And even to people like me who travel so much, I cannot really read out, understand what is happening in a topography. Only I see the red colors, yes, and the blue colors. As a young gentleman, rather man, I am always attracted to. But beyond that, I don't really understand. And that's why the concept of why we should have diagnostics in ophthalmology, right from basics to what is happening today, becomes more relevant for most of the people who are of my era, because we have seen the evolution of this diagnostic techniques, but we were not born and brought up with this. So we were never very comfortable from other subspecialties, and that's the reason why we rolled out on behalf of ARC this particular series. And I hope This will be useful to you, for everyone over here, not only for postgraduates, for people of my generation who have seen the evolution of ophthalmology becoming so diagnostic dependent. I would definitely expect you to write us back to us so that we understand what are our limitations and how we can further improve. So with that, without much ado, I would come back to my topic on OCT angiography. This is a new tool which is in the armamentarium of our vitreoretinal surgeons, and it is really difficult for us, most of us, to understand what it is. So I will be talking on very basic things what this system offers you. This is a non-invasive retinal blood flow which you can get. And I will not run through, but for the sake of postgraduates, I will share with you what is the principle of it. What happens? There are tissues which are static in a retinal tissue, and there are certain areas where there is a movement happening. In the blood vessels, the blood cells are moving. So two rays are sent by the probe, and once that is, then it gets reflected. The reflected lights, two A scan signals come. So the signals from the moving particle and the static tissue are contrasted against each other, and based on that we develop a structural B scan. So if there is a difference in the time, you get is what is called a phase decorrelation. Means a tissue, the wave comes back from the solid tissue versus a mobile tissue slightly differently. That is called time decorrelation or a phase decorrelation. Or if the reflectivity of the tissue is different, again you get an amplitude decorrelation. And this is the basic principle on which the whole system of understanding the OCT angiography happens. The various systems, various companies use various things. Zeiss uses the phase or time decorrelation signals for developing the B scans, while the OptoView like machines use the amplitude decorrelation. These are the various companies which offer them. So what is the basic advantage of Octa over fundus fluorescent angiography? Most importantly, whenever we had a fluorescent angiography, you get the superficial image. You cannot make out at which segment into the depth of the retina it is available. Neither could you measure the exact areas of non-perfusion or neovascularization. Also, being an invasive procedure, the reaction to the dye is well known. So this is the thing. And other thing is you cannot repeat an fluorescent angiography within next 72 hours. While Octa you can do a number of times. Now look at this particular thing. This is an initial phase of a neovascularization on the elsewhere, and it immediately becomes blurred where you cannot really understand the architecture, anatomical tissue, what exactly pathology. While in the Octa, of the same picture you can see beautiful lacy network of the neovascularization, and this does not get blurred out with the phases. This is one of the biggest advantage. Now look at this particular big neovascularization versus on an Octa where you can see the blood vessel, such a beautiful architecture of the blood vessel, and this helps you in better understanding of the disease. There are various strategies. Now let us move on how we interpret this. Strategies can be in first view where you look upon as if you are sitting in the vitreous cavity and looking at the various segments, or segmentation where you cut it into various areas, and the slabs and slices depending upon the thickness of the tissue which is gone. Most importantly, when you are analyzing, you need to understand, you have to go into the various slabs independently to understand and pick up the disease, because the retinal diseases, unlike in fluorescent angiography, remember, can be picked up at various levels. And this is what you have: superficial slab, deeper slab, outer retina slab, and a choriocapillary slab. Similarly, optic nerve head can be visualized at various levels, which I will be sharing with you. You need to become familiar with certain terminologies in Octa. One most important thing is non-vascular flow signal, where because of the certain tissues, the A scans do not go behind it, and that is why you get a non-vascular flow signal. It can happen because of RP, hard exudate, and you can confuse it as rather ischemia. Rather, it is not an ischemia; it is a blockade in the terminologies which we use for fluorescent angiography. While in avascular region, actually there is a loss of blood vasculature over there, and that's why you do not see. That is the difference: non-vascular flow signal versus avascular flow signals. These are other things which I would just run through it, which helps you in further studying how much is the vessel loss or the ischemia in that particular tissue, be it in the macular region or be it in the optic nerve head region. In optic nerve head region, if you understand the loss of the vessel pattern, especially in the cases of glaucoma, it helps you in monitoring the cases of glaucoma. I will show you my cases. So how do we start interpreting? So whenever you are given a slab, remember there is a particular way at which you look. Like in a perimeter, you have to look at a grayscale, then you move to the standard thing and all those things. Similarly, so remember, first when you start, you have to image the right spot, then look at the emphase at various sections of it. Then you look at the segmentation line, whether it is styling with that particular level. Then you have to move at the B-scan fluid overlay, and then you have to compare it with ENFLAS intensity image. I would take some more time so that PGs understand this new topic. So this is what the first image you have to image is, you have to image the correct spot. For example, this is a case of a macroaneurysm. You have to put your scan in this area. If you put it through the foveal avascular zone, you will miss out this important etiology. And this is 3x3 scan versus 6x6 scan, where you can see, you can further decipher the detail by using the smallest scan for understanding the details. Then now look at the ENFAS octa images. ENFAS means you are sitting in the vitreous cavities and looking at various slabs. So remember, there are 3 or 4 slabs which you have to look for. Superficial retinal slab, the deep retinal slab which looks something like this on a normal octa, an avascular slab which is devoid of any vessel, so it is black, and then a choriocapillary slab which something looks like this. This you should remember the picture how it looks. I cannot go into details for want of time. And remember, what is ORCC slab? It is a combination of avascular slab plus choriocapillary slab. So this helps you in picking up the MNVs. And this is the choroidal slab. This is what the standard pattern which you should be looking for. Then you should move to the segmentation line. Is it moving exactly through the area which you are visualizing? Because if it is not telling, you can have certain wrong images. For example, if you look at this image, you feel there is a CNVM complex here. But now compare it with the B-scan image, you will see this is a PED and it is not tallying with the vascular flow index, and therefore it is not this is just an artifact. Now look at the B-scan with overlay. You will be able to pick up. This is an ENFAS image which is happening at a type 1 MNV, type 2 MNV, type 3 MNV. Always compare it with flow overlay. And then look at the ENFAS intensity image. For example, you see some hypolucent spots here, so you think there is a loss of the flow over there. But now when you look at the structural pattern, you will see that it is repeating over here. And B-scan, you will see that there is a drusen. So this is not a hypolucency because of the loss of vascular tissue there, but it is basically because of the drusen. So this is the importance of comparing it with choriocapillary slab here. Similarly, another example, you see some hypolucent spots, but here if you compare over here, it is not signal intensity, it is matching with the vascular flow over there, and so here the signal reduction is because of exactly choriocapillary loss. And then you look at the ENFAS intensity image. For example, I will just run through this particular thing. Then next step is you have to move at which level you are going to see. Remember, there are 3 vascular complexes: superficial, vascular, intermediate, and the deep capillary plexuses in the retina, which you could not pick up with the fluorescein angiogram. And these are the 4 zones where you look at what for any pathology. So what are the various abnormalities visible in different zones? For example, if you look at this if you look at the superficial slabs, you miss this CNVM. You have to look into the right slab for picking up the pathology yourself. Now, for a telangiectasia or microaneurysm, you have to use a superficial slab. For using a ghost tree or a MNV, healed scarring CNVM, you have to go to the deep slab. Again, for active CNVM, you have to go into ORCC slab and drusen's at sub-RP level. Now, one classic example, this is a young patient, hypertensive, sudden loss of vision, 5 days. Superficial slab appeared to be normal. Fluorescein angiography was absolutely normal. I do an octa in a deeper plane and I can see this is hypoperfused area. So this was because secondary to hypertension, there was a choroidal infarct which we could pick up on this particular thing. So this is how it helps you in unraveling some of the unexplained puzzles in retina. Also, for the sake of understanding, you have 3 patterns of abnormality. One is abnormal presence of flow, One is abnormal geometry, the vascular pattern becomes distorted or more than physiological, or absence. These are the three patterns which you should look for, this especially for postgraduates. And this is few of the examples of abnormal presence. This is telangiectasia versus a microaneurysm. This is another IRMAS, new vascularization. This is a hemangioma. And in deeper slabs, if it is there, usually it is a new vascularization, as you can see over here. And this you should always compare with the B-scan OCT. Another important thing for people who are from anterior segment, optic nerve head octas are important, basically because you can understand the progression of the glaucomatous involvement earlier than the perimetric changes. And this is how it helps you. I am not a glaucoma man. This is shared by my own glaucoma department people. So this is what we will be seeing. At optic nerve head, whenever you are seeing the pathology, you have to see at the level NVD looks like this, collaterals look like this, and this is glaucoma. This you have to look at two peripapillary. The one is radial peripapillary capillary plexus and choroidal slabs. For changes of glaucoma, progression can be picked up on this, and these are the indices of optic nerve head in glaucoma on octa, which you should look for. This is one of the case where you will see that there is a progressive loss of the thing before perimetric changes. You can see reduced vessel density in this particular cases, and this particular case shows the loss of deep layer microvasculature. So this is a wonderful investigation which can add, I think because of want of time I cannot show you much more than this. I will just run through it. This is optic nerve head with few of the cases which we will be running. I will come to one another.
Kindly wrap up.
Yeah, I will be wrapping up. So in diabetics, you can pick up the new vascularization on the disc in the area. You can pick up the microvasculature. You can also pick up the unexplained visual loss in a diabetic retinopathy, as we can show. So I will just run through it and come to the last thing. So it is a wonderful tool. Just because we don't understand exactly what is happening doesn't mean that we should not be using it. It has a terrific potential to explain you and understand you what exactly it is happening. I just wanted to come to thank you slide once. Okay, I just wrap it up with this particular thing. So once more, thank you Sirsa Ophthalmological Society and HOS for this wonderful invite. I hope this CME of ours, ARC CME, which has been we have developed for all of you, will be of a great help to you. I have my own member from this zone, Dr. Tinku Bali. Welcome, Dr. Tinku Bali. Over to you now.
Now I call upon Dr. Mosmi Banerjee to kindly start with the presentation. In the meanwhile, Dr. Tinku Bali ma'am is here, and they will upload that on their computer. Dr. Mosmi, kindly come up with your presentation.
Good afternoon, everybody. I'm Dr. Mosmi Banerjee, and I'll be speaking on ocular ultrasonography. So why is it important to know about ocular ultrasonography? Because it's a painless, non-invasive, safe investigative modality which is not time consuming and is a cost-effective method for precise diagnosis of ocular lesions. I'm not going into the details of the history of ocular ultrasonography. However, one should understand that ocular USG, it should be we should perform a standardized echography, which is the combination of the A scan along with a contact B scan. It's based on a very simple principle that with increase in frequency of ultrasound, the wavelength of ultrasound will decrease, and with that the depth of penetration will be also decreasing. However, the resolution will increase. The most common frequency of ocular ultrasound which is used is 10 megahertz, and 20 megahertz is also been used, especially to appreciate the orbital details. Now what actually happens is a piezoelectric transducer is stimulated first with an electric oscillator, and the high frequency sound waves will then be projected into the eye and the orbit. Now echoes will be produced when there is an acoustic interface, that is the junction between the two tissues which have different tissue densities. Now greater the difference in the sound velocity, stronger will be the echo. Now this reflected echoes will come back and it will generate a current in the quartz crystal through the piezoelectric effect, and then it will be displayed on the computer. Now the amplification of these echoes can also be regulated by adjusting the gain. So this is the velocity of sound through the various medium. Especially we should know about the velocity of sound in vitreous, that is 1532 meter per second, and in silicon oil it's around 980. The 1000 centistroke silicon oil has a velocity of 980. So coming to the types of ocular ultrasonography, first is the A scan, which is the time amplitude scan. It produces a one-dimensional acoustic display. Here what happens is a single sound beam is sent to the transducer, and then the returning echoes will be converted into a series of spikes, and the height of the spikes will be proportional to the strength of the echo. So there are various factors which will influence the height of the spikes. First is the difference in the acoustic interface. So when there is a flat, smooth interface, most of the sound beams will be reflected back to the probe, and therefore will get a high amplitude spike. Now when there is a smooth, however concave or convex interface, some of the sound beams will be reflected away from the probe, which will result in a diminution in the height of the spike. It will further decrease the height of the spike will further decrease when the surface is irregular, and when it's a very small interface, then most of the sound beams will be scattered away. Second is the angle of incidence of the probe. When it is perpendicular to the surface, a high amplitude spike will be produced, and as it becomes oblique, then the height of the spike will decrease with it. Another important thing is the density. The denser the object, it will absorb the energy, and therefore there will be attenuation of the A spike. So there are three parameters which we can measure from the A scan, that is the reflectivity, the internal structure of any lesion, and the sound attenuation. So coming to the second type of USG, that is the B scan. Here a two-dimensional acoustic display is produced. Most important point here is the orientation of the B scan is very important here, and there will be a mark at the top of the B scan. Now the area towards which the mark will be directed, that will appear at the top of the echogram on the display screen. Now next three slides are very important because this shows how to perform an ocular ultrasonography. So B scan can be performed in three sections. First is the axial section. Now before I go forward with the procedure, we should know that these sections are actually described on a anesthetized cornea where the probe is placed directly over the cornea. However, in day-to-day clinical practice, we usually prefer to do it transpalpabrally. So here what happens is the patient fixates in the primary gaze, and then the probe will be placed directly over the globe and directed axially. So it can be done in three ways. One is the axial horizontal, the vertical, and the oblique scan will be produced. So what happens is when we place it, suppose here it's a vertical axial scan. So the sound beam will be sweeping across the opposite two meridians, and here it will pass via this optic nerve. So the optic nerve will come in the center of the scan in an axial section. So this section will help us to demonstrate the optic nerve head as well as the posterior pole. Second is the transverse scan, where the probe is placed at the limbus and parallel to the limbus. So it can also produce horizontal section, vertical section, and the oblique section. Now in this section it won't pass through the optic nerve. So what happens is, suppose in this diagram we can see it's a horizontal transverse section which is placed at the 6 o'clock position. So the sound wave will be directed towards the 12 o'clock meridian, and the sound wave will be sweeping across the 12 o'clock meridian. So what happens is, if there is a lesion here, so when it's sweeping across the meridian, the lateral extent of any ocular lesion will be well appreciated. So with the transverse section, the lateral extent of any ocular lesion is appreciated. Third is the longitudinal section in which the probe is placed perpendicular to the limbus, and here the optic nerve head will come at the bottom of the scan. So here what happens is, it will help in demonstrating the anterior posterior extent of the lesion. So let's see how. So here it's placed vertically at 6 o'clock position. So sound beam is directed towards the 12 o'clock meridian, and the sound wave will be sweeping along this meridian, not across but along. So if there is an ocular lesion here, so it will help us to give the anterior posterior extent of the lesion. Now another important thing is, as we go away from the limbus towards the fornices, so here you can see the probe is placed near the limbus. So any lesion which is at the posterior pole will be better appreciated because the sound beams are directed on towards that. But when we move away from the limbus, it will be directed anteriorly. So if we have to screen the anterior part of the retina, then we have to go beyond. Here also we can see the same thing. This is a horizontal transverse scan, and here the lesion, the sound beams are directed here, that is posterior to the equator. As we move away, we can screen the anterior part. So I'll come to some of the examples. So whenever we see we describe a B scan, the important things we have to say is whether we are seeing dot-like echoes, membrane-like echoes, or pseudomembranes-like echoes. So here we can see there are numerous dot-like echoes in the in this diagram. Along with it, we can see a membrane-like echo, and it has a pinpoint attachment to the optic nerve head. Now this is a static diagram. If we would have done a dynamic ecography, then we can see there will be an after movement of this membrane as well. So this is vitreous hemorrhage along with a PVD. This is here also we can see a membrane. However, this membrane is thick, and there is a broad-based attachment of the optic nerve head. So this was a case of retinal detachment, and it will have poor after movements. This is another example of retinal detachment. However, we can see the membrane is in a funnel shaped. It's a closed funnel, which is a closed funnel RD. Here we can see the rolled up edge of a tear, the membrane. It's a case of giant retinal tear. Here the membrane is in a tabletop configuration suggestive of a tractional retinal detachment. However, all these cases have to be clinically correlated before giving a diagnosis. So here we can see a dome-shaped elevation, and there is hyperechoic lesion. There are dot-like echoes here. It's a hemorrhagic CD. And here also there is a echoluscent dome-shaped elevation with the retina is opposed, suggestive of kissing choroidals. Here we can appreciate a excavation. Along with it, if we see here, there is a membrane here, and there is a breach in the membrane. So this is a fundal coloboma, and there is an
kindly wrap up here.
So there is an intercalary membrane detachment as well. So this is a case of endophthalmitis. I'll just go to the last one. This is a case of posterior dislocated cataractus lens. I'll not show this. So another important thing is for papilledema also, ultrasound can help with a 30-degree test. I won't go into the details. So there are three techniques. First is the topographic echography, which will help in documenting the shape, extent, location and dimension of the mass lesion. The kinetic echography, which will help in determining the mobility and vascularity of the lesion. And the quantitative ecography, which we have already explained, that it can help in describing the reflectivity, internal structure and sound attenuation. Indications have already been described. So thank you.
Thank you very much. Now I'll ask Dr. Manisha ma'am to kindly facilitate Dr. Mosmi for an excellent presentation. Dr. Mosmi as a speaker, please kindly bring the memento, please. And I call upon Dr. Tinku Bali ma'am, who is here now, to present their talk. We will be taking the questions at the end of our session.
Good afternoon. It's both my pleasure and privilege to be here this afternoon, and it's so nice to be here amongst you. Thank you to the Haryana Ophthalmic Society and the Sirsa Ophthalmic Society for hosting me. And I would like to speak to you on a simple topic, that is the interpretation of retinal OCT, and just give you some pearls and a few pitfalls. So as we know, the OCT is a non-contact, non-invasive method of retinal diagnosis which has revolutionized retinal disease management. It gives us high-resolution images of this posterior segment, almost like an optical biopsy, and the layers of the retina are very well depicted on the OCT. So the OCT has come a long way from where we had these fuzzy pictures to a very high definition OCT now, which gives us a resolution of 5 microns. And as the technology has developed, more and more terminologies have come in as we've started seeing more and more structures. The names of the layers keep on changing. So, and I'm sure that in future when we have better technology, we'll have further additions to this. So it's a very dynamic technology that's been developing over the years. It's not moving. Also, most of the machines now have a 3D image, which is extremely good to show patients. When you show this 3D, the patients understand much better. So when we analyze the OCT, we do a quantitative analysis and a qualitative analysis. So this is from the Zeiss Cirrus OCT. This is the quantitative analysis where you see the map which tells us the thickness. What we are most interested is the central subfield thickness. It also shows out all the layers separately here. And this is color coded here. As you see, red, the hotter colors show that there's more edema. The greener colors show that the retina is almost normal in this green zone. And this is the qualitative scan. So this is what we are more interested in. The quantitative scan is generally used for follow-ups, and it's the qualitative scan that we look at. So as I said, all the retinal layers are very well depicted on the OCT. This is the color-coded map, the hyper-reflective layers. This is the nerve fiber layer. This is the retinal pigment epithelium. And this is the photoreceptor layer, which is now called the photoreceptor layer. But in that red, most of the retina specialists do not like to see that color-coded picture. What we like to see is this black and white picture, the gray areas, which gives a better delineation. So these are the layers again. This is, if you start from here, this is the retinal pigment epithelium. This layer on top here, this one is the external, this is the retinal pigment epithelium. This is the ellipsoid zone. This was earlier called the ISOS junction or the photoreceptor integrity line. Now the terminology has changed and it's called the ellipsoid zone. So this white line here, this hyperreflective layer. Above that is a slightly lesser hyperreflective layer. This is called the external limiting membrane, this one. So the most important line for us is this one, the ellipsoid zone and the retinal pigment epithelium. As we go in the inner side, here we have this both the hyporeflective layers, that is the ones which are black, are the nuclear layers. The hyperreflective layers are the plexiform layers. Then you have the ganglion cell layer, and on top you have the nerve fiber layer, and then you have the limiting membrane, the internal limiting membrane. So these are all the layers. But it's not so important to know all these layers, because when we see an OCT, we don't really say that, oh, there's swelling in the plexiform layer and the ganglion cell is involved. Most often we look at the patterns of OCT to make our diagnosis. And it's important to know that the layers which are affected, the retinal vascular diseases affect these inner layers, and the choroidal vascular diseases affect the retinal pigment epithelium, the choroid, and the ellipsoid zone. So as I said before, we generally look at patterns of the OCT. So if you see the first layer, the retinal layers are all very compact. In the second OCT, you see these cystoid spaces. You know it's either a diabetic or some vascular occlusion. This OCT, you see these cystoid spaces in the outer retina, huge cystoid spaces. And you see that the retina is bifurcated. Only one side is edematous. This is very typical of a branch retinal vein occlusion. Here you see these optically empty cysts. So this is cystoid macular edema. Here you see some amount of fluid, subretinal fluid, and some hyperintense material below the retina. And this picture, when you see this PED, intraretinal cyst, subretinal fluid, some hyperreflecting material here, you know that this is a CNVM. So many times when we just look at the picture, we are able to make the diagnosis just visually. And that's the time we start thinking of how to treat or how to follow up this patient. So as I said before, these are the different conditions which you can just see and say that this is the one. Now coming back to the layers, out of all the layers, like I said, the ellipsoid zone and the RPE is the most important for us to prognosticate, to treat, and to know what's going to happen with the patient's vision. Now many a times subretinal fluid is confused with pigment epithelial detachment, and that's what I'd like to touch upon. So this star shows the subretinal fluid. It's very easy to delineate the subretinal fluid. So this is the retinal pigment epithelium, this white line here. Above that is the ellipsoid zone, which is continuous. Any hyporeflective material in between these two layers is subretinal fluid. So if you just delineate your pigment epithelium and the ellipsoid zone, you know that this is subretinal. It is not the retinal pigment epithelium which is lifted up. As opposed to this, where you see the retinal pigment epithelium itself is lifted up and you can see the ellipsoid zone over it. So this is a pigment epithelial detachment, and that was subretinal fluid. Sometimes you can have a combination of the two, so a pigment epithelial detachment. Here you see the ellipsoid zone, you see this hyporeflective space below the ellipsoid zone. This is the subretinal fluid. So you can have a combination of that. Most often in CSR you see such a picture. Now to the audience, if you see such a picture, it does become confusing. So is it a PED? Is it SRF? So it's simple. You can see the RPE layer here intact. This is the ellipsoid zone. So this is subretinal fluid. Again, this is also subretinal fluid because you can see the RPE layer, the pigment epithelial layer below it. This subretinal fluid has some proteinaceous or some vascular component in it. That is why it has got these hyperreflective areas. So this is also subretinal. Now, every OCT tells us a story, and we have to pick up clues from the OCT if we have to weave that story. For instance, just for a little diversion, I can see this OCT and say which eye is this. So any guesses which eye is this? So this is the left eye of the patient, and why do I say that? Because the nerve fiber layer is thicker near the optic nerve. So if you take this section, this is the optic nerve should be somewhere here. You see this nerve fiber layer is so thick here, and when it goes temporally, it thins out and almost disappears. So when you see this, this is the left eye of the patient. Again, by just seeing this OCT, I can make out the refractive error of the patient. So I'll tell you how. You see this RPE, it's going straight and then it suddenly dips down like this. It's not in a straight line like you saw. So this is a staphyloma and this is a myopic patient. So this is myopia. So when we see the OCT, first thing is to do is to determine that the scan quality is good. Sometimes the patient has a dry eye or the patient has a cataract or the patient is moving.
Wrap up your discussion.
Okay. Sorry. Okay, so these are, I'll just give some few pointers. These are blood vessels you see here which are causing these hyperreflectivities, shadowing. I'll just skip over all this I've already discussed. So the foveal profile again needs to be evaluated very, this is a foveal bulge. Many people say that, think that this is a pathology. Many of my residents come. So this is the normal foveal bulge and it's very normal. The foveal profile can be deformed, and always when you do the scan you should make sure that you've gone through the fovea. Many times it happens that you've not gone through the fovea, and that is when all the problem occurs. So just my last 2-3 slides. Just some pitfalls. Do not compare the thickness between two OCT instruments, because like the two OCT instruments will give different thickness because they have different segmentation algorithms. Look at all the images. Do not just see 1 or 2 images and make your diagnosis, because you may be missing significant data. This is just yesterday when a patient was sent from outside for this OCT, and the optometrist did the OCT and came to me and said, "Ma'am, CSR hai." So when I had a closer look, this is what the patient had. You see that this was not through the center, this was not through the fovea, and you see this looks like a CSR. But when I asked the patient to fixate, this was a BRVO, branch retinal vein occlusion, and this was the exact picture. So make sure the patient is fixating very well, and you check all the scans, and you go through the foveal center. Don't rely on the retinal thickness maps only to plan your treatment, because if you do that, the patient may not have fixated, he may be fixating extrafoveal and you may not get the correct picture. So in conclusion, in conjunction with the clinical examination, the OCT helps us with better diagnosis, classification, prognostication, monitoring and follow-up. It's an excellent educative tool for patients and also for us, because on the OCT we keep learning new things every day. And it's a tool which is developing, and I'm sure that there are going to be lots more mysteries that are going to be solved by OCT. And the last thing that I'd like to say is that before cataract surgery, I would exhort all the anterior segment surgeons to please do get an OCT done. Many times you'll pick up things like epiretinal membranes, pigment atrophy, surprises which you have not been able to see on your clinical examination. Thank you so much.
Thank you, ma'am, for a very nice talk on OCT. Now I'll ask Dr. Manisha, ma'am, to kindly facilitate Dr. Tinku Bali, ma'am. Dr. Manisha Nada, kindly please come.
partly दिए किसी को pending रहेगा.
I'll ask Dr. Raman to kindly be ready with the presentation. Thank you, ma'am. Thank you. We'll be taking up the questions in the discussion session.
Good afternoon, ladies and gentlemen. Me and my colleagues are standing between you and lunch, I know. But before that, I would really want to thank AIOS, ARC, the Sirsa Ophthalmic Society and Haryana Ophthalmic Society. It's a wonderful show they have put up for such a, I was thinking it to be a dry topic, but very informative it is. And it's wonderful to see you all on Sunday. So after so many colorful slides, as we all know, ultrasonography is a very black and white, but that is what our life is also. We can fill colors in there, but then actually it is more of a black and white. I being an oculoplastic surgeon and deals in orbital lesions, so this topic is very relevant because this is a forgetting science that we are not doing ultrasonography on daily basis or in routine basis, and it is also a subjective science, so it also depends upon who is doing the ultrasonography. That's very important because if the person who is conducting is knowing the details, then he can find out. Otherwise, it's not like as objective as the CT scans and MRI, that the pictures are there and you can find it out. So ultrasonography is very subjective. He or she would be picking up those pictures while doing the dynamic scans, and then only you can decipher. Most of my work has been done by Dr. Mosme. I thank her very much. So I would skip the initial few slides of the basis of ultrasonography. As we know that standardized ecography is the best. We do A and B scan together. So the orbital indications for ultrasonography is, while we are looking in for orbital masses, the extraocular muscle evaluations, the globe evaluations, the optic nerve drusense, orbital inflammations, orbital foreign bodies, more so of wood, which is not picked in CT scans and all, cavernous dural sinus fistulas, orbital vascular anomalies, and to follow up the cases, because you can't keep on repeating the CT scans and MRI scans on a very regular basis, but ultrasonography is very cheap modality but very informative. So 3 portions can be examined while doing an orbital ultrasonography, which is the orbital soft tissue, the extraocular muscles, and the retrobulbar optic nerve. And this is the normal orbital tissue, which is very reflective, very highly reflective on an A scan and on B scan. So this is a very reflective A scan and a very eco-dense B scan. So this is a normal one. First we should know normal, then only we will know the abnormal scans. She has already mentioned about the longitudinal, axial and transverse. So there are other 2 techniques how we do the B scans. One is a transocular, which we generally do. That is, the examination is being done through the eye. So the probe is placed on the globe or on the closed lids, and we have to examine with a higher gain in the orbital area. So these are done for the posterior lesions within the posterior and the mid orbits. Okay. So if the lesions is retrobulbar space or within the mid orbit. And for the lesions which are placed in the anterior orbits, we do a paraocular scans, which is examination is done next to the globe. So these are the lesions which are lying in the lids, like preseptal lesions, postseptal lesions, anterior orbital lesions. Here you can use a probe directly on the closed lids, or you can use a water bath, which you can create, so that gives you a sort of a transocular scan, but it is basically not an ocular surface, but it's a water bath. So this she has told about transverse, longitudinal and axial. I would not repeat. We should examine both the orbits, because confirmation of abnormal scans can sometimes be made only by comparing it with the uninvolved or the normal orbit, right? And clinically appearing unilateral conditions can actually be present bilaterally in most of the times, like in thyroid or some other cases. Topographic, quantitative and kinetic ecography, again, which is location, shape, size, borders of lesion. This helps you to differentiate or to put up a differential diagnosis, because we know that orbit is a Pandora's box. in most of the other conditions in eye, you can see what you are looking for. You can see the cornea, you can see the AC, you can see the lens, you can even see the retina. But in orbit, you will just see that the eye is popping out and you don't know why it is. Okay, and sometimes you don't even know that the eye is popping out. But there is something which is restricting the globe or is hampering the vision or something of the sort. So quantitative echography, internal structures within the lesions and the sound attenuation. It is again very helpful. And kinetic echography, which means that consistency, the internal blood flow and the mobility. Topographic evaluation for the location, shape and size. Like in this, you see that the globe is being indented by this lesion. There is a lesion which is indenting on the globe. The globe indentation can be seen through fundus examination, but then you can see the size of the lesion. Here you can see the lesions are very well outlined. So very well circumscribed lesions can be thought of. Here the poorly outlined lesions like inflammations or lymphangiomas. So these ultrasonographies help in creating a differential diagnosis for you. In quantitative echographies, here you see for the spike height. If the spike height is less, then it is a low spike height, medium, and this is a high spike height. Differences in the height of A scan. Are you moving the slides? Why is it moving on its own? So the spike height differences can be made. Here you see that all the spikes are homogeneous. So this must be something which is a homogeneous lesion like in lymphoma. Whereas here you see there's variable spike heights. So this is a heterogeneous lesion which we may be dealing with, like for example hemangioparasitoma. So even these spikes are very important and they can help you to know what all lesions you are dealing with. Here is a clinical picture of a hemangioparasitoma, a CT scan relevance, and then ultrasonographic spikes which help you. This is very important slide in which we have the initial spike, the baseline, the ocular wall spike, and the angle kappa. The angle kappa is important to know that if the steeper the angle, the stronger will be the sound attenuation, and that attenuation gives you the consistency of the lesion. So in knowing the kinetic echography, knowing the vascularity, the probe and the eyes are held stationary, and you see for the changes in the echo that the internal lesions, echoes are observed, and there are a lot of fast spontaneous flickering which suggests that there is a vascularity and there is a rapid blood flow within the lesion. If you see a cystic lesion with the air fluid level or a shifting fluid level, then you can see with the change in the posture of the globe or the patient, you can see the fluid level. In the upper picture you can see an oblique fluid level. Same patient when lied down, you can see a horizontal. That suggests that's a cystic lesion with some hematoma or some fluid within the cyst. So ultrasonography is a great science, but unfortunately it is dying science because we all want easy access कि assistant photograph ले ले और हम फटाफट देख के उसको बता दें. So हमें खुद ना करना पड़े. That's the problem actually. This is a differential diagnosis which is based on the ultrasonography. I would skip this slide. Now I'll go on for a clinical correlation of the ultrasonography. Here this picture shows a cystic lesion, and when you take this vector through it, so it's a low to medium echo-reflective with a calcific point. Sound attenuation is absent, soft to moderately hard. The audience can always speak up for the clinical if they want. If you want to give a few seconds, few clinical conditions, all I can wrap up. So this is a cysticercosis. And in myocystic sometimes patient may land up in ptosis, some proptosis, inflammatory lesions. But on ultrasonograph, very nice cyst with a scolex inside gives you a picture and a clinical diagnosis. You just treat the patient medically and the patient is fine. No need of any surgical intervention. Extraocular muscle thickening is very important and found out in ultrasonography mainly in thyroid muscle, thyroid-related orbitopathies. So a B scan is very important because you have to repeatedly check for the muscle thickening. Longitudinal scans are important. I'll skip all the things and see here. When you see the whole length of muscle, you see, and then you can measure the thickest point. For every muscle, you have to keep a record and then compare with the normal. You'll come to know which muscle is enlarged to what extent, and later on after treatment, what is the benefit. This is a table showing normal muscle thickness. You have to compare with the other eye or nomogram. Here in first case you see that the muscles are thickened. a thyroid-related case, orbitopathy case, where you, after treatment, can compare. A myositis has a thickened muscle, but the tendon is also thickened. That's a difference. You can also evaluate the optic nerve and see whether the fluid is there in the optic nerve sheath or not. I'll skip the 30 degree, and you can see the optic nerve cupping as well, the colobomas, elevations, and drusen's. In 30 degree, just I want to say that if you do this test, you can differentiate from the optic nerve thickening vis-a-vis the optic nerve sheath fluid which is present, which disappears when you do a 30 degree test. These are long topics and 8 minutes are very short for them. Retrobulbar areas, the optic nerve gliomas, the thickened ones, and some cavernous hemangiomas, the lymphangiomas, dermatocysts, all can be seen and correlated with the CT scan. I'm sure our Amit is going to show good CT scan pictures, and then you can find it out. Conclusion is that it's very useful for detecting anterior and immediate retrobulbar lesions. Difficult to assess the apex. The orbital apex is not assessed. Ultrasonography is a very convenient screening tool to be supplemented with more sophisticated imaging techniques, and that's very helpful. Thank you very much for your patient hearing.
Thank you, Raman, for wonderfully showing us the importance of the ultrasound in the orbit. Now I request our member ARC North, Dr. Tinku Bali, to felicitate my friend Raman. And meanwhile, I request Dr. Amit to please come, and he will be speaking on radiological investigations. इसलिए तो साथ में दिया भाई फेलिसिटेट करने के लिए रीयूनियन करा दिया.
Good morning, everybody. Today I am going to investigations in ophthalmology, and my topic will be CT and MRI. So I'll be starting on orbit. It is on orbit, which is a confined space with walls, which is bordered by the brain on one side and sinuses on two of the other sides. This space can be host to numerous disease processes, including the tumors, infections, and inflammations. Now, this is a normal, just the anatomy of the orbit. Here we can see this is the preseptal area. Then this is the globe compartment. The sideways, that is the extraconal part. This is the intraconal part. This is the optic nerve part. This plate, this is important. This is the ethmoidal sinuses. This is the pituitary gland and the suprasellar region. And this is the cavernous sinus. All these are important parts which we have to see sometimes in our clinical practice too. This is the orbit of the. This is a of the orbit, and here you can see the various bones as well as the soft tissues. The floor is important in this case, which is formed of the maxillary sinus roof, maxillary bone, zygomatic bone, and the palatine bone. Whereas a very thin bony plate, it separates the orbit medially from the ethmoidal layer cells. This is the lamina papyracea, and it is a very important layer. Similarly, in case of an MRI, we can see the delineation of the muscles in a much better way as compared to a CT scan. So here you can see these are the various muscles that we can see here. This is the superior rectus, the lateral rectus, medial one, and the inferior rectus. So this gives a very clear delineation of the various muscles, and if there is any loss of sharpness or any enlargement of the muscles, in that case it suggests infiltrative type. Then the cavernous sinus, again very important. We have been seeing these cases in our clinical practice, and contrast enhanced CT scan and MRI is the investigation of choice when we want to image the cavernous sinus. Now, why do we need imaging in case of orbit or in case of intraocular lesions? Firstly, to confirm or help in our clinical diagnosis. Then secondly, to know the location, extent, tissue composition, effect on adjacent structures, and when we have to plan a surgical approach. The various methods that we use is ultrasonography and X-ray have already been discussed. We'll be discussing today on CT and MRI. Now the principle is that a CT machine actually uses an X-rays which are attenuated by the tissues, and then they are detected by the special detectors as images. The high density areas are depicted as white, whereas low density areas are depicted as black or hypotense areas. Similarly, MRI uses the magnetic resonance of atomic nuclei, which leads on to a disorientation basically in the atomic nuclei. Either they can be parallel or they become excited and become anti-parallel. So when they again come back to their relaxation stage, they this energy, this radio frequency which is released, it is actually taken off by the MRI, and then it is projected. So relaxation can occur via two pathways. So we get two sort of images. That is the T1 image and the T2 image. T1 is important for anatomical part, and T2 is better for inflammatory, ischemic, demyelinating, and neoplastic lesions. So in T2 images, fluid is taken as hyperintense, means it will be brightish in color, whereas brain gray matter appears hypertense compared to the white matter. So T2 images are comparatively better. Now the imaging planes. We have 3 or even more than 3 planes, but the most commonly used is the coronal plane and the coronal and the axial plane. The sagittal plane is reserved for few of the things, like when we have to image the patient for a floor fracture. So the coronal scan, the axial plane, it slices the body into 2 halves, that is into the upper and the lower half. Similarly, this coronal scan, it divides the area into the anterior and the posterior part, whereas the sagittal, it divides into 2, that is the right and the left part. So this is an important thing while we are ordering a CT scan or an MRI. So this is a very basic thing, but we usually don't know what to order at that time. Now, now on comparing MRI and CT, there are some advantages and disadvantages of both these modalities. MRI is actually better for soft tissue resolution. Its resolution is much better as compared to a CT scan, whereas CT is much better for the bony lesions, or if we want to see any bony erosions. In that case, CT is comparatively much better. But the important thing is that MRI has some very absolute contraindications. That is ferromagnetic implants, metallic foreign bodies, pacemakers, intracranial aneurysmal clips, or cochlear implants. In those cases, and even in cases of intraocular foreign bodies, we cannot actually order a MRI scan because we don't know the exact nature of the foreign body. If we are absolutely sure that it is not a metallic foreign body, only in those cases we can go for an MRI. Some of the problem with like CT, there will be a radiation exposure, and which is comparatively very less in cases of MRI. The cost is comparatively less in case of a CT, and it takes less amount of time, where an MRI takes a lot of time, and sometimes the patient may become claustrophobic. Now, while requesting a CT, what are the things which we should be seeing? First is the thickness of the slice, whether we need a contrast, what should be the plane, the tissue windows, any modification, and whether we need a simultaneous brain CT along with that, or any 3D reconstruction is required. Normally we take 2 mm or 1 mm cuts for optic nerve and the apex lesions, because the thinner the lesions, there will be more radiation effect. Contrast is usually required in cases of vascular lesions and in case of cystic lesions, even for evaluation of optic chiasma, the paracellular region, optic nerve lesions, particularly meningioma and the gliomas, but not in cases of fractures, because we don't need any contrast for fractures. Now here we can see this is a normal plain CT versus the contrast CT, and we can, and here the contrast has already been taken out by the lesion. Tissue windows is the soft tissue window will give a better delineation of the softer tissue as compared to bone window will give us a better understanding of the bony structure. So simultaneous brain CT is sometimes required because, as in this case, this is a case of neurocysticercosis. We can see there the neurocysts, they are present in the muscle as well as in the brain as well as in the tongue. So these are the other indications: head injury, optic nerve meningioma, bilateral retinoblastoma, suspected paracellular region. 3D reconstruction will be required in cases of congenital or in some trauma cases. what all to look for. Firstly, the patient's name, the laterality, right or the left thing, plane or a contrast. Then fourthly, imaging plan, that is the axial, coronal or sagittal. Then the Hounsfield numbers, then the slice thickness, window width, and the window level. So here we can see this is the without contrast CT scan. Here this is with contrast CT scan. This is Hounsfield number, means this is the radiation attenuation value which has been given to each and every tissue. So the baseline is water, that is 0, and air and fat will be minus, and above ones they have a positive values. This is the axial scan orientation. This is an axial cut. So I'm not going to go into much detail. This is a lower axial scan. We can see these following structures like nasal, NLD, maxillary sinus, and the inferior orbital fissure. This is a middle scan where we can see entirely the optic nerve is very clearly seen. The superior orbital fissure is seen in this cut. Similarly, the upper axial scan, we can see the lacrimal glands laterally and even the superior rectus. The coronal scan means the anterior and posterior has been divided into two parts. So we can see all the 4 recti muscles. We can see the superior ophthalmic vein, lacrimal gland, maxillary sinus inferiorly, and the ethmoidal sinus medially. Systemic evaluation, we have to evaluate the bony orbit, the dimensions, orbital walls, superior orbital fissure, inferior orbital fissure, orbital floor, apex, and the paranasal sinuses. Basically, for axial scans are usually done in cases of medial wall, the lateral wall for axial scans. Or roof and floor, we need to do a coronal scan. And for orbital bone fracture, we need to do a sagittal scan. These are the various indications for which we should be doing CT or MRI: infections, inflammations, tumors, trauma, foreign body, or hemorrhages. So orbital infections, here we can see this is a preseptal cellulitis, when it is only limited into the anterior or the preseptal area, where in case of orbital cellulitis, it has gone into the postseptal area also, and here we can also see a ring enhancement in case of a subperiosteal abscess. Okay, I just need 1 or 2 minutes. Now this is a case of invasive sino-orbital fungal disease or mucormycosis, where we can see there is this lesion, this is extending to, and there is also the attenuation of the soft tissue as well. So in these cases, MRI is actually better. MRI is superior to CT in identifying intraorbital as well as intracranial involvement. So for softer tissue, MRI is comparatively better. But if you want to see any bony erosions, then CT will be better for that case. Similarly, here it is an inflammation, thyroid eye disease. Here we can see there is the spindle enlargement of the extraocular muscles with relative normal tendinous insertions. This is referred to as the Coca-Cola bottle sign. Similarly, in myositis, there won't be any sparing of the tendons. Tendons are also involved, and there will be enlargement of the muscles. This is vaginous, and we are seeing complete involvement of the orbit. So there is proptosis and complete infiltration of the softer tissue as well. Then sarcoidosis, here we can see the lacrimal gland enlargement. This is the lacrimal glands, they have been involved. And here we can see, this is the MRI picture. Here we can see this is the tram track sign, in which there is involvement of the optic nerve sheath, and it gives a tram track type of appearance. This is a pseudotumor or the orbital inflammatory syndrome. And here we can see there is enlargement of the lacrimal gland here, and along with that, this is the involvement of the lateral rectus muscle. This is now I will directly come over to orbital trauma or the fractures. Here we can see this is a orbital floor fracture, and this is the teardrop sign. Here we have taken a sagittal scan. In orbital floor fracture, we have taken a sagittal scan. This is this is the part which has been chipped away, and we can see here that there is kinking of the muscle, that is entrapment of the inferior rectus. This is kinking of the muscle, and there is also kinking along with that of the optic nerve. Here in case of a children, they are usually have a elastic sort of a bones, and so it has not been, it is not extending downwards, but we can see the teardrop sign that is infiltrating into the orbit. sinuses, sorry. So for superior wall fracture, here we can see this is a CT been done. CT is a preferable modality for trauma. So this is the superior wall. I'm going to skip. This is the intraocular foreign body. CT is the mainstay of intraocular foreign body diagnosis. And we should not be doing MRI as already been told because it can lead to damage to the part. These are the various tumors. Again, for tumors, if there is bone erosion, CT is a modality of choice if you are suspecting erosions. And if just soft tissue extension is there, then MRI is the imaging modality of choice. I'll be skipping over the slides because it's very long. So, this is the retinoblastoma, this is the retinoblastoma, and this is the ultrasound picture showing calcification. This is a uveal melanoma. Significance. Done. That's it. I will be completing my talk. It's a very, very long talk. I cannot be completed in 8 to 10 minutes even. Very, very long talk.
Thank you, Dr. Amit, for wonderfully making it so simple, such a complex topic where we usually, most of us, depend upon the interpretation given by our radiologist colleague rather than trying to interpret. And that's the basic reason why I wanted this particular talk to be included so that we also become familiar with the investigations which we order for. Thank you once more. And now I request Dr. Manisha Nada ma'am to come over. She is the professor at RIO Rohtak and also the president of AIOS. So, welcome madam. First lady, or I should say, or first what? Yeah. Yes. First lady and first lady president. Wow, great. So I request Dr. Tinku Bali as well as Dr. Manisha Nada to do the honors of giving the token of appreciation, please, once. I think we are moving in the scale of difficulty. We have moved from CT-MRI and now going to VP ERG again, which is a tough thing. Yeah. I welcomed you.
Nice. Good afternoon, all. Before I start my talk, I would like to say something on behalf of AIOS. Being the president of AIOS, I would like to thank ARC Chairman Dr. Prashant Kumar Keshav Bavankule for giving the opportunity, first of all, of his CME series to Haryana, and that to Sirsa. So a big round of applause for him. I would also like to thank the senior dignitaries here. Dr. Praveen Arora is there. Thank you so much, sir. Dr. S.S. Khurana, Dr. Chansing, sir, Dr. Jain, sir. And I also welcome the national faculty, Dr. Arvind Maurya, Madam Tinku Bali, and all other senior members. And dear friends, I start my talk. It's a great opportunity, I must say. It's a one-time, lifetime event to be sitting with the ARC chairpersons as a dais persons. So I was sharing the dais with them. Thank you so much. The talk is VP ERG EOG. Let's interpret, let's solve. So this is the college building, our hospital building. Dr. Chansing sir was the director of our institute. So evaluation of waveforms and the different and interesting case scenarios. Visual pathway, we all know, it starts from the retina up to the visual cortex. So we need to know the EEG activity at the visual cortex, which is recorded from the scalp, and the functional integrity of the central vision at any level of this visual pathway is detected by these electrodiagnostic tests. So VEP, first of all, I would like to say that it is flash and pattern. Flash VEP is done when the vision is very less than 660 in children, poor cooperative patients, and in hazy medias. So this is how we use a flash VEP. We use a small GANS field. It's a handheld kind of thing. And the picture on the left side is for the adults. So pattern VEP is one form where we use gray and checkerboard pattern which alternate with each other. And in pattern onset and offset type, this diffuse gray background which is presented on and off is changed and is best suited for malingering and nystagmus. Then is the pattern reversal VEP. It is used for clinical purposes. Most of the times we are using this. And the best corrected visual acuity, if it is 660 or better, it is used. And black and white checks, they are exchanged abruptly. And we note the components of the visual evoked potentials. So it is the latency and the amplitude. Latency in flash VEP, it is as N1P1, N2P2. In pattern reversal, it is N75P100, pattern onset offset, C1, C2, and C3. These are the different kind of presentations. These are the electrodes we use for carrying out the VEP tests. This is how they are placed. How we evaluate. This is the latency and amplitudes we know. Time taken for the stimulus to reach the occipital cortex. That's the time interval between stimulus onset and beginning of the wave response is the latency. Normal is 110 milliseconds. More than that, if it is up to the level of 120 or more, it is taken as abnormal. Serial measurements may be useful to monitor the course of the disease. Then VEP amplitudes, they are the difference from the trough of N75 to the peak of P100 represents the strength of the signal reaching the visual cortex. Normal value is up to 5 to 10 microvolts. If it is less than this, we take it as abnormal. So if it is done, if a steady state is reached and the lower sinusoidal kind of thing is there when we use rapid stimuli, and the normal kind of waveform is the upper one, where it is the low rates of stimulation are there. So visual cortex is the source of early components of the VEP. The early phase of the P1 component with a peak around 95 or 110 milliseconds is likely generated in the dorsal extrastriate cortex of the middle occipital gyrus, and the later negative component, that's N2, N150, it is from the deep parietal lobe. So normal waveform of pattern reversal, N75P100 wave is the one we take. This P100 is very important. Whenever we talk of any latency, we see for this P100 wave. Then pattern reversal VEP, the main measurements are of the size and timing of the P100 component, and amplitudes can be measured as N75 and P100 or P100 to 135. But in flash VEP, it is the N2 and P2 peaks which are important. Clinical applications, we all know optic neuritis, compressive optic neuropathies, malingering, hysterical blindness with opaque medias. We can use this, useful to explain visual loss in patients where they don't tell. In mature cataracts, we want to know the visual status potential of the patient, cortical blindness, and quinine toxicity. So waveform of the normal VEP, this is what we had done in our institute. This is the normal waveform. Retiport was the machine used. And this is the optic neuritis. We can see that VEP is showing normal latencies and reduced amplitudes. We can see there's a flattening of the waves in the left eye. Same is when we follow up a patient. You can see that in neuritis patient, it's a 145 P100 wave is 145 milliseconds. I told 110 is the normal, 145 is abnormal, so we label it as optic neuritis. In traumatic optic neuropathy, we can see in the left eye the waveforms are very flat now as compared to the right side. So this is the case where there is amplitudes are decreased. So traumatic optic atrophy, it's always the amplitudes which are very important, and in optic neuritis cases it is the latency. Latency, that is the P100 values are more important in optic neuritis cases. Then in orbital cellulitis with optic nerve compression, in this patient there was a right eye RAPD and VEP showed increased latencies and reduced amplitudes. Then for cortical blindness, both eyes pupillary reactions, they are normal, and VEP when we do it, they are always shown to have low amplitudes. Then in diabetic papillopathies also we can see that there are decreased amplitudes, and in latency it increases. So is with retinitis pigmentosa, albicans, or any kind of retinitis pigmentosa or sidrosis, or whenever the photoreceptors are involved. Then is the multiple sclerosis where there is optic neuritis. Again, we see that there are reduced amplitudes with increased latencies. This is the case. We can see very well that P100 latency, it is increased. It is 120 milliseconds. So is with optic atrophy cases. We can see the flattening of the waves in the left hand side. Then is the ERG. It is the graphical tracing of summated action potentials generated in retina in response to changes in the retinal illumination. So these are the electrodes which are used. These are DTL electrodes which are used in the conjunctival area. This is how we place the electrodes. The active electrodes, they are placed on the sides, and the reference electrodes and a ground electrode at the forehead. So rod responses, standard combined responses of rods and cones, and oscillatory potentials are the ones for scotopic kind of ERG, and for photopic type, these are the cones which are studied. So single flash cone responses and 30 Hz flickers are used. 30 Hz flicker is very, very important for any photopic kind when we want to know about the cone status in the eye. So mainly the B wave is studied in rod responses, and in maximum rod responses, which has to be read, that is both negative A and positive B wave is seen. A wave, it represents the function of the photoreceptors, and the B wave represents the post-phototransduction that is seen in the bipolar cells. Oscillatory potentials, they are the waves superimposed on the ascending limb of the B wave. It is easily detected in mesopic stage and are generated by hemacrine cells. These are the scotopic waves. And photopic responses, I said, a flicker is very important. In lower one are the flicker waves. If they are disturbed, that means the cones are affected. In cone dystrophy is highly important. And this is the normal wave, ERG wave. Then all the clinical applications in vascular disorders, very, very important. E wave is lost in choroidal vasculopathies as outer retina is supplied by the choroidal vessels. However, B wave is lost in inner retinal vasculopathies and other inner retinal ischemias. B upon A wave is decreased, oscillatory potentials are decreased, and flicker time, implicit time, it is increased in cases of inner retinal ischemias. As Dr. Prashant said in his speech, that in hypertensives, octa can be used. Much before the clinical presentation, I would say, even the electrodiagnostics are even earlier than we see in cases of diabetes as well as hypertension. So the first and foremost, if we go for a regular checkup of ERG, we can detect certain conditions. So ERG is sensitive to ischemia. It is 100% sensitive to ischemia. Diabetic retinopathy can be detected even before the NPDR signs they start showing. Oscillatory potentials are decreased, and we can avoid FFA by doing this electrodiagnostic test. In ischemic, CRVO is also very important. Both the eyes, they should have a difference of 7 milliseconds, or in one eye, if it is more than 37 milliseconds, is the flicker implicit time, it is ischemic kind of CRVO. In all cases of CRVO, we must get the ERG done. Ocular ischemic syndrome, again, it's a 100% diagnostic with ERGs, and here the B by A ratio is less than 2. Flicker implicit time is again more than 37 milliseconds. Intraocular difference is more than 7 seconds. If you see a retina where there are only few hemorrhages present and the vessels are very attenuated, we can go for this test and we can find out that there, yes, of course there is ocular ischemic syndrome, and we can save the life of the patient as well. We can go for a carotid Doppler or for MR angiography so that the patient is detected well in time only by seeing the fundus and doing the ERG. So then is the negative ERG. A wave is present, B wave is absent. This is called as a negative ERG. Congenital stationary night blindness, these are the examples, few examples, CRAO, X-leg retinoschisis, Cunene toxicity, and cone rod dystrophies. These are few examples where we do ERG, cone rod dystrophy. Pattern ERG is done in cases of glaucomas, and multifocal ERG is performed nowadays. It's a fashion. It should be done, and first of all we should do a full field ERG followed by multifocal ERGs. What is this multifocal ERG? It was first developed by Sutter and Trans. In 7 minutes, multiple responses are recorded from different retinal areas simultaneously. In full field ERG, which we do regularly, both rods and cones are seen, but however in multifocal ERG the function of only cones are seen. In full field ERG it's an electrical response, whereas in multifocal ERG it's a mathematical extraction. Full field is for the entire retina, and multifocal ERG is a topographic responses from different areas of the retina. So multiple ERG responses at different retinal locations at cross correlation techniques it is used, and simultaneously we pick up those areas, and it is used with multiple flickering hexagons from 61 or 103 focal responses over a 50 degrees diameter around the fovea. So this is how the stimulus is shown. This is the stimulus kind for multifocal ERG. These are the waves seen, and the indications of multifocal ERG, they are again diabetic retinopathy, dry AMD, and diagnostic and prognostic values in CSR, in Stargardt's, in children. We can see the normal wave in the upper picture. We can see that the central wave is very sharp, nice, bigger wave is seen, and a flattened wave is seen in cases of ARMD. So is with macular hole after surgery. If you wish to see the results, you can go and do a multifocal ERG, and you can see that yes, the fovea is getting its shape again. So EOG, in nutshell, electrophysiological test of function of the outer retina and RPE, in which changes in electrical potential across the RPE. It's recorded during successive periods of dark and light adaptation. This is how the
kindly wrap up this.
Yes, I am wrapping up in 1 minute. So this is the wave pattern which is seen, and Arden ratio is seen. Less than 1.5 is low, more than 2 are normal, between 1.5 and 2 are borderline. It's best suited for breast disease. Thank you. This is the waveform which I like the most, not the other ones. Thank you.
Thank you, ma'am, for a very illustrative talk. Now I'll ask Dr. Prashant sir to kindly come and I'll ask Dr. Nikita to kindly be ready for their presentation. And I'll also, I would like to facilitate Dr. Rajwinder also. Dr. Prashant sir, kindly facilitate Dr. Rajwinder, and Dr. Kanshuk Marwa, if he is in the hall. If you are here, come over to the stage. Dr. Rajwinder, speaker. Dr. Nikita's talk is fundus photography in ROP.
Greetings everyone, I'm Dr. Nikita Arora, Medical Retina Consultant in Dr. Praveen Eye Hospital and Research Center, Sirsa. And my topic today is fundus photography in ROP, that is retinopathy of prematurity. Before going into the details of the photography part, I would like to cover a bit about ROP. So with rise of preterm births, around 3.5 million annually, better NICU facilities, IVF babies, increased survivability, India is experiencing the third pandemic of blindness due to ROP. ROP is a fibrovascular proliferative disorder affecting the developing peripheral retina of the preterm infants. It is an avoidable cause of blindness in children if it is diagnosed timely and treated timely. Recent advances in imaging techniques like fundus imaging, wide field, fluorescein angiography, OCT angiography have provided additional insights to the pathogenesis, disease progression and response to treatment in patients with ROP. So the primary goal of screening is to detect all babies with treatable disease in time so that we can treat them and we can prevent blindness. Screening of all premature babies is a waste of time, as we know that all do not develop ROP. So for Indian scenarios, babies who have a gestational age of less than 34 weeks, birth weight of less than 2000 grams should be screened. Apart from these, the babies who are not in this data but they have had a very rough course in the neonatal units are supposed to be screened as advised by the pediatrician, and this is known as the Sirsa criteria. So to screen, binocular indirect ophthalmoscopy performed by an experienced ophthalmologist remains the gold standard for ROP screening, and the diagnosis is to be mentioned as the stage, the zone, the extent, and whether there is a plus disease or a pre-plus disease as seen by the treating ophthalmologist. So what is the role of imaging in ROP? Significant advances have been made in the last 2 decades to increase the viewing angle, speed, accuracy of retinal imaging devices. These devices are used for diagnosis, treatment and monitoring of the ROP. They help in better documentation of clinical findings, which can be useful especially in medical legal cases. They help in better counseling of the parents, especially convincing them for treating the baby. They can be used as a screening device by trained paramedics in developing as well as underdeveloped countries where there is a deficiency of ROP specialists, and thus help in bridging the gap with the help of telescreening. So the first method that we can use is video indirect ophthalmoscopy. Now this is the earliest method which is being used since a very long time to document fundus findings. Video recording camera is attached with your indirect ophthalmoscope. It is the only modality of imaging which has stereopsis in it. You can change the magnification and field of vision by using different dioptric power lenses. So it is cost effective, it is handy, it improves patient counseling. Wide field, as you can capture even lesions up to the aura with the help of scleral indentation. However, it needs good ophthalmic skills, indirect ophthalmic skills. Prolonged indentation may cause stress to the baby. You cannot perform fluorescein angiography. So the next modality is contact fundus cameras, and these include the RedCam. Now we have the RedCam 3, RedCam Shuttle, Phoenix Icon, Panocam, and our own made in India, the Forus 3 Netra Neo, made by a company in the Bangalore. So its advantages are that they have interchangeable lenses, so you can take anterior segment as well as posterior segment images. You can perform fundus fluorescein angiography in few devices. It is relatively baby friendly with less systemic fluctuations. It can capture anywhere between 100 to 130 degrees of the retina. However, it also needs practice. The probe is heavy. The size is large, so hence it leads to restricted mobility, and you may miss ROP in the zone 3. It is difficult to move around since the devices are quite huge, but except Forus 3 Netra Neo, which literally fits in a bag, and they are expensive. So the next option is the non-contact fundus cameras, and this includes the Optos and the Claris 700. So advantages are that it can capture up to 200 degrees of the retina, faster acquisition of the scans with a single click. So since it is quick, so there are no fluctuations in the baby parameters. However, it does have its shortcomings. It needs special training to hold the baby, as the baby is supposed to be held in a flying baby position. These are very expensive. They are not portable, and you can get artifacts like eyelid, lashes, and speculum. So smartphone cameras are the upcoming thing. For example, the Made in India RedCam. It uses a 20D diopter lens. It is a non-contact. It provides 43 degrees of the retina. It is portable, less expensive. Shortcomings are that it also needs training. It is difficult to capture anterior segment pictures with this device. It needs attachments for lenses other than 20 diopter lens. However, all these devices, for all these devices, you have to shell out an extra amount of money, and the more expensive devices are practically unaffordable for most of the ophthalmologists who are working in private practice. So now I'm going to show you a method by which you can capture images in ROP without using any of these devices. So what do you need? You need a dilated pupil, clear media, condensing lenses, any one that you have, smartphone with an inbuilt working flashlight, and screening instruments. So for that procedure, you have to dilate the patient's eye, position the patient, anesthetize, put an eye speculum, examine the baby, and then once you have examined and found the lesion that you wish to capture, you pick up your phone, you switch on your screen, your camera, start it on the video mode, switch on the flashlight, you zoom in, then focus the flashlight over your lens, like in the same direction as you had focused it before using your indirect ophthalmoscope. And if you wish, and you can take the video. If you wish to image the periphery with this method, you need the help of an assistant who can either hold your phone, or who can either indent. So once recorded, you can either use the video as it is, or you can take a screenshot from the video as shown in the last image. So what are the advances? Advances are that it is cost effective, it is handy, everybody has, whenever you are going for screening, you have your indirect, you have your lenses, and you have your smartphone. So you don't have, there is not an additional burden that you have to pay for any instrument, and it genuinely improves patient counseling. However, it does need practice. It is not wide field, although you can capture peripheral lesions with the help of your assistant, and you cannot perform fluorescein angiography. So these are the few images that I have taken during the ROP screening. The first image shows plus disease, second has aggressive ROP, third is freshly lasered ROP, fourth is, you can see this pre-retinal hemorrhage which was taken in zone 3, and last is zone 1 ROP. So in nutshell, taking better images helps better documentation, and it helps to counsel the patients that look, the vessels are dilated, this is plus disease, and the baby needs treatment. Thank you.
Thank you, Dr. Nikita. Very nice talk. I will ask Dr. Manisha ma'am to kindly facilitate Dr. Nikita for an excellent.
Everyone should be.
And I'll ask Dr. Prakhar to kindly be ready with their presentation. Okay.
Dr. Kinshuk.
I'll ask Dr. Manisha ma'am to kindly stay for Dr. Kinshuk. Kindly facilitate Dr. Kinshuk also. Dr. Manisha ma'am. Facilitate Dr. Kinshuk also. Dr. Kinshuk as a speaker. Dr. Prakhar Goel.
So, just lunch, I'll not take much of your lunch time. तो भगवान ने जब बीमारियां भेजी तो उसके साथ एक दो टेस्ट भी भेज दिए उसको ठीक करने के लिए, लेकिन जब यूवीआइटिस बनाया तो उसको पूरी की पूरी फोर्स भेज दी साथ में टेस्ट की, और ये जो पूरी फोर्स थी इसको कहाँ लगाना है, कैसे यूज करना है, ये नहीं बताया. आई डोंट नो इफ द स्लाइड्स आर एडवांसिंग ऑन इट्स ओन. So for that I will try to decode this for you guys, and at the outset I would like to thank AIOS, HOS and SFOS for providing me this opportunity to present in this wonderful symposium. I have no disclaimer. So uveitis, as we know, it's an intraocular inflammation affecting uveal tract, vitreous and retina. It's a third cause of blindness worldwide, and etiological diagnosis in this case is important for prognosis and therapeutics. But etiology remains uncertain or unknown in 28 to 45% of cases, and hence your clinical acumen, your history taking remains very important. 70% of diagnosis can actually be made on history and clinical workup alone. So how do we proceed with a patient of uveitis when you see in clinic? You have a patient in clinic, you do a complete history taking and review of symptoms and signs, which include the both systemic as well as ocular history. You do a detailed ocular examination, which includes slit lamp and fundus in all patients, along with gonioscopy, FFA and OCT in selected cases. Then, this is the most important point, to classify the uveitis on the basis of the anatomical location, that is anterior, intermediate, posterior and pan-uveitis. Once this classification is made, you arrive at a differential diagnosis which is based on your regional epidemiology, history, intraocular signs and clinical classification. And then come last the stepwise diagnostic workup, which is a three-step approach which I'll be explaining. Before that, I'll just talk a small point about two things, which is snout and spin, that is the sensitivity and specificity of a test. Sensitivity of a test, it basically rules out the disease, whereas specificity of test is basically it rules in the disease. Now the first step is the investigations which are to be done in all the cases of uveitis, no matter their anatomical locations. These steps are CBC, ESR or CRP, a tuberculin skin or a Montus test, syphilis serology, that is TPHA or VDRL, a chest X-ray, and LFT, KFT and RBS. Basically I do LFT, KFT and RBS in all the patients in which I am planning to start on immunosuppression to have a baseline values. So CBC, the most important thing to note in CBC is the lymphopenia, which is a strong predictor of sarcoidosis. ESR and CRP, they do not have much contribution to the etiological diagnosis, but they are just a marker of inflammation. Tuberculin test or a Montu test is very important in a country like ours, which is endemic for TB, and we also need to rule out a latent TB before initiation of any treatment. Value more than 15 mm is diagnostic, but in our country even value of more than 10 mm is considered to be positive. A skygram or a chest X-ray is important to rule out sarcoidosis as well as tuberculosis, but we rarely see in cases of intraocular tuberculosis the chest X-ray to be positive. And syphilis. Why syphilis? Because syphilis is rarely seen, but then it is a great masquerade and it can present in any form, and we are seeing a resurgence of these cases in recent times. So a reverse screening algorithm is used for these diagnoses, which includes a treponemal test followed by a non-treponemal test. The non-treponemal tests, they have high specificity but low sensitivity, and treponemal tests, they have both high sensitivity as well as specificity. Now we go, once we have a diagnosis, we go on to the second step. These are the tests which are elucidated in the second step. We'll talk one by one. HLA-B27, it is the most important test when it comes to acute anterior uveitis. Spondyloarthropathy is diagnosed in more than 40% cases after the first episode of uveitis, and ophthalmologists are the one to diagnose it. This is the duet algorithm which is used, and in this duet algorithm, it is stated that the presence of backache and then positivity of HLA-B27 has a very high sensitivity of 95 to 98% of specificity. Second is the serum ACE levels, which are used to diagnose presumptive diagnosis of sarcoid uveitis. But important thing to note over here is a patient who is on ACE inhibitor, you should take that in caution because it makes this test uninterpretable. CT chest or thoracic scans give a good amount of information about the sarcoid, as well as they are going to tell you about the calcification of hilar lymph nodes, parenchymal calcification and scarring of the apex. TB quantiferon gold. This is a very important test in our country because of its endemicity, and it is considered, though the gold standard is identification of TB in eye by PCR or biopsy, but the dual strategy of testing MON2 and a quantiferon TB gold holds very good for ruling in the disease. Now in my patients, I actually, if I have a diagnosis in mind of tuberculosis, then in first step only I get the TST as well as the TB quantiferon gold done. Because if the test is positive in 2 tests, then it pays patient, we can take the patient more into confidence for starting any anti-tubercular treatment. And serology for toxoplasmosis, though in Western literature they have given an emphasis on doing a serology, but as we all know that toxo is primarily a clinical diagnosis and serology is rarely required. Step 3, if we have not reached onto any diagnosis even after these, then the step 3 comes into picture, which is an AC tap for PCR or for CMV, which is done in the steroid resistant anterior uveitis cases, atypical uveitis, or for recurrent or chronic anterior uveitis. Now the immunological tests, which are rarely required, and we should not be doing these tests at all when we need to diagnose a case of uveitis, because the positive predictive value of these tests is very less. They should be only limited for anti-nuclear antibodies in children, suspected idiopathic juvenile arthritis, or in case of peripheral polyarthritis. Now we know that multiple sclerosis is a main cause of intermediate uveitis, but that doesn't mean that you have to do a cerebral MRI for every case of intermediate uveitis. You only do when you suspect these cases in case of neurological signs suggestive of CNS involvement, bilateral papilledema, or a suspected PIOL. Extra open investigations which are rarely performed are these. It is moving very fast. Minor salivary gland biopsy, bronchoscopy and bronchoalveolar lavage, lumbar puncture, and these tests are rarely used. Diagnostic vitrectomy, which is a very, why is it turning? Which is I think he also wants to go for the lunch. So it is a gold standard diagnosis for the, now we talk about the stepwise approach. We do a clinical examination, then do a minimal routine workup in all cases, investigation which is guided by our clinical findings. If we have a diagnosis, then fine. If there is no diagnosis, then we do the investigation according to the anatomical type of uveitis. If we have a diagnosis, then fine. Otherwise, in rare scenario, we go to the third test and do all the extra open investigations. This is the list of all the investigations which can be performed in the cases of uveitis. So, to end my talk, I would like to say that establishing a laboratory proven etiological diagnosis may not be possible in 40 to 45% of cases. Emphasis on history and clinical examination cannot be stressed enough. Always make a diagnosis based on anatomical location and then order appropriate investigations. Know your investigation as in when, what and why to order and how to apply in practice. And stepwise approach is the best and most cost-effective way of management. Thank you.
Thank you, Dr. Prakar, for wonderfully making it so simple, the investigations which appear to be otherwise. What we do is, in our country, definitely we order in toto, and that's why the costing definitely increases without much productivity. Making it so simple. Thank you, Prakar, for that.
Thank you.
Now I request Dr. Tinku Bali to hand over the memento to him. So before we break over the lunch, just an announcement. We have a quiz by Dr. Ashish Lal and Kapil Midha at 4:45 p.m. The students, especially even the comprehensive ophthalmologist practitioners, can also participate in the quiz. They can form the teams and they can also report to who is in charge of it for that. They are supposed to. Okay, we will let you know. But form teams, that will be great, especially for students.
All the panels. Now now I would like to call upon certificates के लिए हाँ नीचे से start. The certificates are being given at the registration counter. Secondly, I will ask Dr. Nagpal sir to kindly come over and give facilitation to all the panel members. Dr. Nagpal sir. हाँ जी हाँ. Very nice talk, Dr. Prakhar. Very nice. Firstly, I'll call upon Dr. Prashant. Kindly come over. फैकल्टी इनमें कुछ नहीं थे पैनल के अलग हैं फैकल्टी डॉक्टर टिंकू मैम काइंडली कम ओवर डॉक्टर मनीषा मैम डॉक्टर राजविंदर मैम प्लीज कम ओवर डॉक्टर रमन डॉक्टर गौरव डॉक्टर
Kindly, all the speakers kindly stay for the group photo of this session. And please be near the dais.
Thank you. Okay, thank you. The next session will start sharp at 2:30.
शुरू देख दो
वेट तो कर ही रहा हूँ मैं डॉक्टर राजीव जान के पीछे अभी हम पंचुअल चल रहे हैं सुबह से कोशिश हमारी यही है नहीं We are starting with our fourth session, glaucoma diagnostic. Our chairperson is Dr. Rajiv Jain. Panelists are Dr. Urvish Vashisht, Dr. Sanjeev Jindal, Dr. Manpreet, Dr. Mahesh Unida. We welcome our chairperson, Dr. Rajiv Jain. Now we start with our first session, viewing the angles by gonioscope. Singh will present the case.
A very good afternoon to everyone. Myself Dr. Reena Singh, a 5-month-old glaucoma surgeon. I am here to present my talk on gonioscopy, viewing the angles. Gonioscopy is a clinical technique used to examine structures in the angle of an anterior chamber. Trantas for the very first time using limbal indentation in an eye with keratoglobus visualize the angle of anterior chamber. As we all know, the angle of anterior chamber cannot be visualized directly through an intact cornea because light emitted from angle structures undergoes total internal refraction. The gonio lens eliminates this phenomena, that is total internal reflection, by replacing the cornea-ear interface, which has a refractive index greater than that of cornea and tears. There are various methods like direct gonioscopy and indirect. In indirect, we used to do indentation and without indentation. In direct gonioscopy, the interior curve of the gonio lens is such that the critical angle is not reached and the light rays are refracted at contact lens air interface, provide the direct view to the angle. There are different types of the lenses. Kopay is the most commonly used diagnostic direct gonioscopy. It is easy to use, provides panoramic view of the angle. And in case of infants, a small Kopay lens that is Richardson-Schaeffer's is used, and for anchors the cornea by partial vacuum we use Worth, and the gonio lens which floats on the cornea is Seebeck, and the prototype surgical gonio lens that is used for goniotomy is Huskin-Barkens. We use a binocular microscope and use this technique. Examiner holds the gonio lens in one hand and the light source in the other hand and scans the anterior chamber angle by shifting his or her position until all 360-degree have been studied. What are the advantages of the direct gonioscopy? There is a greater flexibility and it gives a panoramic view. It is easy to see the angles, can be used in infants, provides straight view, allows retro illumination. And if there are some advantages, there should be some disadvantages also, and that are the annoying light reflexes from the cornea. It is time consuming. Benefits of slit lamp like variable light and better clarity are not available. In direct gonioscopy, in this, the light rays are reflected by a mirror or prism in the contact lens and leave the lens at nearly a right angle to the contact lens air interface. It provides the mirror image of the opposite angle. The technique, after anesthetizing the cornea, the coupling gel is inserted into the cup of the gonio lens. Gonio lens is then placed and tapped onto the cornea. Slit lamp beam is focused on the mirror, which shows the inverted angle image, like this, as shown here. Gonio prism non-indentation. Surface is slightly larger than that of the cornea and require coupling gel. There are various lenses like Goldman single mirror, 3-mirror, Allenthorpe. The technique, varying amount of pressure applied over the cornea with a tear coupled indirect contact lens. Examiner observes the effect on the angle width. Increased pressure indents the central cornea and displaces the fluid into the angle, opening it wider, as can be seen here. Gonio prisms that are used for indentation gonioscopy can be Vogt 4-mirror, Sussman 4-mirror, Tokel single mirror, Posner 4-mirror. The 4-mirror gonio lens have 4 identical mirrors that are angled at 64 degrees, which allow examination of the 4 quadrants without the rotation of the gonio lens. The contact surface of the lens has diameter of approximately 9 mm. This is Sussman 4-mirror that is similar to Zeiss but has no handle. Posner, similar to Zeiss but made up of plastic. Advantages, easy to perform when mastered. easy to perform when mastered. That is true because I have faced this thing. Now gonioscopy appears to be very, very easy to me when I have learnt it by heart. All 4 quadrants can be seen when 4-mirror gonio lens is used. With slit lamp, variable magnification and illumination can be achieved. Indentation gonioscopy can be performed, which allow differentiation of appositional and synechial angle closure. Coupling agent is not used, so it is comfortable for patient also. So visualization of fundus and photography is possible. Disadvantages, as I earlier said, it is difficult to master, but once mastered, it is a great tool. Mirror image can be confusing, may open the angle artificially if pressure is applied. Gonioscopic view of the angle structure. I usually start from posterior to anterior when I was in the learning phase, that is starting from the ciliary body band, scleral spur, pigmented trabecular meshwork, non-pigmented trabecular meshwork, and the Schwalbe's line. Schwalbe's line, it is the most anterior structure, 50 to 100 micrometers. Peripheral termination of cornea where the descent membrane ends. Best identify by locating the corneal wedge. Trabecular meshwork, it lies between the Schwalbe's line anteriorly and the scleral spur posteriorly, and smooth in infants but become coarse and pigmented with age, and anterior part is non-functional and non-pigmented. The posterior functional part has a grayish blue translucent appearance. This posterior portion overlies the canal of Schlemm from where the aqueous humor escapes from the anterior chamber. Scleral spur, anterior-most projection of the sclera, situation just posterior to the trabecular meshwork, appears as a narrow, dense, often shiny whitish band. Ciliary body band lies just behind the scleral spur as a pink to dull brown to slate grey band, portion of ciliary body which is visible in the angle as a result of insertion of iris into the ciliary body. Then the root of iris, and after that iris processes. Angle grading system for gonioscopy. There are various grading systems, several grading systems like Schaeffer, Scheiss, Spieth, RPC Center, that is a modified grading system. When we used to draw the diagram, we used to write like 0 to scleral spur. Then we have to mention that which grading system are we using, either Schaeffer or Scheiss. Because in Scheiss, grade 4 is the close angle, like only Schwalbe's line invisible, while in Schaeffer, grade 4 is the widest angle. In Spieth gonioscopic system, we use the Fourier approaches like iris insertion, angular approach, peripheral iris, and the pigmentation of trabecular meshwork. Difference between the Schaeffer classification and the Spieth classification. There is RPC Center grading system. Now the clinical uses, it can be used for diagnostic as well as therapeutic purpose. Differentiation between the angle closure and the open angle glaucoma. To diagnose secondary glaucomas like angle recession, uveitic glaucomas, diagnose tumors of anterior segment, early detection of KF ring, and the therapeutic role is to perform argon laser trabeculoplasty, laser iridoplasty, laser sclerostomy, goniotomy, and trabeculotomy. The limitations are it cannot be performed in painful inflamed eyes, cannot be performed under mydriasis, in hyphema, in case of compromised cornea, lacerated or perforated globe, and complications it can cause like corneal abrasion if not done in a proper manner. Gonioscopy is used in the pathological condition like angle closure glaucoma. The angle is first occluded appositionally, followed by a sticky adhesion, and later on the peripheral anterior synechiae over wide area. Peripheral anterior synechiae, these are not pathognomic of any single disease entity, tend to form first superiorly in angle closure glaucoma, inferiorly in uveitis, and anywhere in post-traumatic cases. Now how we grade it is an appositional or synechial closure on open angle. If scleral spur is visible 360 degrees, we record it as open angle. If visible less than 180 degree, do indentation gonioscopy, any synechiae. Yes, then it is a PAC, primary angle closure. No, then we have to look for the IOP. If IOP is raised, yes, then it is a PAC, appositional angle closure. And if no, it is PAX, primary angle closure, suspect. Plateau iris configuration and syndrome, we have to look for the sine wave and double hump that we can see with the gonioscopy. In cases of pigmentary glaucoma, heavy pigment dispersion in the trabecular meshwork. Neovascular glaucoma, neovessels are formed on the iris known as rubeosus iridis, which is frequently associated with severe form of glaucoma known as neovascular glaucoma. Pseudo-exfoliation glaucoma, typically we look for the sample as the line. Exenfield anomaly, prominent Schwalbe's line and abnormal iris processes as can be seen here. It is very important case of angle recession glaucoma. Once a patient came who was having a optic neuropathy in one eye, and we were not able to find out the cause. Then we did the gonioscopy, and it come out to be angle closure glaucoma, angle recession glaucoma. As patient himself forget about the trauma he had earlier in his life. Miscellaneous gonioscopic finding like iris melanoma, lens haptic. I just want to discuss here, gonioscopy is that important. Right now I'm dealing with 2 failing blebs. I did gonioscopy on both the patients. In one patient the ostium was patent, so I planned for bleb needling, but in another patient the ostium was blocked by the peripheral iris. So the line of treatment then changes. So gonioscopy itself is a key to master. We should learn. Thank you so much for giving me this opportunity.
Thank you, ma'am. Thank you, ma'am. This is a wonderful talk. I pronounce to Dr. Narendra Taneja to please facilitate our speaker, Dr. Reena. Dr. Rajiv Jain for next talk. उधर लग जाएगी. Pointer. Dr. Gaurav.
Well, good afternoon to you all. I take this opportunity to thank you all, respected seniors, colleagues. Quickly going on to the presentation part. So today's probably this glaucoma imaging symposium is divided into all these things which will be discussed one by one by all of the speakers. I have been interested with the talk on GDX, HRT and OCT angiography. Probably these are the 2 spectrums. Everything in optic nerve head imaging started with GDX and the HRTs, and probably it is going towards the OCT angiography as a newer modality to analysis of the optic nerve heads. So this is no more in use in majority of the centers. I personally had this experience way back in 2005 only. So that was the only time when we probably captured these images. It was later replaced by OCT. So maybe I'll just quickly review on this. This is an image actually which needs to be. Can I have the collar mic?
Collar mic, hand mic.
So if you see this particular image actually has to be. So if you see this particular image, complete image actually has to be kept in mind, because this kind of image, whether it is GDX or HRT or OCT, you will keep on seeing these images and these kind of parameters. The diagnostic modalities have changed. It's okay. The diagnostic modalities or the imaging techniques have changed, but the interpretation of the data and the parameters which we take into consideration practically remains the same. So this slide probably has meaning only on this. This just highlights a normal GDX analysis. These are the fundus imaging or the optic nerve head imaging. This is the deviation of from the normal. As you can see, there are this particular thing is all normal in this. In this particular analysis, what is important to interpret is the red signs are not red. Actually, red is normal. So the blues are they are the flat areas, or the RNFL is thin in that particular area. And these parameters, double hump signs, I'm sure every one of us is seeing these. So this all started, the double hump signs, the fundus imaging, the optic nerve head, parapapillary zones, this all started, the analysis pattern, it all started with GDX. So probably it's of historical importance, but it actually is kind of, the analysis pattern is a father of all the optic nerve head imaging which is yet to come and which has already been in practical use. So these are again the slides. On the right hand side you can see it is just the left eye of the patient actually is diseased, the right eye is normal. This red zones, these are actually the deviations, that is the thinning. You can see this is blue. All blue is that the retina is flat over here, the RNFL is thinned out over here. The red and yellow indicates that it's a normal retinal fiber layer. This is a on the right side, this is a bilateral disease. And you can see all the blue zone, this is both these superior and inferior neuroretinal rims, they have been knocked out. So moving on to the second, this is Heidelberg's retinal tomography. Again, only a few of the centers from at least North India. I just see one of the centers in Delhi actually who has this machine, and maybe PGI people, they have this machine, but it is not being regularly used to monitor the disease progression, but it is primarily being used for research as a research modality, because it gives a very in-depth analysis of the optic nerve head. So I had this opportunity way back in 2005 and 6 when I was in PGI to use the HRT module 1. So now it has got advanced to HRT 3 module with a lot of investigation, Moorfield's regression analysis, the glaucoma progression analysis, which has got into this. So briefly telling you this, why is it better than GDX? Because GDX used to give us a 2-dimensional image, while this gives us a 3-dimensional image. It requires the image starts from the vitreous interface and goes deep into the optic nerve head. So these serial scans which are taken, then they actually are sealed together to give us a 3-dimensional image. So series of images are taken from anterior going to posterior and gives us a 3-dimensional image. So this is how the scans are taken, and it just generates a 3-dimensional image. The importance of the reference plane, in case one of us, I'm sure a few of us must be getting these HRT scans at least for review, even if you don't have the machines. So it is important to at least know what is there in the HRT report. So there is a reference plane basically in this. The reference plane basically indicates what is to be taken, what is above and what is below. So this is by rule, it has been fed into this that 50 microns from the surface of the inner limiting membrane posteriorly is taken as a reference plane. Anything above is taken above the optic nerve head, anything below is the cup. The second important point in this HRT measurements is the contour line. If you do not draw the contour line correctly, now in the newer machines obviously the machine in itself takes up these contour lines, but if you do not draw the contour line properly, everything goes haywire. So this was the drawback in HRT 1 and 2. So why it got better? Because it was giving us a 3-dimensional imaging, so we could get the cup and rim volumes and the areas dimensions which were not there available on the GDX. So the parameters increased, and it was found actually the cup volume to be the best correlating factor in the disease progression and its relation with the visual field parameters. So these are the reports. I'm sure a few of us who are actually into glaucoma practice, they will be seeing these reports. So we should actually be a little bit aware about what all these reports indicate. As I was telling you in GDX, the report parameters remain the same. So it is important that this is an optic nerve head. These ticks indicate the nerve fiber layer is in the normative database zone or not. And this is a double hump. This is a classical sign which tells us the RNFL in the superior and inferior zones. So if this is well within this green zone, it is normal RNFL thickness, and if it is obviously in the red zone, it is a thin RNFL. The pattern of the graphs remain the same. So that is how the things have grown. So what is the difference? The difference in how do we acquire these images. So what is new in HRT? This is HRT 3 glaucoma. It is precise, more predictable, powerful and portable. They have added a lot of softwares into this, which includes the advanced glaucoma analysis. There is glaucoma probability score is there, and there is a progression analysis software in this, which gives us a structural interpretation of the imaging in a much better way than any other instrument. So this is a GPS printout. This is a glaucoma probability score. So this is just this is the first image the patient we acquire from the patient, and this is how it grades into whether this falls into a disease category or not. So it has multiple quality parameters. There is a ethnicity parameter is there. So it gives us the idea whether this patient, on the basis of the structure, does it have a disease or not. So this is probably the most advanced analysis software based on optic nerve head imaging which is available till date. So this is the TCA progression report. This is topographic change analysis progression report. As you can see, this is a change in the structure, and it can be well documented on this machine. So we need a serial photograph, as is there in glaucoma progression analysis in perimetry, which is more commonly available, more commonly known. So something similar has been given by the HRT team, and this is called topographic change analysis. And you can see serial scans have been taken, and the thinning is reflected in the red zones. So the powerful new tools which the HRT has incorporated is on-screen cluster analysis there. The change indicator areas of statistical change are highlighted in red and green. The magnitude of change is shown in the color gradient. So cluster analysis, contiguous areas of change are mapped and tracked for both area and the volume. The blue circle represents the contour line. So contour line is the key in HRT. So it is very important to identify the edge margin. So you can well imagine, I'm sure everyone must have seen the myopic disc, the tilted disc, which just give us the right contours of the disc margin. So the machines do fail in acquiring the images of these, and the analysis over there has to be done manually. So the third part of the talk would be on OCT angiography. It is a very, very new tool, has not been used as a primary diagnostic tool or for progression analysis, but yes, I would like to add, this might be a track somewhere around 20 years back. Even OCT was not considered as a tool to be used in glaucoma, but probably it has become now a standard of care in management of, in diagnosis of glaucoma, or at least even in the progression of the glaucoma. So as we all know, blood flow and glaucoma, they are very intricately linked to each other. Probably 10% of the glaucoma patients in everyone's clinics, they are unexplained loss of nerve fiber layer is there. So how do we explain that? We always tell that this patient probably has a blood loss somewhere in one or other form. So what changes have happened, we do not know. These are the different instruments which have been used, but none of them actually has stood the test of time. The angiographies, the Doppler ultrasounds, the Doppler OCTs, laser Doppler flowmetry, and laser speckle flowgraphies. These do measure, but none of them has been reproducible. So I'll just rush through some of these slides. Why OCT angiography? It is non-invasive, it is highly repeatable and reproducible, takes just few seconds. How does this OCT angiography work? It actually works on the basis of, it detects the blood flow. Since it detects the blood flow, so the major pitfall in this is that it has to be very fast. As you can see in this, the moment the patient moves the eye, everything goes haywire, because it tracks the blood flow based on the movement of the RBCs in the blood flow, in the blood vessels. So if the patient moves, everything goes haywire. So where to look for? Do we take the pictures at the optic nerve head, or do we take the pictures at the macula? So it has been initially, obviously, optic nerve head looked very fine, but the nerve fiber layer over there, it actually overlaps the optic nerve head blood vessels and doesn't let us have the correct analysis. So it was the focus has now been shifted to the analysis of the macular vessel density analysis. So over there in the macula also, there are vessels which can be analyzed, and there is perfusion which can be analyzed. So vessel density is important, and the perfusion, perfusion indices, both are important. Even perfusion index, this tends to vary, as every one of us knows that the blood pressure varies, the perfusion of the blood flow changes. So perfusion also has taken a back seat. Now it is a vessel density, the number of vessels which are there on the scan. This is called N-phase scans. So N-phase scans, number of vessels which are there, which actually allows us to interpret whether this particular area is related to glaucoma or not, the damage is happening or not. So flow rate or vessel density has been taken over the flow rate also. So different vessels which are incorporated in its analysis. So why OCT angiography, why it scores better than OCT probably, is there is an effect called floor effect. We all know in advanced glaucomas, even moderate glaucomas, once this RNFL loss happens to say around 50 values, even if the disease is progressing, we still are not able to pick up the disease only on the structural analysis. So this OCT angiography, since it's based on the vascular aspect of the optic nerve head or the macula, so the floor effect, even in advanced stages, it keeps on showing the progression. So this probably will score over the structural analysis on the optic nerve head, but the time will tell whether it stands the test of time or not. So what is the potential? It not only actually gives us the OCT. Just last slide. So this is no doubt it has a diagnostic importance as of now, but as of now it is probably a research tool. There's a lot of data which it generates and a lot of data which actually can be used in research, in PhD, or in our MD thesis. So just to show you, this patient actually has a GCC loss, has an almost normal RNFL, normal fields. This patient has a early defect over here, and in the left eye, the perfusion. I'm sorry for the poor pictures. The vessel density over in this particular patient actually has decreased. Whether it relates to the disease or not, we do not know. There's a lot of variations, a lot of things which actually have to be seen. But this is just a teaser to our minds that what is OCT angiography, is it useful or not. So as of now, this is just slides which highlights that GDX and HRT probably have taken the sides. Perimetry and OCT still stays. OCT angiography might be the destination to follow. Thanks a lot. Thanks for your patience.
Thank you, sir. Thank you, sir. I invite Dr. Prashant and Dr. Manisha Nada to facilitate our speaker, Dr. Rajiv Jain. Dr. Nada, please stay. Please stay. I invite Dr. Tinku Wali to the stage. Dr. Prashant, Dr. Manisha Nada, Dr. Praveen to facilitate. Ma'am, please.
इनॉग्रेशन टाइम आप लेट हो गए थे ना, थोड़ा वेट किया आपका, लेकिन चीफ गेस्ट आ गए थे।
कोई बात नहीं, टाइम बहुत कॉम्पैक्ट है। I invite Dr. Arvind Maurya, national speaker. Thank you, sir. Thank you, sir. Please take seat. Now, Dr. Urvish Vashist give talk in the OCT in glaucoma.
Yeah, good afternoon. And first of all, I'd like to thank AIOS, HOS, and SFOS for inviting me to be part of this wonderful meet. After Dr. Rajiv has described the things that we very uncommonly see, now coming to the things that we commonly come across, that is OCT in glaucoma. Nowadays it has become an indispensable tool in the management of glaucoma. So we all know that OCT stands for optical coherence tomography, introduced in 91, and it uses infrared light to access the tissues of the eye. So we know that today most of it is spectral domain, time domain is hardly used. So what does OCT do? It accesses the optic nerve head and macula and anterior segment. So how does it assess the ONH, that is the optic nerve head? It takes a 6 by 6 mm cube around the optic disc, and it does serial scans of this area, and a circle of 3.46 millimeter diameter is positioned around the center of optic disc, and multiple RNFL measurements are done in this area. So this is a standard OCT printout of the patient who is standing on the dais. It has so many parts. So at least 7-8 parts are there. So the most important factor is to read this report carefully and give our interpretation. So let's start step by step. The first thing that is on the top of the report is the demographics and the signal strength. In demographics, it's very important to note the examination date and the date of birth, because if examination date is wrong, suppose at times they enter a wrong year, then the whole of the interpretation would go haywire. So it is very important to recheck before we interpret the report. And another important thing is the signal strength. It has to be at least 7 to give a reliable finding or reliable report. So what is this signal strength? It is the quality of the image that the machine is able to capture. And causes for poor signal strength are media opacities, including dry eye, cataract, corneal scars, vitreous hemorrhage, a miotic pupil, irregular astigmatism, and not to miss the unclean optic lens, because most of the cases, most of our clinics, it's the technician who is handling this machine, and at times it is done carelessly, and which gives rise to a lens like this with lot of scratches, and that will make the machine useless. So we should create an SOP for lens cleaning and ensure its strict implementation. So next in is the RNFL thickness map. Here the red is good. That means the red means the thicker RNFL layer, and a blue, more blue will mean thinning of that area. So next comes is the RNFL and disc parameters. So these are the all parameters we are very familiar with, like RNFL thickness, symmetry, rim area, disc area, average and vertical CD ratio, and cup volume. Here green means the values between 5 to 95% of the normal database, yellow means values which are between 1 to 5%, red means values lower than 1%, white means values which are more than 90%, 95% of the normal database, and for gray means the database is not available for comparison. So disk area is always gray because of the wide variation in the disk area in the normative database. So in all reports we will find disk area to be gray. What pattern deviation is for HVF? RNFL deviation map is for OCT. It is very important to see because red or yellow areas around the RNFL area will denote RNFL loss. Nasal or temporal defects are usually not due to glaucoma, and we should always look for break in the blood vessels here. We can see these are breaking, that's a motion artifact, and we should take such reports with a pinch of salt. So this scan gives the maximum information about the glaucoma. Then standard Tisnett curves, which are very similar to what we see in GDX or HRT. So any of these curves dipping down into the yellow or red area, it indicates the RNFL or the rim loss. Then comes the RNFL thickness map, which is usually on the down. It has got two types. The one is the quadrants and other is the clock hours. We should always see both of these. And at times it's possible that the quadrant map is absolutely green, whereas we can find yellow or red areas in the clock hour. And then these are the horizontal, vertical and the circular tomograms. So why are these there? It's because they should be well in the center. The image should be clear. If they are not clear, or they are either just above the upper margin of this, then image might not be very clear. So we should take such scans again with a pinch of salt. Next comes the ganglion cell complex analysis. Why is it important? Because it can detect early glaucoma, it can detect progression in advanced glaucomas, it can access glaucoma in myopic eyes, and it also helps in risk assessment. That is, thinner GCC at baseline is significant predictor of future past progression. So this is how GCC looks. There are scans of 6 by 6 cubic millimeters centered around the fovea. So I'll now move a little fast. So this is the GCC demographic data, similar to the RNFL, and shows the thickness map. It should be, it should not be blue here. It's warm colors are good. And then this is the deviation map. It will show red if there are some GCC loss, and that is the horizontal B scans. So again, to show this, it has got an ONH. We can see a defect here in this scan, and here also we can see some defects. So if you see here, the date of birth and everything should be checked. It's got a good signal strength. Then we can see the blue areas here, which denote RNFL thinning in both the eyes. Then these red areas denote RNFL thinning here. So right eye shows the superior thinning. Now this is important in GCC. This is the temporal raphe, which could be an early sign of glaucoma. I'll just try to hurry in another 1 minute. So GPA can also be used to assess the progression of glaucoma. So temporal raphe sign is very important. And it can also be used for the anterior segment, as in assessing the angle. Studying the bleb morphology, we can really study the bleb very well. This is an avascular bleb, again a bleb compartment. There are 2 compartments. We can see the posterior and the anterior. But the limitations are that it is an expensive, so database of less than 18 years is not available. It is not useful in very advanced glaucomas. So to conclude, OCT is indispensable in glaucoma management. Both ONH and RNFL and GCC scans should be done, and more useful in early to moderate glaucoma. Has a special role in normal tension glaucoma and pre-perimetric glaucoma, and it has a role in documentation in angle closure glaucoma to study bleb morphology and to study the tube's position, and it should be judiciously used. Thank you so much.
Thank you, sir. Wonderful talk. Now I invite Dr. Chand Singh and Dr. Mahesh Ujja to please facilitate our speaker, Dr. Urvish Vashist.
प्रेजेंटर मोड कर दिया ना, कर दिया।
Next speaker be ready. Thank you, sir. Our next speaker is Dr. Astha. Step-by-step interpretation to read Humphrey versus octopus visual view.
Good afternoon, everyone. I'm Dr. Astha Bajaj Marwa, and let's have a step-by-step interpretation on how to read a Humphrey versus an octopus visual field. So before going on to the octopus, we should know what is the pattern, strategy and the technique used in an octopus, as we are quite familiar with the Humphrey already. So the test pattern in an octopus are a G pattern, M pattern, F and N pattern. The test strategies used are tendency oriented perimetry, also called the top, and the dynamic. The technique is same, white on white perimetry. So when we see both, the test patterns are G, which corresponds to the 30-2 or the 24-2 of a Humphrey. The strategies are same, dynamic or top. For the macular program, that corresponds to the 10-2 of the Humphrey. It is called a M program or a macular program, and the strategy is again same, that is the dynamic or the top strategy. This is an overview of the different test patterns and the test strategies available in an octopus field. So the G pattern is the most commonly used test pattern, and it contains 59 points that are arranged along the retinal nerve fiber layer distribution. The M pattern, on the other hand, has 81 points with high density of test location at the fovea, mostly used for macular disease, drug-induced maculopathy, and advanced glaucomas. Now, TOP is similar to the CETA fast, and dynamic is similar to the CETA standard. TOP test strategy takes only a few minutes, which is best suitable for patients who struggle with fatigue and those who are unable to sit for a longer period of time. The TOP strategy takes advantage of the fact that the sensitivity thresholds at each location of the visual field are related to the sensitivity thresholds at the nearby locations. That is, there is a spatial correlation among adjacent test locations. The dynamic strategy takes a little longer time and differs from normal full threshold strategy by crossing the sensitivity only once, and step size is similar in regions of normal sensitivity and larger in areas where the defects are present, where the step size ranges from 2 to 10 decibels. Now just having a look at the zones of the printout of a Humphrey. First we look at the patient data and the test data. This constitutes the reproducibility of the visual fields. Moving on to the reliability, the threshold values, the grayscale map, total deviation map, pattern standard deviation maps, the glaucoma hemifield test, global indices, and lastly at the gray stacking record. This is for a Humphreys. Now going on to the octopus, an octopus printout is near identical to the Humphrey. The basic difference is in the terminology used and in something that is perhaps called as the baby's curve. So this is just the here the patient data and the type of test strategy constitutes the reproducibility. Now in an octopus, the reliability indices are called the catch trials, and they are placed within the reproducibility of the field. We then here look at the grayscale, the comparison and the corrected comparisons, the probabilities and the corrected probabilities, the raw data, the indices, and lastly we look at the Bayes curve. Now let us see how similar is our octopus to the Humphrey. The patient's name and age has to be entered. The refraction, pupil size, false positive and false negative catch trials. The test strategy, pattern, test duration and all can be seen here. The total deviation values are seen as a comparison values in octopus. GST in Humphrey is depicted as the Bayes curve in the octopus, and the global indices called the mean deviation in a Humphrey is seen as a mean defect in octopus. The pattern standard deviation of a Humphrey is seen as a square root of loss variance on the octopus. Now this is just for comparison with the Humphreys. The CETA fast of a Humphrey corresponds to the top standard of the octopus, and the CETA standard of the Humphreys is the dynamic strategy of the octopus. Both the parameters use an interpolated graphical map to assess the magnitude and shape of the defects. The Humphreys grayscale is based on the sensitivity thresholds in decibel, and this is influenced by both the patient age and eccentricity of the test location, whereas the octopus grayscale is based on the sensitivity loss in percentage. Thus, it is the interpretation is independent of the patient age and eccentricity of the test location. Both the parameters display sensitivity loss in total deviation map and the comparison, but use opposite signs. The octopus parameters display a sensitivity loss less than 5 decibel with a plus sign. Now here the red circle pointing towards the dark black squares, which signifies an absolute defect, that is the sensitivity threshold is 0 decibel. Both the parameters display the local sensitivity loss, that is the deviation from age corrected normal values with the correction applied to eliminate any influence of diffuse loss. But here they use opposite signs. The octopus and Humphrey both use the same level of probabilities using similar symbols. Now if we look here, the total deviation map gives us the total depression of the visual field, which includes the generalized loss as well as the focal loss. Now since we are more interested in the focal loss, we should have a look at the comparisons and the corrected probabilities. This gives us the focal loss of the visual fields. Both the Humphreys and Octopus display the percentage of false positive and false negative errors. Octopus additionally presents the absolute number of answers and the total number of catch trials. The Humphrey uses the Hagel-Krakow method to determine the percentage of fixation losses. Humphreys record the eye movements using the Grace tracker. Whereas the Octopus parameter, they prevent fixation losses by using fixation control, in which the test is interrupted when adequate fixation is not maintained. So in Octopus, you have many fixation controls like a blink control, contact control when the patient chin or the forehead is off or away from the machine. Similarly, the pupil position control and dart control. Octopus also has the automated eye tracking, which will prevent the low reliability of the test. So this is another important part of the Octopus field, the defect curve, also called as the baby's curve. It is based on the comparison representation. The comparisons are first ranked according to their magnitude from the smallest to the largest defects. The defect curve is drawn by plotting the defects as a function of their rank. The colored area is the amount of diffuse and local defect. This image is self-explanatory. Here we can see the different defect curves where we can pick the local, the diffuse, or the combination of defects. Now, the cluster analysis and the polar analysis or the trend analysis, this is something that is available only on an Octopus.
Please wrap up, ma'am.
The polar analysis is specifically designed for glaucoma, and coming to the steps. So first of all, we should confirm the patient and the examination parameters, determine whether the visual field can be trusted, identify the diffuse visual field defects, distinguish between a normal and abnormal field, assessing the shape and the depth of the defect, assess the cluster defects in glaucoma, see where to look for a structural defect and match the visual field loss according to the optic disc changes. And then lastly, we should assess the severity.
Thank you, ma'am. Now I invite Dr. Sanjeev Jindal and Dr. Parveen to facilitate our speaker. Next speaker be ready. Dr. Priyanka Daya, tonometer types and newer modalities. Thank you, sir. Thank you, Dr. Sanjeev.
A very good afternoon to all of you. I would like to thank the SAR Ophthalmological Society and All India Ophthalmological moving towards how we are moving towards the IOP measurement independent of corneal thickness and continuous measurement of IOP using triggerfish contact lens systems. So why do we need to talk about tonometry? Because despite research, the intraocular pressure remains the single most important modifiable risk factor for glaucoma. It can be measured obviously directly with the help of manometer, but that is possible only in research purposes, and practically we have to measure it indirectly with the help of tonometers, in which when we are using indentation tonometer, we must take into account the ocular rigidity, which plays an important role, and increase in ocular rigidity as in cases of chronic glaucoma and hypermetropia results in increased IOP, while eyes which have decreased ocular rigidity like vitrectomized and myopic eyes tend to have a decreased IOP. Now when we had nothing, we have a finger. So when we start in our PG days, we always start with digital tonometry. Obviously it's a very crude method of assessing, but it is invaluable in emergency situations when we have nothing but our fingers, and we should take care not to use this tool when we are suspecting ocular trauma or globe rupture. We use index finger of both the hands when the patient is looking down to avoid the tarsal plate, and with one finger we stabilize and the other finger checks for the compliance. Then how do we measure IOP? Indirectly, we can measure it by using indentation methods and applanation methods. And applanation is further divided into contact and non-contact types, which we'll be taking up one by one. Now, indentation tonometry, the prototype is obviously the Short's tonometer. I believe most of us started using measuring intraocular pressure in a postgraduate days with this instrument only. And India being a developing country, it still remains indispensable, though in most centers it has become obsolete. So it uses a plunger to indent the globe, the cornea, with a standard weight. And it is a useful instrument, and there is a scale on which there is reading between 0 to 20, which is measured correlated with the scale. If it is found high, then we gradually increase the weight. Then moving on to applanation tonometers, they can be either a fixed area type, that is Goldman, which is the prototype, and Perkins, and fixed force type, which is the McLaughlin type. So Goldman applanation tonometer, most centers, this still remains the gold standard. Whatever new technology comes is still compared to the Goldman in terms of reproducibility and accuracy. And in this, we are doing it day in, day out. We need good compliance from the patient. We have to take care that the collar button is loose. There is no Valsalva maneuver which is taking place. And then the patient has to be relaxed, and obviously anesthesia is required, topical anesthesia along with fluorescein. And then with the biprism, we see two Myers. And the inner edge of the two Myers at the midpoint of the pulsation is taken as the end point. And but there are a lot of sources of error, like thick Myers will lead to overestimation, while thin will lead to underestimation of IOP. Then there is the central corneal thickness, which is also correlated, like thin corneas lead to underestimation and thicker ones lead to overestimation. Again, it's not a linear function, so we have a map of corneal thickness, but it should be central corneal thickness should rather be used as an independent risk factor for ocular hypertension and glaucoma, rather than, we cannot correct GAT with CCT. It is not that accurate because it's not a linear function, which we're routinely doing. So we should just keep in mind that because it should, many other factors should be taken into mind, and we are still working towards a mathematical formula which can cancel this central corneal thickness. We are moving towards IOP measurement independent of central corneal thickness. Then there is corneal astigmatism, especially if it is more than 3 diopters. Then it leads to 1 mm Hg of overestimation if it is with the against the rule, and underestimation if it is with the rule. Then corneal it leads to overestimation in steeper corneas. Now cleaning is very important. We should all be aware that we can either use 3% of hydrogen peroxide or 70% of isopropanol or 70% ethanol, which should be done for every patient, and it should be allowed to dry because it is definitely epitheliotoxic. Then we move on to other from the prototype to other similar kinds of applanation tonometers, like the Perkins tonometer. And obviously the advantage is it can be used in children, in supine patients under general anesthesia, and it is easy to carry and portable. Then there's the Draga tonometer, which is also similar to Perkins, and but it uses a different biprism. Also it uses a electric motor for the force of applanation. Then we have the Mackey-Merck tonometer, which is no longer in use. It's a fixed force tonometer, and IOP is recorded as wave for France. Then we have TonoPen. TonoPen initially became popular, but nowadays it's not that popular. There is a latex covering which is changed for every patient. It is portable, and it is used as a screening tool. However, it is very advantageous in patients who have scarred cornea or edematous and irregular corneas, and in patients who are having nystagmus or head tremors, or in little children. However, it should not be used for screening or diagnosis of congenital glaucoma, because it has found to be fairly inaccurate as it overestimates. Then we have pneumotonometer, in which cornea is applanated with air pressure as the sensor. Advantages are it has minimum contact with cornea and is useful in scarred and irregular corneas, and pressure can be taken over BCLs, bandage contact lens. Disadvantage is that it still requires anesthesia, and frequent calibration is required, and IOP values are not that accurate. Then this, I believe, is present in all our ophthalmic setups, the non-contact type, although it was not that accurate, but it was definitely a very good screening tool for glaucoma. So if NCT is high, then we can further take up the patient and be more aware that this may be a case of glaucoma. It is very good for mass screening. Since there's no contact, there's no risk of infection, no anesthesia is required, even for non-compliant patient, little children, old people. It is very doable, and it is definitely affected by corneal biomechanics and central corneal thickness. Then there is pulse air tonometer. It is also good because it is portable and can be used in any position, like in camps and other areas, but the reliability decreases as the range of IOP increases. Again, it's used more as a screening method. Now we move on to newer generation tonometers. Okay. So we have the Pascal dynamic contour tonometer, the Richter's ocular response analyzer, which also gives us corneal hysteresis and Goldman corrected IOP. And there's eye care, which works on the principle of rebound tonometry. These came in then we have latest is continuous monitoring of intraocular pressure, because if we have continuous IOP reading, then in 70% of the individuals it was found that the line of management changes. In this we have a Sensimet triggerfish contact lens sensor, which is already FDA approved. And there is we are working towards implantable IOP sensors, which we are planning to place either in the anterior chamber or the vitreous, or maybe in the capsular bag with the help of IOL. This is still under research. And we have Corvus ST, which is almost independent of corneal thickness. It has a Schlemmflug ultra high speed camera, which takes 330 frames per second, and it gives a IOP which is fairly free of corneal thickness and corrected for age and corneal biomechanical response. Thank you.
Thank you, ma'am. Now I invite Dr. Arvind Moria and Dr. Mahesh Uja to facilitate our speaker. Thank you, sir.
Whether it is the IOP, we are not following any chart.
A very good afternoon, everybody. My topic is optic nerve head examination. Optic neuropathy with corresponding visual field defect, and the most important risk factor being the raised intraocular pressure. But it's not that high IOP is not always glaucoma, and we can have normal IOP in normal tension glaucoma. So optic disc evaluation is very, very critical. And slit lamp biomicroscopy is better compared to direct ophthalmoscopy and indirect ophthalmoscopy, as it gives 3D view, as it gives depth perception also. And fundus camera is important to document and give static images in which minute details can be seen. But we all be looking for in optic disc size, shape, cup to disc ratio, neuroretinal rim, any disc hemorrhage, retinal nerve fiber layer defect, peripapillary atrophy. Normal optic disc size is 1.7 to 1.8 millimeter in its vertical meridian, and we can measure the size on slit lamp by decreasing the graticule size to match with upper and lower disc margin and measure the reading on graticule. And if we are using 90 diopter lens, we have to multiply that reading by 1.3. Why it is important? Because large discs can have large cups and they can be misdiagnosed as glaucoma, whereas small disc glaucoma can be missed because they usually have very small cup. Disc shape, the disc is normally vertically oval with ISNT rule is followed, where inferior is thickest, followed by superior nasal and temporal rims. Disc is said to be torted if it is rotated 15 degree from the vertical meridian, and it is said to be tilted if it is 3D angulation. Cup to disc ratio. In cup to disc ratio, we should be looking at the contour cup rather than paler cup. As in this photograph, we can see this is paler cup as well as contour cup. But in this photograph, we could see that cup is reaching up to the disc margin, whereas the paler cup is still here. This area which is retaining the neuroretinal rim color but is devoid of NRR, it is called tinted hollow, and this is bayoneting of the vessel. If cup to disc ratio is more than 0.7 is highly suspicious, and asymmetry between two eyes of more than 0.2. Only cup to disc ratio itself is not important. Disc size, shape and neuroretinal rim should also be mentioned. Neuroretinal rim, as we know, disc is donut-like and it is the main functioning tissue, that is pink or orange. So rather than looking only at the CDR, NRR should be seen, and NRR less than 0.1 is highly suspicious of glaucoma. Disc hemorrhage, it occurs due to IOP fluctuations, and it is seen in most commonly in inferior quadrant, in papillary and peripapillary region. It's more common in NTG. Whenever we see disc hemorrhage, after ruling out diabetic and hypertensive changes, we should be thinking that the glaucoma is progressive and we should be treating it very aggressively. Retinal nerve fiber layer, retinal nerve fiber layer is thickest at superior and inferior poles, and it is seen as shiny strands. And if there is RNFL defect, this shiny area is replaced by dark wedge-shaped defect. And on slit lamp, we can examine for RNFL defect better with dilated pupil and using green light filter. Peripapillary changes, they themselves are not pathognomonic of glaucoma, but they are seen more frequently and larger in eyes with glaucoma. And in ocular hypertension, if there is PPA, there is more risk of developing glaucoma. This photograph shows that this is disc cup, this is NRR, this is scleral ring, this is zone beta, and this is zone alpha, which shows hypo and hyperpigmented areas. Now I'll be showing few of the cases of optic disc. This is case 1 where disc seems slightly tilted. Cup to disc ratio is about 0.6 to 0.7. RNFL is appearing normal, and in the left eye also 0.6. RNFL, there is no defect seen. On red free we could see that RNFL is good in both the eyes and visual field is normal. This was normal optic disc despite having cup to disc ratio of 0.6 to 0.7. This is a case of small disc where we on cursory look we can see that it's looking absolutely normal. But on careful look we could see that inferiorly this vessel band is going till here. And there is some dark area in inferior quadrant in the right eye, the RNFL defect, whereas the left eye is normal. OCT also showed thinning in the area, and visual field right eye showed superior nasal field defect. Another case, 58-year-old male was referred as glaucoma suspect in the left eye. Intraocular pressure was 14. This is right eye. We could see, if we see only at the pallor, cup to disc ratio is about 0.6. But if we see contour, this vessel is going sloping. This band is still here. And RNFL defect is also seen, whereas the left eye cup to disc ratio is about 0.8. And there is wedge-shaped defect in inferotemporal area in the left eye. So IOP was normal, but the discs are glaucomatous. So plan was to do diurnal variation test and visual field. Diurnal variation test showed right eye maximum pressure was 20 and left eye was 23. Visual field, as in left eye, there was inferotemporal RNFL loss and it showed superior nasal field defect. Whereas in the right eye, there was changes in the disc and this early nasal step formation, though the test was low reliable. So patient was, on the basis of optic disc findings, OCT and field, patient was started on prostaglandin. There is another case, 41-year-old male was referred as right eye disc suspect. IOP was normal. So in a young patient, if IOP is normal, one should be thinking that it can be normal disc because NT is not seen in young patient. And in cup to disc ratio was about 0.7. Field was absolutely normal. So it was case of congenital anomalous disc. There is another case. On cursory look, the discs are looking grossly normal, whereas the left eye seems little larger cup. But on careful examination, we could see that this disc cup bent is going here, this vessel bent. And there is superior RNFL defect, superior temporal area. There was cup to disc ratio of about 0.6 and left eye also 0.6 to 0.7. Red free photograph showed RNFL defect and OCT also showed RNFL thinning in this area. There was corresponding visual field defect. Another case, 26-year male complains of decrease of vision. Visual acuity was 6/24. IOP was normal. This was the cup to disc ratio is about 0.6. Temporal rim is little paler. RNFL is good. Similarly, in the left eye, visual field showed central field defects. On OCT, there was temporal thinning. As we all know, in glaucoma, papillomacular bundle goes at a very last stage, and vision goes at a very last stage. In this case, it was paler more than cupping, and there was vertically aligned field defects. So MRI was done, which showed decreased diameter of optic nerves. So diagnosis of LOHN was made, Leber hereditary optic neuropathy. This is a case where cup to disc ratio is about 0.9 in both eyes, so it was a case of advanced glaucoma. This optic disc shows around 0.9 cupping. Similarly, in the left eye, around 0.9 with disc hemorrhage also, suggestive of progressive glaucoma. Then another patient, 28-year male, baseline visual acuity right eye 2/60, left eye 6/6. There was radially lined vessels and central white tuft. This was morning glory. 15-year female, there was family history of glaucoma. Visual acuity was counting finger 1 meter in the right eye, 6/9 in the left eye. These were the discs. Discs appear, cup to disc ratio appears larger, and there is optic disc pit. Similarly, in the left eye, cup to disc ratio of about 0.7. So this was case of optic disc pit. There is another case, cup to disc ratio about 0.6 to 0.7, about 0.6 in the left eye, but the rim was paler. It was a case of toxic amblyopia. So take home points that careful optic disc evaluation is very, very important to diagnose glaucoma, and one should be looking at the contour cup rather than paler cup. CDR, NRR both are important, and whenever we need, we can dilate the pupil after ruling out angle closure disease. And ancillary investigation, OCT and visual field can confirm the diagnosis. Thank you.
Thank you, ma'am. Wonderful talk. Now I invite Dr. Rajiv Jain and Dr. Manpreet to please facilitate our speaker. Thank you. Now, Dr. Gaurav Gupta, UBM made easy.
A very good afternoon to all. At the outset, I would like to thank AIOC, HOS, and Sirsa Ophthalmic Society for the opportunity. So, I'll be talking on UBM made easy. So UBM is basically ultrasound biomicroscopy. It is an ultrasound-based equipment developed by Pavlin, Schrar, and Foster. It is a non-invasive tool to evaluate anterior segment, and it provides in vivo imaging through opaque media. So the difference between normal ultrasound B scan and a UBM is its frequency. As we all know, 8 to 10 megahertz for a routine B scan, and it has a frequency of 50 megahertz or more. So due to higher frequency, it has higher resolution but less penetration. So it provides very beautiful anterior segment images in opaque medias. So it is used for anterior segment evaluation, that is cornea, angle, lens, and ciliary body. So I'll be showing a few images. So this is a normal cornea. So cornea is a multi-layered structure. So this anterior to posterior first echogenic lines structure is corneal epithelium. Then comes the Bowman's membrane. Then the stroma, and another echogenic structure is the Desmond membrane. So in a normal angle, so here we can see the junction between cornea and the reflective sclera is the anterior Scholber's line in the Schlemm's canal, and the anterior limit of the junction between the sclera and the ciliary body band is the scleral spur. So scleral spur is critical to angle assessment during the UBM. So this landmark, understanding this landmark, is very important. So how to do it? So I'll be showing few videos about how to do it so that everyone can do. So first and foremost is setting up the machine. So machine setup is very important. So we need a printer, a monitor, a UBM machine, and a console. I'll be demonstrating about Quantal, no financial interest. So we need this machine. Then initially patient entry is done. Then once we have set up the machine, patient entry is done, then we will be demonstrating how to perform the UBM procedure. So we need distilled water, viscoelastic, clear scan, and scleral shell, speculum and saline. So there are various techniques, clear scan and scleral shell technique. So this is the probe of the UBM. Why it is important, we need to see this white mark. This understanding of this white mark is very important to understand the anatomy while we are doing it. Because while we are rotating this, then only we can see the structures, and orientation is very important. So now I'll be demonstrating scleral shell technique. So basically, what is the difference between a scleral shell technique and clear shell? It needs a cup. It is done under water bath. So this is the probe. We need to open the cover and we need to fill this probe with distilled water. So that here you can see this is the transducer mainly, which will move and provide the images. So it need to be completely in the water bath. So here you can see, and we need to place this cover over here. So once it will move, so you can see in the computer the image will keep on coming. So this shows that it is working properly. So now this is a patient. First we instill the paracaine eye drops and put some little bit of viscoelastic to protect the cornea. Then this cup is applied. And we need to fill this cup with distilled water 50% till 50% depth, and then we will start the procedure. So here you can see this mark. So whatever side is a mark, it will come on the right side of the screen. So we have taken this trap patient so that we can understand the anatomy better. Here we can see we have kept the mark inferiorly. So once we will start doing the procedure, here you can see this is the PI of the trap. So it is coming on the left side, and we can assess the bleb also. So now I'll be showing few images. So this is the previous one, the scleral spur and the Schwellbase line. So this is the sulcus space. So why it is important? It is very important in cases of ciliary body effusion. This is the iris ciliary body, and this is the supraciliary space. Here we can see the fluid. So this is the lens. This is how we see a lens, clear lens on UBM. So this is an image of a pseudoexfoliation patient. This is the cataractus lens, and here we can see the zonules. The zonules are broken in patient of pseudoexfoliation glaucoma and a cataractus lens. So we can evaluate the broken zonules also on this. So this is another case. A young patient, 22-year-old, presented with sudden high pressures, and here we can see the angles were closed. So bilateral case of angle closure in a young patient, so we should always suspect secondary angle closure. On gonioscopy, 360 degree, it was closed. So on UBM, we could see the supraciliary fluid bilaterally. So it was a case of bilateral uveal effusion. So pupillary block can also be evaluated in these cases. So here we can see shallow anterior chamber, narrow angle recess, and posterior and forward bowing of the iris. A lot of time we see patients of malignant glaucomas post surgeries. We are very confused if it is malignant glaucoma or not. So UBM comes as a rescue. We need to see shallow or flat anterior chamber with a closed angle, and there is an anterior rotation of ciliary process and a supraciliary fluid. So in cases of pigment dispersion also, as we all know, there is posterior rubbing of the iris with the zonules leading to release of pigments. So there is a deep anterior chamber with this concave iris configuration. This concave iris configuration is very pathognomic for pigment dispersion syndrome, and this will help in deciding if laser iridotomy will help in these cases or not. Similarly, in the post-glaucoma surgery, very beautifully OCTs were shown, but UBM can also play a role because many a times with the OCT we cannot go deep. So here we can see a bleb with fluid. And it can also tell intrascleral fibrosis that will tell us if needling will work or not. Because if there is intrascleral fibrosis, then the only needling will not work. So we will need to do some ab interno procedure. So this is another case. So here we can see this is a normal ciliary body, but you can see the ciliary body. This is very atrophic. So this is the case of post-dialysis cyclophotocoagulation. So we can assess the efficacy of by UBM that if the ciliary bodies have atrophied or not by doing this. So now I will be showing few cases of pediatric glaucomas. So basically, why UBM is important in these cases? Per se, any corneal opacity. When you see these eyes, you see just opaque eyes. You don't know what is beneath them. So we can see the both appear very same. So but when we do a UBM, we can see it is just not opaque. There is a posterior descent defect, suggestive of Peters anomaly. And both are looking same, but we don't know how is the anterior segment. So UBM will tell us that the iris is stuck and we need to be careful doing surgery in these cases. So this is another case, it is also looking exactly same. But on UBM it will tell there is no posterior segment defect. And it is just a case of primary congenital glaucoma with intracorneal fluid deposition. So this is another case. So both eyes are looking same, but on UBM we can see one eye is having Peters anomaly, there is a posterior defect, but the other eye is same. Why knowing these things are very important? Because it will help us prognosticate these cases. It will tell us what we need to do in them, we need to operate or not, and we can help them prognosticate how they will perform. Because a primary congenital glaucoma with cornea will completely clear up, but not in Peters anomaly. So this, it's almost last slide. So basically there are a lot of differentiation in ASOCD and UBM. So mainly where a UBM is very important. So corneal opacities before planning surgeries, differentiating secondary angle closure from primary, malignant glaucoma, ciliary body tumors we cannot see without UBM. So in a case of PDS for planning LI, trauma, childhood glaucoma, and to see beyond the obvious. So take home is doing UBM is an art, and every glaucoma specialist should master it. Thank you. I would like to acknowledge my mentors.
Thank you,
Thanks.
sir. Thank you, sir. Now I invite Dr. Urvish Vashisht and Dr. Ritesh Singla. Please facilitate our speaker. Now I invite Dr. Prashant and Dr. Inder Mohan to facilitate our chairpersons and panelists. Dr. Rajiv Jain, please. Dr. Urvish Vashisht, Dr. Sanjeev Jindal, Dr. Mahesh Oja, Dr. Manpreet, Dr. Manpreet, Dr. Ritesh, and Dr. Vivek. audience. Now we start with the next session.
Now I invite Dr. Manisha Nada, chairperson for the next session. Dr. Harshul Tak, sir.
Sir, Dr. Harshul Tak will present first.
Dr. S.B. Jain, panelist Dr. S.B. Jain, Dr. Inder Mohan, Dr. Gulshan Mehta, Dr. Dheeraj Gupta, and Dr. Hemant Fogart.
Dr. Harshul Tak presenting first.
Dr. will give the presentation.
नेक्स्ट मेरा कर देना तो सही तो इधर बैठ ना बैठ
Diagnosis and management, managing surgical challenges in cataract surgery, Dr. Harshul Tak.
Okay. So, good evening, everybody. At the outset, I'd like to thank AIOS ARC Chairperson Dr. Prashant, entire team of Sirsa Fatehwad Ophthalmic Society, especially Dr. Rajan, Dr. Indermon Rastogi, for bringing me here and giving me a wonderful opportunity to meet all of you. It's a very warm society. I can see the enthusiasm in each and every person here. So I was just informed 3 days back that I have to be here. So I thought what to show. So I decided to show some of the situations which are surgical situations which are difficult and challenging for every cataract surgeon. So let's see a few of the situation and how to deal with that. So this is the first case I'd like to discuss. Is we all know that toric IOLs, they are pretty accurate in their accuracy, but we may land up in surprises sometimes, and we should know how to manage the surprises which we encountered in these toric IOLs. So because every 1 degree rotation or error in toric ion alignment, we all know it causes reduction in the efficacy by 3.3%. So why toric IOL surprises happen is there may be pre-operative measurement errors which were there. There may be incorrect marking of reference points on the cornea. If you are not marking it correctly, then you may place it wrong. Or you intraoperatively you have placed the toric IOL not in the correct position, or if you fail to take into account the effect of your SIA or posterior corneal astigmatism. So we all know that after the toric IOL is put in post-operative period, we can check the toric IOL alignment by using either slit lamp. So we can rotate the slit and align with the toric marks which are there on every lens. Different kind of marks are there, and we can see on like this on slit lamp that what is the axis on which our toric IOL is there. This is I'm using Tomy OA 2000 optical biometer. If you take capture this image retro illumination mode, so it gives 2 lines here. As you can see, the green is the reference axis and yellow is the IOL axis. So you can get the exact IOL axis by 1 degree difference like this. So here green is your reference axis which remains stable, and you can rotate the yellow line and you can come to know that where the toric IOL marks are. So let's see what option we have if we get a toric IOL refractive surprises. First is we can rotate the same IOL to reduce the cylinder. So we need to use some online back calculators which are available. They're like astigmatismfix.com or Assort. Even iTrace directly let you know that how much of rotation is needed. So if those calculators show us that the amount of astigmatism can be reduced, we go ahead and rotate the IOL clockwise or counterclockwise to the desired axis, whatever we calculate from these. And there may be situation that the calculators don't show any reduction in the amount of astigmatism. In that case, we only have option of either to exchange the toric IOL or to put a piggyback IOL in those cases, or we can do LASIK PRK to correct the refractive surprises. So this is the website astigmatismfix.com. So essentially, let me take you through one of the example, one of the case which will make everything clear. So these are different calculators. So this was the case which was referred by one of my colleague on 12th day after surgery. So the patient had uncorrected vision of 636, and when we did refraction, patient had -1 sphere and plus 2.5 cylinder at 140 degree, and he was improving to 6.6. So first thing what you need to know is the post-operative refraction, that what is the exact refraction of the patient with which patient is improving. So this is first data which you need to know. So in that case, T6 IOL was placed at 10 degree. That's what surgeon told me, that when I calculated, it gave me that I need to put the IOL at 10 degree. So when I dilated the patient, you can see here these marks, toric marks. This is the acroleal toric from care group. And if you rotate your slit, these markers here, you can see that the axis is 10 degree. So the IOL was at right place, 10 degree. The problem was in preoperative calculations. So whatever was the cause, you need to feed these values here in this calculator. This is astigmatismfix.com. So after I feed in the current refraction which is there, and it gives what is the ideal position of the, can I have a pointer here please, pointer. So this calculator, it shows me that I need to rotate the lens from 10 degree to 178 degree. That is 12 degree of rotation is needed in this lens in the clockwise direction to reduce the cylinder to minimal. So I need to rotate the lens from this position, which is blue line, 10 degree, to this axis. And here it shows that if I rotate it to this axis, 178 degree, it reduces down the cylinder. So now we have data that I just need to go ahead and rotate this IOL 12 degree in the clockwise direction. Again, see here, it was, the ideal position is 175 or 178, whatever. So now I go ahead and what I have to do is, now these marks, now we don't need to put the reference axis mark, because these toric IOL marks are acting as reference axis. We just need to rotate, we take this as 0 and 180 and mark 12 degree clockwise direction. So I just go ahead and align the Mendes degree gauge here and put marks here 12 degree on both the sides. So I need to rotate my toric IOL from this place to this. You don't even need to put OVD. This is hydroimplantation technique which I described in 2010. It's very easy to put IOL under irrigation and even to do post-operative rotation. So I just put irrigation cannula there. This is 14th day in post-operative period. So I just go beneath anterior capsular axis margin, free lens little bit, and use the Kugel's hook to rotate the IOL to this axis here, which I marked. So IOL is rotated to clockwise direction, and I hydro stitch all the incisions. No OVD is used here. You can rotate the IOL and look at the position of the lens. So again, if I check from this preoperative, the IOL is rotated in clockwise direction, and in post-operative period, patient improved to 6'9" uncorrected, and he was 6'5" with minus 0.5 diopter sphere. So in that way, you can fix toric IOL surprises which are there. It's very easy and very much doable. So if you have any surprises, you can go ahead and use any of these calculators which are there available. Second, okay. We all know that posterior polar cataract, these are true posterior polar cataract, and they really causes problem to any phacosurgeon, because this bullseye type of posterior polar cataract, they are true posterior polar cataract. Posterior capsule is very weak or defective there. So all your steps need to be directed towards how long you can delay opening of the posterior capsule, because this true posterior polar, ultimately when you take out the central disc, you will see a defect there. But if it's controlled, you can salvage a lot of things. So your axis size should not be more than 4.75 millimeters. Why? Because if it's an uncontrolled tear in the posterior capsule, which mostly happen in these kind of true posterior polar, you need to put a 3-piece IOL, and if you put a 3-piece IOL in sulcus, you need to do optic capture. And for optic capture, if your axis size is more than 5 millimeter, believe me, you can't get a good optic capture. So axis sizing has to be not more than 4.75 or 5 millimeter, 4.75. After that, we all know that only hydrodelineation is little bit what is needed, and this is a grade 3 cataract, so of course you don't need any kind of good hydrodelineation also, because it's very easy to chop this nucleus. So you go ahead and chop this nucleus, don't do much of lateral separation. So our aim is not to put undue forces or stress on the posterior capsule, so that we can prevent opening of the posterior capsule as late as possible. So I'm rotating tip on the right side, left side, and taking off the nucleus. So once your endonucleus is gone, then you need to take care of epinucleus, loosen it up from all around. So now after endonucleus is coming the epinucleus sheet, and after that will come the central polar opacity which is there. So once I loosen it up all around, I flip it. So the key here is to maintain closed chamber, never come out suddenly from anterior chamber and let your anterior chamber collapse. And now this is the last epinuclear sheet which is coming up, and the central disc is coming up. Along with that, I can see that there is opening of the posterior capsule, but I am not withdrawing my instrument suddenly. Just whatever is there in front of the phaco tip, I am just emulsifying them. And after that, you need to maintain closed chamber. At this stage, you know that this is the posterior capsule which has opened up and it has increased in size. It means there is vitreous which has come up and which has expanded this opening. At this stage, you don't have to aspirate the cortical matter without cutting the vitreous. If you do that, you do harm to the vitreous base, which Dr. Prashant will never like, because vitreous base is 100 times thinner than the central retina, and you may cause retinal tear and all those problems. So if you follow the principle, nothing is lost here. Just maintain closed chamber, put OVD there, come out slowly, and after that, this is all under topical anesthesia. If you want, you can augment with subtenons. So this is a triamcinolone tricot which is put in anterior chamber to visualize vitreous, and after that you need to do bimanual vitrectomy in cut IA mode. That is, you need to cut the vitreous first before aspirating it. So that's cut IA mode, and always maintain anterior chamber, never let it collapse. So I go from the side port and do good anterior vitrectomy. And once you have done this vitrectomy and you cleared the entire vitreous from anterior chamber, then only you try to take entire cortical matter now. Now see, if I take out this cortical matter, there is no vitreous traction whatsoever, and you can easily take off the entire cortical matter from one side. Again, before exchanging hands, I put OVD, maintain closed chamber, and then take out my irrigation cannula and then exchange hands, go from other side. You can see a big posterior capsule defect which is there. These are the last pieces of cortical matter. So clean up this cortical matter, and you can only do this if you have done adequate vitrectomy. Again, maintain closed chamber, put OVD, and now you are going to put a 3-piece IOL here. So this is a 3-piece IOL putting a 3-piece IOL in cases like this becomes little tricky because the leading haptic behaves in very funny way many times. So the little trick for this is you always keep your leading haptic in horizontal direction like this. So wherever the haptic is there, you need to turn your hand so that it's always coming out horizontal and goes beneath the iris. So here I am just rotating my hand so that it comes out horizontally, and once it comes out, I will rotate again in counterclockwise, anti-clockwise direction, and it goes beneath the iris margin. And then you can put the IOL in sulcus. And after putting in sulcus, you need to do optic capture, which is very essential for long-term stability. So you go ahead and use Kugel's hook, capture on both the sides. So once you see this ovalization of the anti-capsular axis margin, you know that the IOL has been locked with capsular axis. Again, do some vitrectomy, put Miochol, and this finishes the case. And look at the slit lamp photograph in the post-operative period. So you can see that this is a big posterior capsule defect which was there, and this is the anterior optic capture which has been done. And this lens is nicely locked in place. So again, one more case. The point here, what I want to. Okay, fine. So I'll finish my talk here. Thank you so much for giving this wonderful opportunity. It was great to be here. Thank you so much.
Thank you, Dr. Herschel, for such wonderful depictions. Such a wonderful presentation.
Thank you so much. Thank you.
Next speaker, Dr. Arvind Maurya, sir. And meanwhile, I request Dr. Dheeraj Gupta and Dr. Ravi Trehan, sir, will felicitate Dr. Herschel talk. Progressive polyfocal IOL to correct all types of vision.
Good afternoon, everyone. Thank you, ARC, AIOS, HOS, Dr. Manisha Nada ma'am, Dr. Inder Rustagi sir, Dr. Dheeraj, and especially Dr. Rajan for inviting me here. So my talk is on a novel progressive polyfocal IOL to correct all type of vision. So I will be talking about some solution to a lot of problems. So while choosing a premium IOL, so we look for that it will be able to correct all types of vision with no negative dysphotopsia, no glare or halos. It needs to be pupillary independent and no effect of angle kappa and alpha. Is it possible? Yes, of course it is possible. So there is this autofocus pro that looks almost like a monofocal. So you can see this is the autofocus pro. It looks clearly like a monofocal. It doesn't have any diffractive ring. So it is static and fixed in the bag, and there is no mechanical pseudo accommodation required whatsoever. Yet it functions like an autofocus lens, hence the name given to it. It is a progressive IOL, of course. So you can see distant vision, and this is the intermediate vision, and this is the near vision. And it can be confirmed by the NIDAC OPD scan with 0 in the center that gives the best distant visual acuity. We talk about the design and dimension, so these are very patented design. It is moving ahead on its own. IT people, so this is the design. So it is a L loop, it's not a C loop, and with a zigzag outer edge for the rock solid rotational stability, and there is all around a square edge is there, and the polyfocal progressive optic is there, and these are the dialing, and the visco also comes out of it. These are the zigzag serrated outer margin, and the total size is 13.5, it's not 13. So the optic is 7.5 millimeter, which is much larger than the average 6 millimeter of optic we see. And so it has excellent day-night distance, intermediate and near vision because of the GRIN technology, that is a gradient refractive index of 1.45 to 1.54 in the 3 millimeter to 5 millimeter of the zone. So these two dialing holes are also position indicator, so that it needs to be kept in the upper half of the eye, and it also helps to drain out any remaining retroaisle viscoelastic. So if we talk about the distribution of light, so 60% it is for the distance, then 15% for the intermediate, and near 25%. And the serrated zigzag outer edges give rock solid rotational stability, and it is taken like the edges of the ticket. These haptics are completely atraumatic, just like knuckles of a fist. If we compare with the optics of the conventional round optic IOL, so they cover lesser than the needed horizontal visual field, so that's why they create the negative dysphotopsia. And if a patient has implanted both eyes trifocal, it is moving on its own. Please don't move it. Right? So there is this 10 to 20 degree of aphakia is there. This leads to negative dysphotopsia because the optic size is of less size in the horizontal direction. That's why the patient who has implanted both the eyes trifocal, sometimes they don't see the divider while driving. And if you talk about the haptic, so it just touches because it is the C loop, whereas this is a L-shaped, so it is in alignment with the rock solid stability because whole of the edge 6 millimeter of the haptic is in alignment with the PC. So at any size of pupil there is light distribution, proportion remains same, and set as pupillary independent, and there is no light energy loss because there are no destructive interference or diffraction, so there is no effect of angle kappa or angle alpha. If you talk about the MTF, so we want 100%, but that is not possible to achieve, and the monofocal they have 72% MTF, and this autofocus pro has around 70% of MTF value. So there is good image quality at the retina, and the contrast is also good as we compare with the monofocal IOL. What are the advantages? So there is no optical noise, so there is no neuroadaptation required, and it can be implanted in monoocular cataracts also. So this is a small video. So first we need to inject viscoelastic, and there is a butterfly type of this injector is there, injector cartridge system. And even if the axis is not regular, because of the large size of the optic, it can be implanted quite easily. Now with the help of the Sirsa hook, these holes should be in the upper part. That gives the indicator that that is placed in a correct position. So to proper position we need to have these two dialing holes as a marker in the upper half of the eye. And if we see the depth of focus, so from +1 up to -4.0, there is 6/9 vision is noted in most of the patient. It is a forgiving IOL for the post of refractive surprises from +1 to -1 diopter, and we really don't have to be so acute, so vigilant and so apprehensive about the IOL power calculation and the formulas. Even without an optical biometer, results will be excellent. So there is no waxing or misty vision is there because the free crisp sharp vision is obtained most of the time, And out of the more than 500 implanted by me at our center, not a single patient complained of negative dysphotopsia. Because there is no gap. As we can see, there is 10 to 20 degree of aphakia is there. This creates negative dysphotopsia. In diabetics, well-controlled diabetics, we can implant these, and because there is no double or triple diffraction of green laser spot, so if they need PRP in future, there is no problem. And the large size of the IOL optic body is also a good advantage for retina surgeons for examination, treatment, and of course surgery. Contrast sensitivity is as good as young adolescent, and we removed 18 patients complaining of negative dysphotopsia, and now they all are doing good. Also, because of its large size, the Autofocus Pro is the lens of choice for various type of natural iatrogenic or traumatic coloboma and for mydriatic pupil induced by acute narrow-angle glaucoma. In some patient, we saw that the lens is shifted in the downward direction. So they have problem with the near vision. So we created this WhatsApp sort of spectrotomy, and they have a very good vision now. So as we compared the ringed multifocal IOL, so there is a problem in the night vision. But the Autofocus Pro drivers, they don't complain any problem during their night vision. Whose patient we don't need to implant? These are the perfectionist, type A personality, and those patients who are asking too many questions. So if we talk about the socio-sexual hierarchy, the beta, gamma, omega and delta, they will be very happy with this type of IOL, but not the alpha and this sigma kind of personality. My acknowledgements to Dr. Jagdeep M. Kakadia and Dr. Ramesh Shah sir for this innovation, beautiful innovation. Thank you so very much. And it's good to be at home. Thank you so very much.
Thank you, Dr. Arvind, for such a wonderful presentation. Now I request Dr. Inder Rustagi and Dr. Satish Nagpal to please felicitate Dr. Arvind. And meanwhile,
लाइन से चल रहा
है next talk on keratometers by Dr. Sandeep. Dr. Sandeep.
And thank you for giving me opportunity. Also known as anterior corneal curvature and axis and extent of astigmatism. Principle of keratometry is based on that anterior surface of cornea behaves like a mirror, and its radius of curvature can be calculated, and so the size of the image formed by that the power of the cornea can be calculated derived from the formula. And optics of keratometer consist of the mirrors basically which formed image by the anterior corneal surface, which whole size is calculated by the at the observer side. And types of keratometers are basically two types: manual and automated. Manual they are cost effective, portable, and some models does not even require electricity. Automated keratometers examples are IOL Master, Pentacam, Orbiscan, and corneal topographer. They are very easy to operate even by unskilled person and give report in very short time. Can provide detailed analysis and corneal presentation over time. Manual keratometers, they are basically different types like one position or two position, and their calculation are calculated by the superimposition of mirror image, and the image mirrors may be different in different types, and their limit is 36 to 52 diopters that can be increased to 30 to 61 diopters by adding some additional lenses at the telescope end. Limitation of manual keratometry: cornea is considered as sphere or has a spherocylindrical configuration, but we actually know cornea is aspherical in structure. It takes into account only the central curvature of 3 to 4 mm. Low accuracy in very flat or steep cornea. Corneal irregularity astigmatism will preclude the perfect corneal reading, keratometry reading, and keratometer have assumed the index of refraction in radius to diopter conversion. It employs paraaxial optics to measure the corneal surface power. Surface area of corneal covered by Myers of different devices. As we see, the manual keratometers cover only 3 to 4 mm diameter, and keratometer wise cover almost 75% of the area. And recent advanced corneal topography system Myers and Infento Myers cover almost all of the cornea. Corneal topography techniques, they are automated keratometers. Principal are Placido based, like Placido disc, video keratoscope, and slit scanning system are Orbiscan, and SYMPOSIUM imaging are Pentacam. Placido based devices are handheld Placido disc, and like the same principle on manual keratometer, they imagine the handheld Placido disc of white and black circles, and then the difference in distance between the Myers give an idea about the steepening and flattening. Corneal video keratoscopy, it is a blacklit Placido disc and camera respectively to image the cornea instead of indirect illumination and the observer eye. It measures central and mid peripheral cornea. Corneal video keratoscope limitation are measurement depend on reference axis, susceptible to artifact like distortion and tear film effect. Based on simplified optics only applies to central cornea. Smoothing effects and sampling occurs around circumference of Myers. There is no measurement between Myers. Scanning slit system. It is a series of slit lamp beams are compiled across the cornea to create a profile of cornea. Entire cornea covered with 40 vertical slits, normal to surface at each point of acquisition, capturing the backscattered light. And Orbiscan is depending on this principle. Advantage is direct measurement of posterior corneal surface, non-contact imaging, anterior segment imaging. Disadvantage are generation and detection of sufficiently narrow slit for accurate measurements are difficult to achieve, and also corneal edge affect the measurements. Orbiscan limitation are pachymetry lag in accuracy and reproducibility to SYMPOSIUM devices, and reading were not interchangeable. Inaccurately identify the post-operative posterior corneal surface, routinely locate the surface too anteriorly. Pentacam, it is rotating SYMPOSIUM camera system, and its advantage is that it direct measure the posterior corneal surface and also visualize the anterior chamber structure 360 degree. Disadvantage are difficult to measure small changes in central cornea as it left the central cornea in imaging, and so image distortion due to SYMPOSIUM principle must be compensated by computer. Advantage over Placido disc based topography. In Placido disc topography, that was only topography and pachymetry, but in Pentacam 3-dimensional corneal reconstruction is made, and so the posterior and anterior curvature are created along with pachymetry map. Comparison between Pentacam and Orbiscan. Pentacam is based on SYMPOSIUM principle, and Orbiscan is based on scanning slit and Placido disc system. In Pentacam, maintain the central point, the thinnest point of each meridian, thus can re-register each central point and eliminate the eye movement, so it is 10 times more accurate than the Orbiscan. Usage of keratometry in astigmatism assessment and monitoring, contact lens fitting, corneal shape assessment, anisometropia, and IOL power calculation. And in different studies, it was found that there was no statistically significant difference in the calculation of IOL power between manual keratometer and automatic keratometer. However, the time required for the calculation was very short in automated calorimetry, and also with other uses like we discussed in previous slide, and in other combination like auto refractor with keratometer.
So please sum up.
Factors leading to error in keratometry may be at the patient level, examiner or machine. Patient level exam, excessive lacrimation, faulty lead position, the patient has not fixed the instrument at examiner, abnormal functioning of corneal image as in manual keratometer, and machine incorrect calibration in manual keratometer. IOL master, it is distance independent telecentric keratometry. It enables robust and repeatable measurement and so excellent agreement between manual keratometer while achieving higher precision. In combination with a wide variety of established formulas, we can achieve refractive outcomes and can trust on their outcome.
Thank you.
Thank you, sir.
I request Dr. S.B. Jain and Dr. Rajiv Sood sir to felicitate Dr. Sandeep. Dr. S.B. Jain, Dr. Rajiv Sood. Next presentation by Dr. Ayush Singhal, biometric tools. Which one to choose?
Good afternoon, everyone. So my topic is biometric tools and which one should we choose. I have no financial disclosures to be made as I'll be naming lots of fancy instruments and equipments. So as you all know, cataract surgery is the most common surgical procedure performed worldwide. With the improving technology, instrumentation and availability of newer aspheric, multifocal, torics and EDOF IOLs, cataract surgery has provided wide range of refractive error correction than any other surgical procedure, and hence there has emerged the concept of refractive cataract surgery. Heightened patient expectations for precise post-operative refractive results has led to this. Now in order to meet these expectations, we need to pay attention to proper patient selection, IOL power calculation and appropriate IOL power formulas along with optimized lens constants. My talk will be basically based on the second point, that is accurate biometry. IOL power calculation is the single most important determinant of clinically improved results of a technically precise cataract surgery. Newer biometry instruments that perform ocular measurements with micron precisions and newer IOL calculation formulas provide precise IOL power required for intraocular implantation. Therefore, it forms the backbone of the refractive cataract surgery. Now, what is biometry? Biometry is the process of measuring various anatomical characteristics of the eye that are needed for IOL power calculation. It is basically applying mathematics to the biology. So what are the variables we need to calculate as a part of ocular biometry? These are corneal power, axial length, anterior chamber depth and lens thickness. Now we'll be coming to each of them. Corneal power, as has been explained by Dr. Sandeep in detail, I'll not go much into it. It basically is the second most important factor in calculating the IOL power, and it is in the ratio of 1:1 that it affects the IOL power. We can measure it by various ways, which has been already told in detail about principles of keratometer, different types of keratometers, handheld, and what are the popular brands we have. Now coming to the second important factor, it is perhaps the most important parameter for IOL power calculation, that is axial length. It changes the IOL power by nearly 2.5 to 3 times, and more so in shorter eyes. So even a unit of error in axial length calculation will lead to 3 times error in the calculation of IOL power. What is axial length? It is defined as a distance from anterior surface of the cornea to retinal pigment epithelium. Now we can measure axial length by 2 methods. One is ultrasonography and the other is optical methods. In ultrasonography method, it is traditionally measured by ultrasound, It is measured by time taken by sound beam to return to ultrasound transducer, and this distance is calculated. Clinically, there are two types where we can do it, either applanation or immersion techniques. In applanation, there is a direct contact of probe to the cornea, which gives us a chance of error by indenting the cornea, thereby erroneously decreasing the effective axial length. It is highly operator dependent, but it is more comfortable in doing. Immersion biometry, it is currently preferred technique of doing ultrasound biometry. It needs a coupling fluid in a shell with probe immersed in it. As there is no direct contact of the probe with the cornea, so there is no risk of indentation, and hence it is more accurate. But the patient is a little more uncomfortable position, as patient is in supine position, and it has less operator control. Now, what are the limitations of ultrasound biometry? It has a lower image resolution as it uses the long wavelength, and it measures the relatively small distance. It is highly operator dependent, and it cannot be used for multicentric comparisons. And variable retinal thickness, as ultrasound biometry measures the distance till the internal limiting membrane, and to this distance it adds on a fixed number of a retinal thickness. Although the retinal thickness might not be the same in every individual, but the retinal thickness which is added from internal limiting membrane to RPE is constant. So this is a little inconsistency in ultrasound biometry. Now coming to the another way of doing the axial length measurements, that is optical biometry. It is currently the gold standard for intraocular lens power calculation. It is highly accurate, non-invasive, easy to perform. It is an automated method for measuring the anatomical characteristics of eye. This method also measures the time needed from infrared light to travel from cornea to the retina. But it uses the principles of interferometry in order to avoid the problem of very high light speed measurements. There are two main instruments which are available for optical methods. One is IOL Master from Zeiss, and other is LensStar. So first coming to IOL Master, it was introduced in 1999, and it proved to be highly accurate and reliable for axial length measurements. It uses the infrared light in the range of 718 nanometers. In this, patient is asked to fixate on an internal light source to ensure the axiality to fovea. And when the light reflected from the fovea reaches back to the instrument, it calculates the axial length using modified Michelson interferometer. IOL Master is based on the principle of partial coherence interferometry. A signal is produced as a result of interference between the light reflected by the tear film and that reflected by the retinal pigment epithelium. Now, what is the data which we obtain from IOL Master? We can come to know about axial length using the principle of posterior coherence interferometry. We can come to know about the corneal power using telecentric keratometry technique, anterior chamber depth by using slit beam photographic technique, and wide to wide diameters. So these are the four parameters which we can come to know from IOL Master. Now, what are the advantages of IOL Master or optical biometer over ultrasound biometer? Optical biometers have low technician dependence, they are non-contact and rapid tests. It measures refractive axial length, that is from cornea to fovea, and not the anatomical axial length, which is from cornea to posterior pole. It actually measures the retinal thickness, as not in the case with ultrasound biometry. There is a 5-fold increase in accuracy due to better resolution. The resolution is in the range of 0.02 nanometers. As a result of these factors, it offers more precise and reproducible IOL measurements than ultrasound biometry or keratometry. So there is a 5-fold increase in accuracy in the optical biometry, and we can use in cases where we cannot use in A-scan, or it gives more reliable readings like posterior stapholoma, long and short eyes, eyes with silicon IOL. But it has few limitations also. IOL Master 500 is not very good in media opacities, patient having poor fixation or tear film abnormalities. Patient need to have minimum vision so that he can fixate properly, and in patients with maculopathy, it's not reliable, IOL Master 500. Also, we cannot measure lens thickness through IOL Master 500. IOL Master 700 is the upgradation of the technique. It uses swept source optical coherence tomography. It enables OCT imaging and visualization of the entire length of the eye. It provides full length OCT image of the eye showing anatomical details in longitudinal cut section. It also identifies the irregular geometries like lens tilt and lens decentration. Additionally, imaging of the fovea helps us in knowing whether patient is fixating properly or not.
Dr. Ayush, please, sir.
Okay, just coming to the lens star. Lens star is based on optical low coherence reflectometry. It uses 820 nanometers of the light. In addition to the 4 parameters which we can achieve from IOL master, we have additional 5 parameters which we can come from lens star: pachymetry, lens thickness, retinal thickness, pupil size, and eccentricity of visual axis. So in this way, lens star has an edge over IOL master 500. Various other optical biometers are iStar 900 from Hack Street. It is also a spectral OCT based. Tommy's OA 2000, it is based on Fourier domain technology, and Placido disc Argos from Alcon. It is again swept source OCT based technology, and it has enhanced retinal visualization mode which can be helpful in dark hard cataracts. Aladdin from Topcon also uses 3 principles like lens star. Nidec has optical biometer by name AL scan. Recently Toshbro has launched Anterion. It has a multimodal system. It has 5 applications: corneal application, cataract and matrix and imaging applications, which even helps in corneal evaluation along with the optical biometry. And the last is Galilei G6 Lens Professional. It is more based on Placido disc topography, Schemflick tomography. Thank you.
Thank you, Dr. Ayush, for such a wonderful presentation. Now I request Dr. Ayush to please stay, and I request Dr. Manisha Nada and Dr. Rajan Gupta to felicitate Dr. Ayush. Now Dr. Amit Arora will present formulae in IOL calculation, a tailor-made approach, and he has got 2 talks. Next one is role of AC.
Thank you everyone. So I will be very fast. My talk is on the evolution of IOL formula, why so many IOL formulas are there. It is often said that cataract surgery is effective surgery nowadays. In older days we used to remove the cataract and we used to give a spectacle, and now things have been opposite. We want to have a desired refractive effect, and that is why IOL according to that, and we want to reduce the spectacle dependency. So in all these things IOL formula is very important. IOL calculation plays a very important role. Let us skip this. Earlier we used to have only axial length measurement. Now so many things have been. Basically we are with the evolution, first generation, second generation, third generation and fourth generation formulas are there. First generation, basically if we divide these formulas, there are either theoretical formula, regression formula, or mixture of both. Theoretical formulas basically based on a mathematical principle of a schematic eye. And when we have use these formulas, we have seen so many surprises. So working backwards on the post-operative outcomes came the regression formulas. These were second generation formulas, and then came the mixture of these theoretical and regression formulas, that is third and fourth generation formulas. Let us. Sir Horald Ridley, the credit goes to Sir Ridley for implanting first IOL. Let us talk about these formulas. SRK formula. SRK formula is a regression formula that we use in our internship and PG time. This was a simple equation that we used to calculate the power is basically A minus 0.9 into K minus 2.5 into L. Here the power was related to the A constant, and there were so many variables of the A constant like IOL manufacturer, the style of IOL, that placement of IOL within the bag, what will be the intended location of the IOL. So when SRK formula came, there were 3 assumptions were made for the cornea. they assumed that cornea is a thin spherical lens and there is fixed A to C ratio, A to P ratio, and the index of refraction is 1.337. And they measured keratometry by the corneal power with keratometry or the corneal topography, and they give the simple this equation. So in SRK formula, what we need is basically the axial length, which is measured by the ultrasound A scan in the earlier times and the optical biometry in the recent times. And as you know, 1 millimeter error in the axial length can give 2.5 to 3.5 diopter of the error in IL power calculation. This SRK formula was very good for axial length between 22 and 24.5. Then came SRK2 formula. SRK2 formula is second generation formula. Earlier we, with first generation formula, were good when we used to do ECC and we used to implant ACIOL, because ACIOL was a fixed IOL and we have a fixed distance from cornea to the IOL plane. But when ECC started and phaco started, and when we started implanting IOL in the bag, then came the question, what will the exact lens positioning in the bag? And because of this, these different formulas came. SRK2 formula, with SRK2 formula, we were able to achieve 80% of the eyes with less than 1 diopter of the error, and this was much better than this. This has taken keratometry axial length, but this instead of A, there was a constant A1 was given, which was customized. Basically in SRK we see that was good between 22 to 24.5 diopter of axial length, but when you apply this SRK formula for short eyes and long eyes, you got error. So A1 was devised. A1 means if you have hypermetropic eye, we used to add +1, +2 or +3 depending upon the axial length in short eyes. And for myopes we used to add -0.5 or we used to subtract 0.5. So this was basically SRK2 formula. Then Hofer formula also came in second generation, and in this thing he tried to take into account the pseudophakic depth. Apart from what he tried to estimate the post-operative pseudophakic depth apart from axial length and the corneal power. So in conclusion, in SRK formula was good when you have to implant an ACIOL or you had to do ECC with ACIOL only. For SRK2, when you started with ECC, you started doing phaco and you used to put IOL in the bag. Then came the third generation formulas. What was the need of these third generation formulas? These third generation, as I told you, these were the mixture of regression as well as mathematical formulas. So basically 3 third generation formulas were Hofer Q, Hollard A1 and SRKT. Hofer Q the variable was basically he tried to estimate the pseudophakic AC depth. Hollard A1 took into account the surgeon's factor, and SRKT worked on A constant of these formulas. So third generation formula, they improved the accuracy and they had better results. Basically, apart from axial length and keratometry, these formulas they try to estimate the effective lens position in the bag. What is effective lens position? It is the distance of the cornea to the lens, the IOL basically, and effective lens position is very difficult to predict because IOL is thinner than the cataract. Then AC depth tends to increase with pseudophakia, and there is variable lens geometry across the whole power range. So in third generation formula, they put an assumption. They thought that eyes which are longer eyes and those with steep K, they thought that it will have a deeper effective lens position. And other thing, they thought whatever eye is short or those who have flat K will have a shallow effective lens position. So Hofer Q, he used 3-4 factors actually. Apart from axial and keratometry, he took into account any previous refraction, and he took into account the estimated PACD. PACD is basically what will be the pseudophakic AC depth, which he tried to estimate from personalized A constant, and he gave this equation. Hofer Q formula was very good for when they worked on it. That was very good when the axial length is less than 22. For shorter eyes, it was very good. In post-corneal refractive surgery, there was still a surprise because, as I told you, these third generation formula assumed the things. Assumed means flat K means it will be shallow ELP, and if steep K will be there, there will be a long ELP. So whenever the corneal power changed with PRK or the LASIK, and with the keratometers we were actually measuring the anterior corneal surface only. So myopic LASIK, after doing myopic LASIK, whenever we used to calculate the IOL power, it was underestimation of IOL power, and with hyperopic LASIK there was overestimation of IOL power because of the change in the anterior keratometry. So two methods were devised, Masket method and double K method. Masket method was basically they added they calculated the IOL power with the same formulas, and with this they added this equation. Basically this is a very, in our practice, if we don't have any optical biometers or anything else, what you can do is, if you know the preoperative refraction of any patient undergoing LASIK, say if he had 3 diopters corrected or 4 diopters corrected, 6 diopters corrected, you just 1/3 of it, and you subtract it in cases of myopic, in hyperopic LASIK, and you add it in cases of myopic LASIK. This is the basic formula that was given by Masket method. Second is Aramberry's method of double K modification. If you have preoperative K and postoperative K, then the preoperative K is used to measure the effective lens position, and postoperative K after LASIK, that is used to basically calculate the IOL power. And this is very effective method, Aramberry's method. And he gave this table, what to subtract in cases of hyperopia and what to add in cases of myopia after calculating IOL from the basic formula. Then came the Holaday 1 3rd generation formula, which added another factor. This was very good for steep corneas more than 45 diopters and axial length of 24.5 to 26 millimeters, that is medium long eyes. He took into account, apart from axial length keratometry, he took into account basically surgeon's factor. What is surgeon's factor? Basically he tried to estimate the distance between the iris plane and the IOL position. So till now we know between 22 to 24.5 any of the formula will work. For shorter eyes Hoffer Q will be good, and for longer eyes more than between 24.5 to 26 Holaday 1 will be good. What is surgeon factor? I was telling it is the distance between iris plane to the IOL optic plane, and that should be personalized. This Holaday tried to personalize this because any change in 1 millimeter will cause a 1.5 diopter change in the final refraction. So Holaday 1, after refractive surgery, he used the same Aramberry method for post LASIK patients. Then came third generation formula, that is SRKT. SRKT was same as SRK2. Only thing was that this SRKT used a TT, stands for theoretical model. They added a linear progression. In SRKT for theoretical is one such formula representing basically a combination of linear regression method with a theoretical eye model. So SRK1 we know, SRK2 we know, where we added +1, +2, +3 or -0.5, and SRKT based on the post-operative results and a theoretical model, they personalize the A constant, and they personalize these A constant based on the IOL models. Different IOL models have different A constants for even for the same power correction, and they personalize the A constants based on the location of the IOL within the eye, whether it is in the sulcus or in the bag or in the AC. For the AC they used a constant of say 115.5, for sulcus they used a constant of 117.5, for in the bag they used a constant of 118.5. So SRKT basically changed the A constants based on the location of the IOL and based on the brand of IOL which is to be used. It was manufacturer dependent. Say any IOL with A constant of 118.4 will require 21 diopter, and thus another brand of A constant of 118.9 will require 21.5 diopter. So there is 0.5 diopter of difference between the two IOLs to achieve the same emmetropia in the same eye. Is there any difference in refractive outcome using SRK2 and SRKT? No. There was no difference in the predictability value, but there was difference in the predictability of refractive outcomes between the different IOLs by using SRKT. So third generation formula, till now we know any formula will work between 22 to 24. SR Holiday 1 will be best for 24 to 26, Hofer Q will be best for less than 22, SRKT will be best for more than 26. Till now, third generation formulas were good. So why there was the need for fourth generation formulas when the things are working? Things were not working. Actually, we want to improve our outcome. Till now, 80% of the eyes were within 1 diopter of range, and we want to make it to 0.5 diopter. So with the use of fourth generation formulas, 80% of the eyes, they have come to within 0.5 diopter. These fourth generation formulas are Holiday 2, Haigis and Olsen formula. What are the principles of these formulas? First is the work done by Haigis. Haigis worked with IL Master 500 and IL Master 500 software, and he devised this Haigis formula. This Haigis formula is he devised basically 3 constants. Till now, what was assumed, as I told you, they assumed that longer eyes will have deeper anterior chamber. They assumed that shorter eyes will have shallow anterior chamber. But that was not true, and this was the main cause of error for shorter eyes and the longer eyes. So Haigis gave us, this is the first talk, second talk time. A1 is related to AC depth and A2 is related to the axial length. So he gave 3 constants, A0, A1 and A2. And then came another formula, which was the Holiday 2 formula, and this has revolutionized the things. What he did actually, Holiday 2, Sir Holiday, he involved 34 cataract surgeons to determine 7 variables.
Please wrap it up fast.
One talk time is there, second talk time. Just बस थोड़ा सा last खत्म ही हो जाएगा अब इसके बाद. There were 7 variables. They told the relative importance of all these variables for IL power calculation. They assumed that axial length is the most important variable for IL power, followed by average keratometry, followed by horizontal wide to wide, then refraction, then AC depth, then lens thickness, and then the age. And what was surprising was that horizontal wide to wide measurement emerged as the next important variable apart from axial length and keratometry in determining IOL power. And they also proved that there is no significant correlation between the axial length and the size of the anterior segment. This is the most important thing. Holiday 2 gave 9 eye models basically. In the center is basically eyes with normal axial length. On the right side is eyes with longer axial length, and on the left side is eyes with shorter axial length. As you can see, 96% of eyes with the normal axial length, they have the normal anterior segment. On the other hand, 90% of the eyes with axial myopia still has the normal anterior segment. Only 10% has large anterior segment, and similarly 80% of the eyes, short eyes, they have still the normal anterior segment. Only 20% has the short anterior segment, and this was the reason why Holiday 2 gives the best results. So he put all 7 variables for calculating the IOL formula, and he gave this formula. So you can say till now any formula work for the normal eyes. Haigis will work for the small, medium and large eyes, but in extreme cases you will have to use A1, A2 constants also. And Holiday 2 works for all types of eyes, right from extremely long to short to myopic eyes. Holiday 2 is with IL Master 500, 700, Argus with all these things. One more formula in the recent generation is Olsen formula, which is there with lens star. Olsen worked on the principle of ray tracing. On the basis of ray tracing, basically he used axial and paraaxial light to directly determine the AC depth and lens thickness. Till now, in the left side you can see there is a H factor and surgeon's factor. H factor is basically corneal height, which is determined by corneal diameter and the shape of the cornea, and SF factor is surgeon's factor depending on the position of IOL. Whereas on Olsen directly used ray tracing to calculate the AC depth and the lens thickness, and he omitted all other things. So he basically devised C factor. C factor is basically a fraction of the lens thickness, and it tells, this C factor tells you where exactly the IOL will be there in the capsular bag. So that is why the Olson's formula's predictability is very good, particularly in myopic eyes, in hyperopic eyes, for normal eyes, and particularly for post-LASIK eyes also, because it is not using any keratometry data for calculation. This is there with the lens star. Now is the new what is effective lens?
You have to hurry up your time for both the talks is over.
Yes. Yes. Just to say, Barrett's universal formula, and this is now currently accepted the most important formula. This is based on theoretical model of the eye, and it retains the positive correlation of axial length, keratometry, AC depth. In Barrett's formula, what is different is it has incorporated the principal plane of the IOL in this formula, and that is why its accuracy has even become more than even Holaday 2 and other formulas. Last is we are now incorporating artificial intelligence into this thing, and with the incorporation of artificial intelligence, Keynes formula, HRBF formulas, the accuracy is becoming now 90 to 95%. Thank you.
Thank you.
Thank you, Dr. Amit, for wonderful presentation.
Yeah, before Dr. Monga starts, there is an announcement that there is going to be very exciting quiz session by Quiz Master Dr. Kapil Midda and Ashish Lal of 20 to 25 minutes with lots of audience prizes. And anyone who wants to play his team can form the team and give the names. Yeah.
Before Dr. Monga starts, I request Dr. Hemant Fogart and Dr. Salil Gupta to felicitate Dr. Amit.
Team of two people. Oh, Hemant bhai, dhyan se.
Very good afternoon. My warm greetings to dignitaries on the dais, off the dais, and my dear colleagues. Dr. Harshul has discussed what to do in toric IOL implantation. What if things go wrong? My talk is how to ensure that things don't go wrong. Financial disclosure, but yes, currently two type of system are in vogue. One is Callisto from Zeiss and another is Varion from Alcon. As I am currently using Varion, so my talk is mainly based upon Varion. As we all know, these days cataract surgery has become cataract refractive surgery, and with the advent of LASIK, patient expectations have gone very high, and everyone wants 6/6 vision. But how to get this vision? There are so many variables in cataract surgery, especially toric IOL implantation, starting from biometric error, transcription, astigmatism planning, then manual marking error, then cyclorotation, surgeon-induced astigmatism, then capsular axis construction, IOL positioning, and then how to optimize all these factors. Image guiding system has the potential to reduce all these variables to get good vision, to get optimal outcomes. So what is digital guidance system? It captures the data from eye to be operated in the OPD itself, and this data is transferred to OR, and the plan is overlaid on the eye being operated while microscope. So this system is designed to decrease variables in cataract surgery and to get more consistency in surgical results. Pre-operatively, a high resolution reference picture is taken from the eye to be operated, and by using various biometric formula, we plan the IOL to be implanted and at what axis it is to be implanted. Pre-operatively plan, then intra-op guide, it is transferred to the OT and overlaid through the microscope. First step in the OT is to register the eye. In register the eye means in the OT, the reference picture is matched with the eye to be operated, so that the right eye is being operated. Then intra-op incision sites are overlaid on the microscope live image. As you can see in the picture, you can plan your incision accordingly. You can construct your capsular axis if you want to decenter a little bit, if you want to center a little bit, or you can customize the size of your axis as well. Then toric IOL orientation is overlaid on the microscopic image. And post-operatively, by using the data, we can optimize our A constant for various IOLs, and also we can calculate surgery-induced astigmatism. However, there are shortcomings in this system, as this system is based upon, the keratometry system is based upon the Placido disc system, and it ignores the posterior corneal astigmatism, and we were getting inconsistent results when we were totally relying on this system. So we devised a little different strategy. What we did first biometry by IOL master. We took TrueK, which included posterior corneal astigmatism also. We take spherical IOL power from IOL master and astigmatism also from IOL master, confirmed whether these results are corroborated from the topography. Then we did all these planning on the Varion. IOL master also gives the ideal IOL spherical power as well ideal cylinder to be implanted. All these data is taken care, and final planning is done. Barrett for various IOL designs, various IOL models. Different companies have their own toric IOL calculator also. We generally use that also. That also give the nearest IOL model available for this particular astigmatism. And then the final plan, the intra-op toric IOL orientation is overlaid on the microscope image. And to check this new strategy, we did a small clinical audit to see residual astigmatism after toric IOL implantation. We did a study on 50 consecutive cases of toric IOL implantation. And in our study, out of these 50, 49 patients had desired outcome as per our reference range, as per meta-analysis taken. One patient had astigmatism beyond this range. One patient has had astigmatism of 1 diopter. It was a little unexpected. We worked upon it. We found somehow both the axes were getting flatter after the surgery. However, using the astigmatismfix.com, IOL was rotated to the new target, and the ultimate astigmatism was 0.25 diopter. So to conclude, digital guidance system is quite a useful tool to reduce postoperative residual astigmatism by controlling various variables in cataract surgery. Thank you.
Thank you, Dr. Monga. Now I request Dr. Mansi Jindal and Dr. Neeti Garg to felicitate Dr. Ashish and Dr. Monga. And Dr. Salil Gupta to come for his presentation.
Thank you. You really deserve the
very to the point presentation. Really very nice.
Dr. Praveen Monga and Dr. Mansi Jindal are classmates also. Okay, college mates.
Junior से senior बदल जा रहे reunion करवा रहे हो basically.
Next, Dr. Salil Gupta on understanding.
People are still. I am the showstopper of the day, it seems. So I'll just run off these refractive IOLs because no one is using nowadays. We'll just go straight for the diffractive ones. Okay, so diffractive multifocal IOLs. This type of IOL utilizes principle of diffraction in conjunction with refraction to create two foci or more than two foci. The basic refractive power is provided by the anterior aspheric surface, and the diffractive power comes from the multiple grooves you called as steps from the posterior surface. So what is the meaning of diffraction? Diffraction is a slight bending of the light as it passes through the edge of an object. The amount of bend depends upon the wavelength of the light and the size of the opening. If the opening is much larger, then the light's wavelength bending will be almost unnoticeable. However, if the two are closer in size or equal, the amount of bending is considerable and easily seen by the naked eye. So this is how a diffractive IOL looks like. You have in the center you have a plain looking surface which we call as a bull's area. Then you have multiple steps along that, and the diffraction is produced by the steps, right? So that you can have multiple foci. So when the light passes through these steps, so some of the light which will pass from the bull's area will have order 0, right? They will not be diffractive, so you have the vision for the far. Some of the light which will be passing from the step will be focused at one point. This is called order 1 or order 2, depending whether you are wanting a trifocal or a bifocal IOL, right? So now the things to be considered is what is this step width and step height. This step width gives you the amount of utilization of the light energy. As we say, 80%, 70% energy, whatever the utilization is there. And the step height gives you the amount of diffraction. So that will consider you the power and how much and as much the amount, whether you want a plus 1.75 add or you want a 3 add. So that will give you the power. Now in the same slide I will take. So approximately till date what we know that 40% of the light in bifocal diffractive IOLs was being used for the far and 40% for the near, and there was loss of 20% of the light. So 80% of light waves were utilized to give you the vision. So now came the trifocal technology. So what happened in trifocal technology? We have this central thing. Now this is like a trough you see, right? Then you have two heights of the steps. The first height will give you the intermediate vision, and the second step, which is slightly less than the first step, gives you the near vision. Right. Now, what are we worried about when we are using our trifocal lens? We are worried about the halos and glare. So how the halos and glare are produced when you are using a diffractive thing? The halos are produced by the width of your step, and the glare is produced by the height. So if you remember the physics, there was something called as total internal reflection. So the lights which fall on the tip of this step, that is totally internally reflected. That is angle C. So this gives you the glare. So if few IOLs like Physioil and all, what they have done is that they have truncated this thing. So they have rounded off this thing, and hence they have decreased the glare. So the newer trifocal IOLs, when we say they are glare free, glycerin free, what they have done is they have truncated the height, the edge of the step height. Then came something called as the enlightened technology, where you have 3 step heights. Okay? So they give you further adds to that. Then another thing we are talking nowadays is something called as apodization. Few of your trifocals are apodized, few are not. So what do we mean by apodization? Apodization means that the step height will decrease from the center to the periphery. So how it helps? The peripheral light, otherwise if the steps would have been same height, the light would have been distributed for near and for intermediate too. But by decreasing the step heights, we are going more towards the planar side. So these waves will be more utilized for the far vision. So in the mesopic conditions, you will have a better view as compared to the area where you have the same step heights throughout the lens. Then what should be the near vision, or what should be the point of intermediate vision? So there was a study done by OSHA, and they recommended that 60 centimeters should be the possible, it will be a good thing to use for the intermediate vision, right? So traditionally what was there, we were using near vision for 40 centimeters, intermediate for 80, and distance for more than that, more than 120. Then came the technology of quadrifocal IOLs, where we introduced these steps to 60 centimeters. But then that gave a lot of glare. So what was done, that the 80 centimeter was shifted to the distance, and you got a step of 60 centimeters. Now how was that done? So if we look back here now, so this step 2, if you see the step 2 over here, this is step 1, step 2. In this step 2, they have a truncation over here. So by this, what they have done is, they have shifted the 80 centimeter to 60 centimeter step. So now you have a 40 centimeter foci for near, 60 for intermediate, and more than 120 for your distance vision. Now, we don't have a EDOF talk, but there's one thing I wanted to emphasize was, we have refractive IOLs, then came diffraction. Now what we are talking about is your wavefront shaping IOLs. So what is your wavefront shaping? How do you do that? So what has been done over here is that in the center, the bullseye area, they have given 2 zones, the plateau zones. Now what the plateau zone will do, when your light wavefront is passing through it, it will decrease the speed of the light. So now the peripheral zone, you have a normal speed. In this zone, you have a slightly slower speed of the light. So when you are getting a foci, that stretches your vision. So you get an elongated view. So then this will give you something like what you say is a continuous vision. Right. So this is how you are getting a wavefront shaping IOLs nowadays. But of course, what sir explained, Dr. Arvind, that was marvelous thing. I hope these lenses soon come in commercial use also. So we don't have to worry about these technologies. Is it? Yeah. This was the first time I heard from your mouth. Hopefully I will get it from you today. So this is how it looks like. There is a transition element which decrease the speed of the light, and there from the light waves which pass from this area, they are of the normal speed.
Please conclude.
Conclude. So last thing I would say is about the chromatic aberrations. So when we are using a refractive IOL, you have something called as positive refractive aberrations, and when we are using a diffractive IOL, you get a negative this thing. But when you combine both, the chromatic aberrations decrease, because plus and minus, if you have a combination of refractive and diffractive IOLs, the LCA, that is the longitudinal chromatic aberrations, they decrease. Then another thing I wanted to just emphasize was there are full IOLs which have steps throughout the optic, and there are few IOLs which have steps only in the 4.5 mm or something like area. So how is that useful? This is your pupil independent, and this becomes your pupil dependent. But the problem is here, in mesopic conditions, you will have a confused picture, because all the rings are being utilized for far, intermediate and near. So you have slightly confusion over there. But here, the far vision will be better. In mesopic conditions, you want more far vision. So far vision is better over here. Then the angle kappa considerations, as I said, there is something called a Boole's area. Now, Boole's area, if it is larger in your IOL, it is something like 1.56. So even if there is a bit of decentration in your multifocal IOL, it will be compensated. And angle kappa is also compensated to a bit of the thing. Last thing is your design. This type of loops, they give you a better centration, right? A double loop technology. And another thing is your ridge technology. So what is ridge technology? You have ridges over your haptics. They help us help the haptics don't stick together. So the opening is very smooth over here. Last is your negative dysphotopsias and edge technology. Thank you.
Thank you.
Thank you, Dr. Salil, for wonderful presentation. I request Dr. C.P. Dadeech sir, Dr. Salil, and I'll also join.
Be ready with the quiz masters to be ready, and
also request Dr. Prashant sir to please facilitate our panelist. Dr. S.B. Jain sir, please come. Dr. Dheeraj Gupta, Rastogi, Dr. Hemant Fogart, and photographer, please take a group photo. आपकी टीम All those who are interested to participate in the quiz, kindly make a team of two person. Audience who want to participate in the quiz, please be ready with your team names, and you can come and get your team names noted down.
Yes, doctor.
हाँ सर डन। आप उधर ठीक है आपने हमारी हेल्प कर हाँ जो बताया।
Dear friends, we are here with a very short and sweet quiz, and we have prizes made of gold and diamonds and pearls and rubies. So, and special lunar dust brought from the moon by Chandrayaan 3. So please, I'll just tell you, get ready and take these answer sheets from me. 2 members in each team. 2 members in each team. We have already distributed quite a few. We have only a very few left. Everybody can play this quiz. We have quiz for everyone, and anybody can take this sheet and play the quiz. So we have a prelim round and then a final round, and lots of questions for the audience, with lots of songs and dancer and some ophthalmology. Songs and dances and some ophthalmology. Yes, take 2 members in each team. Write down your names on the top of above HOS quiz, because below that are the answers.
So we have 2 rounds. First is the prelim round, where we are going to ask 12 questions, +2 and -1, and lots of audience questions. So every third question will be an audience question, which will be a mix of Bollywood and ophthalmology. And then we have a rapid fire round. So in all, we are just going to take 15 to 20 minutes, a short and sweet quiz. And we are really thankful to the entire Sirsa Ophthalmological Society who have given us this opportunity, especially Dr. Rajan Gupta, who specifically called me up and said, you have to do it. Dr. Mahib Bansal, Dr. Praveen Arora, thank you very much for giving us this opportunity, and we are going to make a good fun quiz for all of you.
And President ARC Dr. Prashant Bhavankule,
yes,
who is a quiz maestro himself. A big round of applause for you, sir, for conducting this ARC here, and just such a wonderful ARC. First of all, for the local organizing committee, for the ARC, for everybody involved in this thing, a big round of applause for all of us, and even a bigger round of applause for calling us for the quiz. Thank you so much. स्पीकर नहीं चाहिए हमें, नहीं चाहिए स्पीकर, नहीं चाहिए, हम ही स्पीकर हैं. डोंट नीड एनी स्पीकर, वी आर द स्पीकर. सिर्फ आप इसको स्लाइड शो पे लगा दो. So, before I ask Dr. Ashish to tell you the small rules of this quiz, I can see that ये है, इसको यार काट देना, ये नाम काट देना, ऊपर नाम लिख देना, ठीक है? So, we have distributed all our answer sheets. Everybody can play this quiz. I am Kapil Midda, with me Dr. Ashish Lal. We have been doing the quizzes so often that we have forgotten how many we have done, and we are thankful to everybody that you guys like our quizzes, and we are so happy to do them with you. Dr. Rajan Gupta, thank you so much. You have to help us with the scoring. So anything goes wrong with the scoring, you know whom to contact. Dr. Gaurav Goyal, you have to help us. Dr. Mahib Bansal, you have to help us. So we'll tell you how we go along. Dr. Ashish, you want to tell the rules of the quiz?
And we want Dr. Rajan, Dr. Gaurav to help us in distributing the audience prizes also. Please come over with us. And before we move on to our actual quiz, we have the quiz rules. There is a preliminary round and a final round. Everyone can play. We have distributed the answer sheets. Make a team of 2. So 2 members in each team, 12 questions in 10 minutes. We ask you write down the answer, +2 for the right and -1 for the wrong. After that, we are going to evaluate the answer sheets for 5 minutes, and we are going to throw open these questions for the audience. The top 3 teams will play a final rapid fire round, 3 questions, +10 and -5. And before we move on, we have a quiz anthem with us, and Dr. Gaurav said that there is a special party which is awaiting us post the quiz, so we have this special anthem for all of us.
And Dr. Ashish forgot the most important rule of the quiz, because so many Illuminati are sitting here who obviously know more than us. The most important rule of the quiz, Dr. Ashish, the quiz master's decision is
always right.
Final. So the quiz master is always right, and here we go with the quiz anthem. Life की सिंपल सी फिलॉसफी है, जान लो हम यहाँ 2 पल के मेहमान हैं, पहचान लो। नॉन स्टॉप ये पार्टी है, यहाँ सबको आना है, और खाना खा के दारू
पी के
नहीं,
क्विज खेल के,
खाना खा के, क्विज खेल के, कॉफी पी के, प्राइज लेके,
और जो मुझे पिलाए वो पी के जाना है.
And here we go. Here we go with the quiz. The first question for the audience, Dr. Ashish.
So look at this diagnostic modality. You have to give me what is the diagnostic modality, what is the problem, and how have we treated it. This is an audience question. Anybody from the audience?
DMD, ASOCT.
Absolutely right. This is an ASOCT. Please explain.
This is ASOCT showing DMD with bulla.
Yeah.
Post air injection.
Yes. So this is a case of sort of bullous keratopathy where there is a Descemet's membrane detachment, and you can see the bulla. So we injected air, and Dr. Yuvika has got a first audience prize. Thank you, Dr. Yuvika. A big round of applause for Dr. Yuvika.
So the next question for the audience, before we go with the quiz. So we said we have song and laughter and some ophthalmology. The ophthalmology part has been done. So let's see. This movie won an Oscar, and come young lad, yes, come fair boy, yes, come young lad, dance, 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 brothers dance. Dance like a sour raw mango, dance like you are bitten by a scorpion. Which is this song, and who will sing the hook number with me?
Nacho, nacho,
nacho. Yes, absolutely right.
Sir, please.
Ha, aaja chore, ha, aaja gore, nacho. Nacho, 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 Viro, nacho. Nacho, 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 yaro, nacho. Nacho, nacho, कच्ची कैरी जैसा खट्टा नाचो. Nacho, nacho, बिच्छू जैसे काटा वैसे नाचो. Sir,
Dr. Arvind Maurya.
Yeah, round of applause and a gift for Dr. Arvind Maurya.
So now we move on to some ophthalmology. So question number 1 for you. Please look at this pentacam and give me the diagnosis. Look at these 4 maps and give me the diagnosis. We move on to question number 2 for you. Please write down your diagnosis. Question number 2, Dr. Mehta.
Right. So look at the pentacam, write down the diagnosis. Next question coming up, here it comes. Look at this OCT, write down the diagnosis. 1, 2, 3, 4. And here we go with the question number
3.
So a patient with history of asthma, hypertension, OAG treated with latanoprost had worsening fields over a period of 1 year. So which further evaluation is best indicated at this time? Referral to a neurologist, referral to her cardiologist, referral to a pulmonologist, or refer to a retina specialist? Look at the fields. There is worsening and the patient has asthma, hypertension, and the IOP is under control. So we move on. You have to write down A, B, C or D as your answer choice. +2 for right and -1 for wrong.
A, B, C or D, and where we go with question number 4 coming up on your monitors. Look at this OCT, look at this picture, fundus photograph, and give me your diagnosis. Write down the diagnosis. 1, 2, 3 and 4, and here we go with more. Dr. Ashish.
So next question, I threw my modesty away. The world is yet to see the new Shameless Me. Yes, somebody has to sing.
Controversial song because of some dress thing. Yes. Let's see. हमें तो लूट लिया मिलके. कोई गाओ हमारे साथ. हमें भी नहीं आता. इश्क वालों. आपको प्राइज लेना है ना, थोड़ा सा गाओ. बहुत ही तंग
अब तक इन ख्यालों ने नशा चढ़ा जो शरीफी का उतार फेंका है. बेशरम रंग कहाँ देखा
डॉक्टर साहब के लिए बहुत बढ़िया. थैंक यू सो मच फॉर बीइंग सच ए स्पोर्ट. आपका नाम है डॉक्टर साहब? राउंड ऑफ अप्लॉज. थैंक यू. मेरा बहुत दे रहा है. ठीक है. Okay, now look at this pentacam. Something very striking is staring at you. You look at it for a few more seconds. Something is very striking and it's staring at you. Very striking. I will not go beyond that. Something is very striking, is staring at you. I am giving you a few more seconds. I know I find pentacams deciphering very difficult. You don't have to speak. It may not be right what you're saying. It may be wrong. But something very striking is staring at you. You don't have to speak. You have to write down. Next question.
Question number 6. An orbital floor fracture in an emergency department. Which imaging modality is best suited to evaluate the orbit in this case? Ultrasound, biomicroscopy, MRI, CT or OCT? We move on to question number 7.
Okay, look at this pentagram again. Look at all the pictures here. They are telling you a story. So I think everybody is such an expert. I am going to move very fast. And coming up, the next question with Dr. Ashish. You have seen it, and you have seen it. Here we go. Dr. Ashish, your question.
Now look at this OCT picture. And there is something that
Gupta is going to help us. Dr. Gaurav Goyal is going. Ashish will check the answer sheets in 5 minutes. And I ask, please don't any hand, please. Yes, you sir, you raise the hand. Who said keratoconus? You're right, sir. Please come and take a gift. Please come.
ठीक है, सीएम में लिख दिया दे
सीटी लिखा है आपने।
हमें ये अच्छा लग रहा है कि आपने ध्यान से खेला है और आप हमको बोल रहे हो, ये पूछ रहे हो, ये पूछ रहे हो। कम से कम हमने आपको जगा के रखा है, हमें इसी चीज की खुशी है। देयर इज ऑलवेज ए स्कोप फॉर इंप्रूवमेंट। ओके, नेक्स्ट क्वेश्चन। यस, और सो मेनी हैंड्स रेज। डॉक्टर राजन, आप जिससे पूछोगे उसी को प्राइज देंगे। आप यहां आप पूछोगे किससे? Yes, absolutely right, sir. Your gift for you.
आप ऐसे करो, आप मार्किंग करो, मैं।
हाँ।
इसका 2 ना। ओके जी। डॉक्टर राजन, आपने देखना है कौन हाथ खड़ा कर रहा है, भाई बताओ। आप ये मैडम डॉक्टर। हाँ, नहीं आप बताओ। हाँ, पूछो। आंसर इज डी। No, D is not the answer. Yes, cardiologist for any nocturnal hypotension. Yes. हाँ, पार्टिसिपेट करने के लिए उन्हें भी दो और उन्हें भी दो। जब खत्म हो जाएंगे हम ऑडियंस का क्वेश्चन पूछना बंद कर देंगे। All gifts are made from gold and diamonds and rubies and pearls. Okay. ठीक है, नेक्स्ट क्वेश्चन। डॉक्टर राजन, आपकी पैनी निगाहें चाहिए मेरे को। ओके, प्लीज रेज योर। डॉक्टर राजन, बताओ किन से पूछना है आपने? आप बताओगे? डॉक्टर राजन बताएंगे कहां से पूछेंगे? हाँ, पूछो, बताओ। PED, लेट मी सी। ये रेटना का क्वेश्चन है, डॉक्टर आशीष बनाते हैं। CNVM, नो। हाँ, ये CNVM है, PED नहीं है।
This is a PED, but it is.
तो PED वाले को दे सकते हैं?
Diagnosis is a CNVM. PED is wrong.
PED वाली को ऑडियंस के PG स्टूडेंट को तो
PED, but you have to write the diagnosis.
देना है कि नहीं देना है? दो ना। हाँ। ठीक है जी, अगला आ रहा है। ये तो हो गया। राइट, ये बताओ डॉक्टर राजन, आपने देखना है किन्होंने। सर, आपसे तो पूछना ही नहीं है ना। मैडम बता रही हैं? नहीं, डॉक्टर राजन बता रहे हैं किसी को। क्या नाम बताओ, पूरा बोलो। पैलिसेड मार्जिनल डिजेनरेशन, क्रैब क्लॉ अपीयरेंस, क्रैब क्लॉ,
जो थिनेस्ट एरिया है वहां वो स्टीपेस्ट एरिया नहीं है। मेरे को भी इतना ही पता है। ठीक है सर, ठीक है ना इतना? हाँ हाँ। चलो जी, अगला आ रहा है। सर आप बताओ ना, ऐसे थोड़े ना हम बांटते रहेंगे। आप बताओ किन से पूछना है। सीटी, लेट मी सी। एब्सोल्युटली राइट। ऐसा ही क्विज AIOC कैलकाटा 2010 में किया था। यहां आप देखो 30 लोग हैं, 35 होंगे, बहुत अच्छा। वहां 350-400 लोग थे और ऑडियंस सवाल ऐसे ही पूछे थे। 30-35 ऑडियंस सवाल थे और 400 लोग हाथ खड़ा करते थे। हम लगभग 10 वॉलंटियर थे, तो 400 में हाथ खड़ा होता था। वो वॉलंटियर जिससे पूछता था उसको प्राइज देते थे। बड़ा मजा आया था। अब यहां सारा जिम्मा डॉक्टर राजन का हो रहा है। बताओ जी, बताओ। नहीं डॉक्टर राजन आप बताओ ना, कौन, ऐसे थोड़े ना।
ऐसा है, 4 टीम सेलेक्ट करनी पड़ेगी। सुनो सही।
हाँ जी, नहीं मूरन्स नहीं है ये।
3 किलो है ना?
नहीं जी, ये नहीं है वो। ये थोड़ा सा पोस्ट लेजिक एक्टेजिया भी नहीं है। आप देखो सेंट्रल कॉर्निया इतना थिक है यार, कैसे देखो तो सही। 576 आ रहा है। देखो सेंट्रल फ्लैटनिंग, मेरे को ज्यादा नहीं आता। आप देखो सेंट्रल फ्लैटनिंग है, बीच में भी थिक है, साइडों में ये सब उल्टा पुल्टा चल रहा है। ये पोस्ट आरके है, ये पोस्ट आरके पेंटाकैम है। ये देखो सेंट्रल थिक है और बीच में फ्लाइटनिंग भी हो रही है, साइड में सब ये चल रहा है। ये पोस्ट आरके है। ये किसी को नहीं मिला, ये किसी को नहीं मिला ना। आशीष मैंने कहा था बहुत मुश्किल सवाल डाल रहा है, तो देख ले। चलो जी बताओ, ये तो बहुत आसान है। अरे डॉक्टर राजन पूछो, बताओ आप बताओ। हाँ जी, ARMD कौन से वाली? वैसे दे सकते हैं क्योंकि ये ड्रूसेंस है, आपको दे देते हैं। ड्रूसेंस से ही बनती है ना। हाँ, आप आगे आगे लोगे तो फोटो खींचेगी। आशीष कहां तक पहुंचे? मैं आऊं।
We have a special situation.
अच्छा, स्पेशल सिचुएशन क्या हमें टाइम मेकर करना पड़ेगा? तो 2 का रैपिड फायर। चलो अभी थोड़ा सा सॉर्ट आउट करते हैं, रैपिड फायर कर लेंगे यार। हमारे पास रैपिड फायर भी है। चलो ये अगला बताओ। ये तो हो गया। डॉक्टर राजन बताओ किससे पूछना है? बिल्कुल बिल्कुल ठीक बोला आपने। एग्जैक्टली यार, ये तो रेटना के बंदे हैं तो ठीक ही बोलेंगे, फिर भी गिफ्ट तो देना है ना। डॉक्टर राजन हमें क्विज करने बताया, अब अलर्ट रहना पड़ेगा, ऐसे नहीं चलेगा, आप बैठ नहीं सकते अब। हाँ जी देख लो, ये बहुत आसान है। सर आप पूछो। नहीं जी नहीं, कुछ देखो इसमें कुछ बना हुआ है ऊपर, कुछ ऊपर बना हुआ है इसमें। नहीं वो तो बहुत बड़ा होता है, ये तो माइक्रो वाला है। ये देखो ये है कैपिलरी हेमेंजियोमा, वो तो बहुत बड़ा होता है। ठीक है जी अगला पूछते हैं। वो दिख तो रहा है पर ये डायग्नोसिस ये है इसका। देखो जिसने ये लिखा है उसी को मिलेगा। ये पेंटाकैम बताओ। हाथ नहीं खड़ा कोई। पोस्ट हाइपरोपिक तो नहीं है, आप मिलते जुलते हो, आप कुछ और बोल दोगे तो मिल जाएगा आपको। ये देखो क्यू वैल्यू देखो पॉजिटिव में आ रही है। यस क्यू वैल्यू पॉजिटिव में है तो, और हाइपरओपिंग में तो बीच में मोटा हो जाएगा, बीच में पतला हो रहा है। एब्सोल्युटली राइट, एब्सोल्युटली राइट। लास्ट, बस लास्ट पूछ लेते हैं, फिर ये बता दो जी। आशीष तू खड़ा रहे यार, तेरा सवाल है ये।
Absolutely right. This is VKH, Vogt-Konage-Harada syndrome, which we have multiple PEDs in the center, and we move on to our final round, the rapid fire round. And Dr. Midda, please, you have to.
So the top 3 teams are, the first team is Dr. Gaurav Gupta, Dr. Gaurav Mangla. आ जाओ, आगे आ जाओ। Top team, big round of applause. Dr. Gaurav Gupta, Dr. Gaurav Mangla. They have got 13 marks. They have got 13 marks and they are carrying their score with them. ठीक है जी? उसके बाद 2 टीमें हैं, दोनों टाइड हैं। एक है जी मानसी एंड युविका एंड मानसी। डॉक्टर युविका, डॉक्टर मानसी, आ जाओ। 9 नंबर, यू आर कैरिंग योर मार्क्स विद यू। बिग राउंड ऑफ अप्लॉज, बिग राउंड ऑफ अप्लॉज। उसके बाद है जी डॉक्टर आकाश एंड डॉक्टर प्रखर। डॉक्टर प्रखर, 9 marks, please come. You are carrying your marks with you. And now Dr. Ashish with the rules for the rapid fire.
So we have the rapid fire round wherein we are going to ask 3 questions per team in 50 seconds. Dr. Rajan, your time is very important now. 50 seconds for 3 questions. So please put on your timer. +10 for the right and -5 for the wrong.
और आपको स्कोर भी करना होगा। आप कागज ले लो, कागज इसके पीछे भी कर सकते हैं। चलो ये आ जाओ, सब लोग आ जाओ, फोटो भी खींचनी है। आ जाओ आ जाओ, फोटो फोटो आ जाओ।
फर्स्ट टीम फर्स्ट। नहीं ये फर्स्ट वाला ही है।
कौन सी टीम है?
Yes, Dr. I.M.
Thank you. Now the runners up, please.
Dr. Gaurav.
आशीष,
इधर से आओ भाई, आशीष इधर से आ जाओ।
फोटोग्राफी प्राइज
डॉक्टर युविका फॉर
फोटो प्राइज
डॉक्टर युविका
इतना धक्का लगा
थैंक यू जी, थैंक यू फॉर प्लेइंग विद वी आर सो ग्लैड दैट यू गॉट इट। तालियां एक बार, तालियां। थैंक यू जी, थैंक यू सर। ग्रुप फोटो करा लेते हैं फटाफट। आ जाओ, जो भी लोग सब लोग आ जाओ, सभी लोग आ जाओ।
Sir, one thing we have completed in time. We have started at 9 a.m. sharp and we have completed at 5:45 a.m. exact. Exact 5:45 p.m. No one.
पीछे स्टेज पे चढ़ जाओ जी, कुछ स्टेज पे चढ़ जाएंगे।
अरे आ जाओ यार, सब लोग आ जाओ।
हाँ ठीक है। यस डॉक्टर आ जाओ, डॉक्टर करने का आ जाओ। आ जाओ भैया, ऊपर आ जाओ।
लंबा खींचा नहीं, जिसने खींचा गड्डियां बजा दी। वो भी अमित अरोड़ा के लिए।
वेट सर। डॉक्टर साहब आप आगे आ जाओ, इधर आ जाओ, बिल्कुल सिरे पे।
सिरे के ही हो।
नहीं
Thank you. Wonderful.
Thank you.
चलो टेरेस पे चले। हाँ सब करवा लो। टेरेस पे चलना है। टेरेस खाली करो। हल्दी होनी है। डॉक्टर प्रशांत सर, हमें मोमेंटो रसोई आ जा भाई, हमारे कोई मोमेंटो दे दो यार।
आशीष
अगर वो बाद में देता कोई बात नहीं, नाम वाले कराए। अरे बात सुन राजन यार, हमारे को मोमेंटो नहीं दिया। मोमेंटो गोल्ड सिल्वर भी हमारा असली वाला।
वही बना
क्या यार कैमरा नहीं करता क्यों गुरुदेव भैया